So we are live now.
Good afternoon, everyone, and welcome to this first scientific session in the Hall B of this wonderful conference. This absolutely new concept and a great beginning that we are having in India. This is the World Conference, and so many thousands of people have joined us, not only from India, but abroad. And we are going to have some wonderful, diverse, and interesting topics, a discussion on them, and lectures delivered by our honorable guest faculties. So, to begin the the first session, I would request and invite our chairpersons, Dr. Ashish Dhingra. He's a good friend and he's a renowned diabetologist and endocrinologist from Jabalpur. And Dr. Saurabh Srivastav from Noida. He's also a renowned diabetologist and endocrinologist to chair the session and introduce our speakers and take the session forward.
Thank you, Rajesh, for your kind introduction. And moving on to the India's first D-TechCon, which is the innovative conference which is organized by Bansi Sir and his team. And I invite our friend Dr. Mithun Bhartiya for the interesting talk which will be heard in the few minutes. He's MRCP UK and MRCGP UK, MRCP UK, Founder Secretary of Association of Clinical Endocrinologists, CCT Diabetes and Endocrinology UK. He has done MBBS, MRCGP, MRCP from UK and FE CSM Amsterdam. And he was in Mayo Clinic USA. FE CSM was done from Amsterdam, and he has received the Newman Prize for his work in 2013 on diabetes, testosterone, and erectile dysfunction. And he represents India at the Worldwide AGP Clinical Academy. He is a national and international faculty and National RSSDI Technology Task Force member. And we all know him. He's a very good orator. Over to you, Mithun.
Thank you, Ashish. Thank you, chairpersons. And thank you, D-TechCon. I think it gives me great pleasure. I'll just get my slides up. So first of all, is my slide visible and moving?
Yeah.
Yes.
Okay, fine. So the topic that I have been given is technology advancements in erectile dysfunction or sexual dysfunction. I think the biggest advancement in sexual dysfunction diabetes that we have started discussing about it in meetings. I think this, if you ask me what is the biggest advancement, that is the first universal step that has happened to acknowledge that the problem exists. You can only fix a problem if you are aware that the problem exists. And I remember when I had come from, the way I had gone down to start sexual dysfunction in England was I was doing my endocrine training and patients had come for problems with their sexual life. And my professor sent me to a sexologist, says, uske paas bhej do, kya karega, nahi karega, aafat hamare sar se chali jayegi. So with that, inquisitiveness is the mother of creation. And that is how I embarked on a journey of sexual dysfunction with the person, Dr. Hackett, who I always acknowledge as my guru, who started my training in it. And it has evolved. Things have evolved to the point of understanding where we are. Because when I started my practice in India, I think there were only a few people in diabetes who actually do diabetes and sexual dysfunction. And I was actually said, "Bhai, tum kya karoge? Tum to PD5 inhibitor doge, wo to hum bhi de denge. Why should we refer the patient to you? Wo to hum bhi dete hain. What is the big thing?" So I'm going to start the story from there, use some recent advancements and what is there in the future in this talk. Now, we all talk about PD5 inhibitors that have been there. So what is the newest invention in PD5 that has been there? See, PD5 can be broadly classified into short-acting and long-acting, or the weekender tablet, which is tadalafil. For tadalafil, it works in your body for 48 hours. And, sildenafil takes around half an hour. So you have to take the tablet and wait for half an hour. And that has always been the biggest criticism. Plus, it is non-specific to PD5. So people get a lot of flushing headache with sildenafil and other medications. So the newest addition to the block, which has been started in India in the last 1 or 2 years, is avanafil. Now, the beauty of avanafil is that the onset of action is around 15 to 30 minutes. So you can take it as early as 15 minutes before sexual activity. Now, in India, even though we are the land of Kama Sutra, foreplay is actually not given much of importance. I think 15 minutes is kind of the right tick box for everybody to actually have the onset and have a good mechanistic action. And the advantage of this is that it is more potent on the PD5 than on any other phosphodiesterase inhibitors. So these are the two unique advantages with this molecule, which is the next gen or the recent addition to the PD5 inhibitors that are there in the market. Obviously, you need to know, not to use it in end-stage renal and hepatic impairment, severe hepatic impairment. But the point I was trying to make is that we have now far more specific PD5, the technology advancement in PD5, than generic that we used to use. Now, however, with PD5, there's always been some kind of a criticism. See, boss, sex is spontaneous. You cannot plan sex. You can, but it's very difficult to plan sex. And a lot of patients do not respond to PD5 inhibitors, and they do not get unsatisfactory hardness. And with passage of time, either they develop some resistance to it, and there's a dropout, and they keep increasing the dose. So people want spontaneous sex. So what is the next step that can be done for that? And this was the newer technology advancement that happened, is the addition of shockwave therapy to sexual dysfunction. Now, what are shockwaves? Shockwaves are impulse of acoustic energy propagating with supersonic speed in the liquid or gas. It's a natural phenomena. As you can see, a steep rise of positive peak pressure and short duration, which is there. Velocity is around 1500 meters per second in water. And this has shown to have some improvement in erectile dysfunction. Now, the whole logic that it works, shockwaves work, it has been used in various things, which will come in the next slide. And it causes neovascularization and developing new collaterals, or reducing, I think some new theory has come, it works in reducing peripheral resistance to the blood flow that has been there. Now, it's not something that is new. It's not something shockwave I'm saying which is not existed, suddenly it was discovered. It has been there for lithotripsy. When we do lithotripsy, we use shockwave applications, and it's been used in orthopedics for injuries, in cardiology, and that has got into erectile dysfunction that are there. Now, how does this, the landmark paper that came with this was the extracorporeal shockwave therapy, which markedly ameliorates ischemia-induced myocardial dysfunction in pigs in vivo. So this was a landmark study which was published in Circulation in AHA, which actually was the start of the events of considering shockwave in treatment of that. Now, how does shockwave actually work? Shockwave causes shear stress, which increases intracellular and extracellular response, stimulates endothelial cells, nitric oxide synthesis released from vascular endothelium, growth factors, causes proliferation, nuclear antigen production, and some neovascularization. For each of these, there are a lot of data that has been there, which suggests how it works. So cavernous cell tissue responses to shock therapy. It activates nerve repair. It restores normal endothelial signaling. It recruits immune cells, initiates wound healing, recruits stem cells, and activates resident stem cells. Now, there are numerous machines that are available. The ED1000 was the first machine to come in the market. And there are various machines that are now available in the world which uses this. This could be the Duolith, the Aries, the Renova, and the PiezoWave 2. In the initial ones were focused on electrohydraulic, and the newer ones are electromagnetic. It's very difficult to say which is superior, which is not, whether electrohydraulic is, there's more data with the electrohydraulic, but this is not that the generation has evolved, iPhone 5, 6, 7, 8, 9, 10. It's just two different ways of looking at the same concept that exist. Now, this was all started by, the first study by a very good friend of mine, Vardi et al. And what he showed, and I was in European Society of Sexual Medicine meeting long ago when this paper was presented. We trained together in Oxford. And they do 6 sessions in 3 weeks with a 3 weeks gap and a 6 sessions in 3 weeks. The 300 SW is given per each side, 2 at the crura, 1 at the tip, 1 at the medium, on the base, not on the foreskin or the glands. And the next time when the patient comes in the next session, it's given on the other side of the penis or the corpus cavernosum that is there. So alternate sides that are there, 300 shots per side, so around 1500. It's not a painful process. People may feel the sensation, the pressure sensation that exists. I've used it for a long time and over the years. The other, you need to use a little bit of jelly to reduce the discomfort that the patient might feel. There are no side effects that the patient might have. It is not 100% guaranteed solution. What it might do is reduce the severity of erectile dysfunction and help the non-responders to PD5 convert into responders, or improve the grade of the erection. But it is not a magical cure. And I think that perspective has to be kept in mind when we are actually advising patients for it. As a rough guide with the data, it says 50%, it works in 50% of patients. But, I think over the time I've found that the percentage of patients that it works may be a little lower. So one has to tease the vascular path in the erectile dysfunction that is there. Somebody who's an arteriopath, somebody who's got high blood pressure, somebody who's got coronary artery disease, somebody who's got blood cholesterol raised, it is more better chances of them responding to this LSWT therapy than a psychogenic erectile dysfunction that might exist with patients. So it's important to tease out that, because we are much aware that erectile dysfunction may persist 3 to 4 years before a myocardial infarction, purely of the diameter of the penile artery, which is 1 mm, as compared to the diameter of the artery of the heart or the femoral artery, which is 2 to 3 mm. The smaller the diameter, and it has been shown that the 50% obstruction of the lumen will precipitate in the symptoms. So it has been very much shown that ED comes much earlier of myocardial infarction in patients that are there. Now, this is how to use LSWT. Now, what are the tools to assess that are there? We have the IEF scores. People use penile Dopplers, and I would take the occasion to say that penile Dopplers are not very useful. Please don't use them. Please don't waste your money. Use them. They are the results are inconsistent despite having an improvement in IEF that is there. So I would never recommend wastage of patients' money to do Doppler studies for erectile dysfunction. I've done it, as you said, I've spent a good amount of 10 years or 12 years in this line. So I can tell that I don't use any Doppler studies. Clinical evaluation followed by investigation and treatment is much better than wasting the money, because the expectation, sometimes I often find people writing arteriogenic ED or venogenic ED, and it gives a negative feedback to the patient, because very often I said I have patients who've got brilliant erections improvement, but the Doppler has not shown significant improvement. It doesn't matter what you can see in front of your eyes. A picture will say 1,000 words than a numerical value or the study. The patient can feel the difference. Patient's happy and satisfied, and yet sometimes the Doppler does not show this. Now let's move on to something which is vascular functions. You see the artery, the diameter of the artery, as I said, of the penile artery is very small. And the normal artery of a normal person is like silk, nothing sticks to it, nothing passes to it. Whereas the diabetic artery is very much like Velcro, it's very, very sticky. So an endothelial damage is very much there. And in the vascular function plays a vital role in the vascular tone and the blood flow regulation. So if we could assess this function, it might be a more practical way of measuring endothelial function that are there. Now the speed, let's go to some physics, which I've forgotten in a long time. Speed of the wave is related to the stiffness of the artery it is traveling. So stiffer the artery, the higher the wave speed. And so the wave speed is proportionate to the square root of the arterial thickness that are there. Hence, if we can assess the pulse wave velocity of larger arteries, it might be an index of arterial stiffness and allow us to consider treatment which work on the arteriogenic erectile dysfunction, which can be there, and help recognize as an early risk factor for a lot of patients. Because as we know that diabetic patients are a ticking time bomb for cardiovascular disease. We can use Pigmofor system for measuring central blood pressures. These are the newer technology, or we can use brachial artery ultrasound with endothelial dependent flow mediated vasodilation loop. So this is how we could assess it. Now, what are the newer techniques that are in the pipeline that are there? They are platelet-rich growth factors which can modify endothelium. So concentrated plasma consider many such growth factors. And platelet-rich plasma, PRP therapy, which you can see, you give to people who've got hair loss, And that has also shown that with the interaction with the surrounding cells and intracellular matrix and mediator, the site of injection leads. This may show improvement because there are a lot of growth factors associated with platelet-rich plasma, which can improve the erectile dysfunction. And the regeneration effect continues across 7 days of life of platelets, and it stimulates cellular proliferation and tissue regeneration of the endothelium. The other new thing that a lot of work has been done is stem cell therapy for erectile dysfunction. And this is work in progress. And cells have been derived from multiple tissues with varied potential and may function via local engraftment or paracrine sealing. So we have stem cell mechanism of action, we have PRP mechanism for action. And I think what is going to happen with passage of time, that ED would become the window to look at the cardiovascular profile of the patient in terms of deciding a lot of therapy that is going to happen. Because very often we say, yes, we have got studies with patients with cardiovascular disease, but we know there's an underlying population with undiagnosed cardiovascular disease. And this is erectile dysfunction with newer ways of finding out the arterial stiffness, with the newer ways of treating the arteriogenic ED. I'm sure ED would become a forefront in the discussion that is going to come in the coming years. With that, I'm just going to say the change that has happened with the pre and the post Viagra era. It was erectile dysfunction is post-pill era is organic in most patients unless proven otherwise, which is over 40. This is a historical fact. And things have evolved to look at ED in a vascular, neurocentral, peripheral, visual, tactile formation to understand the molecular physiology. And once we can assess the endothelial dysfunction, we can give better service to our patients to lead a definite and a more productive sexual life. With that, I would end my talk. Thank you so much, which is there. These are the conclusions which we had. Thank you so much. And thank you, Rakesh, again, for twisting my arm for getting me to talk on this topic. Thank you so much.
Thank you, Nitin, for wonderful new things which you have discussed today here, and you have opened the minds for future therapy, as this is a technology future conference. Over to you, Saurabh.
It was a wonderful talk by Dr. Nitin, and as we have discussions in the end, so I just invite Dr. S.R. Arvind for the next talk, and the next talk is on artificial intelligence in diagnosing diabetic retinopathy. And Dr. S.R. Arvind is not a new name, we all are familiar with him. He is Director and Chief Diabetologist of D-TechCon Hospital, Bangalore, India. He is Course Director, PG Studies of Health University, RUGS and RSSDI. He is President RSDI from 2015 and 16. He is President Diabetes India and has over 100 papers and conducted 100 phase 2 and 3 clinical trials. So over to you, Dr. Arvind, for your presentation. Artificial intelligence in diagnosing diabetic retinopathy.
Thank you, Saurabh. Just somebody to tell me that you can hear me, and then
yes, sir. Yes, sir. You are audible.
You can see my this one. So with that, I'll be sharing my screen. Just let me know if you can see the screen well.
Yes, sir. Screen is visible.
Okay. Thank you so very much. I think I'll be concentrating basically on an important part about diagnosis of diabetic retinopathy, especially using the fundus on phone and the artificial intelligence, which is actually a gift from our own country. And of course, these are my disclosures. See, it's important to remember that eyes are the windows to vascular health. Comprehensive treatment has taken so much of our efforts, but sometimes as physicians, diabetologists, and endocrinologists, we are not really completing our comprehensive care because we fail to actually evaluate the diabetic retinopathy, which is the most important microvascular disease, because once you diagnose diabetic retinopathy, you know that it's the first step, and then your focus automatically goes on the liver. Well, I love dogs, and this is a beautiful photograph, but blindness certainly is not the way that we should actually see our patients at any time. And this is exactly what's been happening with 77 million people in India. 1 in 3 have diabetic retinopathy, and 1 in 10 actually have a vision-threatening diabetic retinopathy. Now, if you look at the data from IADP, this was actually way back in 2010, 2012. It's about 45 million people have vision-threatening diabetic retinopathy. We don't have the full data from India, but it's safe to say that 30% of our individuals with diabetes have diabetic retinopathy. Well, we have been never trained during our MBBS days, and all MS ophthalmologists are also not really trained because the retina specialization has come after you complete your MS in ophthalmology. What we have been doing as physicians is, of course, to refer patients for a dilated fundus examination by an ophthalmologist, or we have been taking retinal photograph and sending it to our colleagues for a teleophthalmology consultation. See, there have been a number of challenges in this because access to a retina specialist is still less in smaller cities. You will have ophthalmologists, and trust me, all are not trained. And you need to travel to a different hospital. So that brings in the time and the cost. When once the pupils are dilated, you have blurring of vision, so you can't drive back. So many of the patients will not go. And teleophthalmology showed a lot of promise in the rest of the world, but unfortunately, there is a tremendous amount of integrative variability and delay, which has actually made this possibility not very suitable, especially for a disease like diabetes. In fact, more than 70% of our patients are not just screened because they have to travel to the ophthalmologist. Now, the second important thing is it's so asymptomatic. Even sight-threatening diabetic retinopathy is so asymptomatic, your patient will not take you so very seriously because he thinks, oh, well, it's just a check for my glasses, so he may not actually go. Now, the question is actually who should now screen? In a country like India, we have approximately 1,000 or maybe 1,500 retina vitreous specialists. That's it. And this is the data from the Indian Ophthalmology Society. You have fellowships in medical retina after your MS, and you hardly have 2,000 to 3,000 medical retina specialists. I mean, this is the truth. So everyone with an MS ophthalmology degree is not a retina specialist and can make very, very bad mistakes. So when it comes to teleophthalmology, the big question that we have to ask is, how reliable is the reporting itself? I will not go into too much of details because about 5 to 6 years back when we started working on artificial intelligence and trying to perfect it, we looked at all the possibilities, and there's a tremendous amount of inter-observer difference, and these are some of the papers. And we ourselves looked into the differences that can come when 5 very senior retina specialists are asked to grade the fundus images, which is blinded to each other. And it's what is known as a kappa score. And even for severe NPDR, the kappa score is as low as 0.32. You get a kappa score of more than 0.6, I think there is a fair amount of agreeability among the people who are grading it. And this is a part of the SMART study which got published later. Now, even when we wanted them to grade DME, which range from mild DME to moderate DME to severe DME, in fact, the kappa score was only 0.4. Okay, and even the best of the retina specialists obviously know that when you are looking at an image, it's very, very difficult to actually pick up diabetic macular edema. It's not all that simple. And this is something that we have to now share with all our colleagues. Well, there are reasons for this, okay, because we don't have dedicated centers in India. Some big hospitals have their own branches and their own units, and their doctors are well trained, like Dr. Mohan's place can afford to do this because it's well-trained staff. And there is no training to ophthalmologists who are not retina specialists because this is at least a 1-year fellowship. And for most ophthalmologists, it is not the mainstream of work. So they would not really concentrate on something which does not have a surgical implication at a later time. And then there are things like the experience, the doctor fatigue, the image quality, the pixel size, the reader screen type, internet issues, a number of other things. You know, when you send an image on a WhatsApp, usually, in fact, the quality of the image itself comes down by 10 to 20%. And it depends on what type of a screen you're using to actually see the image, which camera has actually captured the image. And there are so many other things. I'll not go into the details. Now, the question then is, if the physician does not screen for DL, then the patient will actually go blind. Now, we have to find solution. The cost-effective fundus camera, it's just like an ECG machine. Every physician has an ECG machine today. And a cost-effective fundus camera and artificial intelligence, I think, is the solution for DR screening worldwide and not just in India, because this is a problem that's going to be faced by every doctor, every physician worldwide. I think this is the answer. And artificial intelligence is so good with retinal imaging. I'll be talking about the Medio's artificial intelligence and where they stand today, etc. You'll be amazed at the sensitivity and the specificity that this particular artificial intelligence is giving in terms of referable DR versus no referable DR. So we must understand there are two types of artificial intelligence used, and one can be cloud-based and other can be offline, which is on a smartphone and in the camera itself. Now, the cloud-based one, you need expensive cameras, you need electricity, you need internet, and then the images are captured and your AI is cloud-based, and then you get a report probably in about 4 to 5 minutes. Well, it's a very, very expensive alternative. Now, the simple alternative is if you have an offline fundus on phone, which is very inexpensive, you have artificial intelligence support, and it does not require an internet connection. It does not need electricity. The camera cost is roughly below 3.5 lakhs, so everybody should be able to afford it. It may go down further in the number of years. And the reports are generated in less than 15 seconds. And this is very ideal for screening in developing countries, and also take it to a number of your camps. And what is the accuracy level that the FDA is looking for? A sensitivity of 85% and a specificity of about 82%. And these are some of the cloud-based AI algorithms that we have. In fact, the iArt and IDX are the only two cloud-based AI algorithms which are now FDA approved. And this again is not being used in India because it is very expensive, and they have been tested against very high-end cameras, and they have not been tested against the inexpensive cameras that we have been going to talk about. So the question is, the cloud-based AI algorithm suited to all? Definitely no. The cost, the convenience, the need for internet training of the personnel, delayed reports. These are the reasons why we say that this is not going to be the solution. So the Medios from Singapore have come out with this offline AI revolution. It's the automatic detection of diabetic retinopathy. It's fitted on the phone of the Remedio, which is actually manufactured in Bangalore and India. And this particular fundus on phone is FDA approved and costs less than 3.5 lakhs. And when once your artificial intelligence is already embedded onto the system, the processing and the reporting time is less than 15 seconds. And on the right side, you can see the analysis with a confidence level of 92 to 99%. It looks at the image quality and the confidence level of the DR. Now, whenever somebody comes out, you need to actually see how exactly this is going to work and how exactly you're going to do the validation. Now, this is where we came into the picture because we were actually asked to validate this. So we did 2 studies. In fact, the SMART study, which looked at 922 patients, non-mydriatic images, we took 2 images per eye. And the SMART study 2, which had 304 patients, mydriatic images. And on top, you have the 3 images, and on the bottom, you have the 2 images. Now, what we did was we had different retina specialists blinded. The diagnosis also was taken from the AI, and it was compared with that of the retina specialist. So the AI could give us 3 types of diagnosis. One was referable DR, or all DR, or a sight-threatening diabetic retinopathy. And this is exactly what we found when it came to the referable DR. The sensitivity was about 98.4%, and for sight-threatening diabetic retinopathy, it was 100%. In fact, this paper was published at the Indian Journal of Ophthalmology. It was presented at ATTD and several other conferences. Then we also did the other smart study, where this was the largest, in fact, 922 patients using the same Medios AI and the FOP of Remedio. And this is the largest so far, and this was published in the BMJ Open Diabetes and Research. And in this particular study, it was non-mydriatic, which is quite tough among Indians because your pupil size is less than 3. We were still able to get it, and the sensitivity was 93%, and the sight-threatening DR was 98%. It far exceeds the FDA cutoff of both sensitivity and specificity. Now, we have the good results. Now, can we use it in a real world? At that time, in fact, Professor Natarajan from Mumbai was the president of the Ophthalmology Society of India, and he wanted to see whether a layman can be tried. And he tried using this camera and the AI actually to screen for diabetic retinopathy in a regular public population. He took it to the municipal council, and people were trained to actually take the fundus pictures, and they were able to get the diagnosis. And the sensitivity was 100% for good quality images, and specificity was 88%. And images of good quality and poor quality, when you mix both, for referable DR, surprisingly, it was 100%. And this again was published in JAMA Ophthalmology. So very clearly telling us that it can be used by anybody. And all that is required is about 30 minutes of training this particular people. And the study highlights from Dr. Natarajan's thing is deep learning and AI is here to assist us. The most important thing with the Remedio FOP and the AI from Medios is it works offline on an iPhone. Apple also came into the picture at this time, and they made sure that they can help the people who have actually built it with some of the modifications that was necessary on their iPhone. In fact, the sensitivity and the specificity of the Medios AI with both mydriatic and non-mydriatic images far exceeds the FDA mandated superiority. So at this point of time, it's awaiting the FDA's recognition. When once it happens, it will also be used freely in United States, and it's already available in the rest of the world, especially in Europe and other places. And it has also looked into the differences in performance, especially related to ethnicity, because when you look at the retinal pigmentation can change from ethnicity to ethnicity. So even this has been seen and found to be perfectly fine with this. And there were several companies which said we already have images from other desktop cameras. Now, can we use the AI for our images? And these are some of the work that has been done. In fact, it has also been presented. Now, what is going to be the future? I think the future is going to be to move into the binary diagnosis and to see whether the staging is possible, like mild, moderate, severe NPDR, and that work is already started. And the most important thing is to pick up glaucoma and age-related macular degeneration, which is very, very important in our population. And the future, of course, can we look at a retinal image and try to have a CV score with a lot of other data coming in. In fact, this was presented in AWO 2020, where the staging of no RDR, that means no referable diabetic retinopathy, it can also include some mild NPDRs. And RDR means a moderate NPDR to severe NPDR to PDR, and a sight-threatening diabetic retinopathy actually includes severe NPDR and PDR. Now, at this point of time, what I would like to say is, this is not going to replace an ophthalmologist, but it will help a physician to make a quick diagnosis and then probably to refer the case to the ophthalmologist. When the AI says it's moderate or severe, this is a referable DR. Now you don't hang on to the patient. Please ask the patient to see a retinologist. I think this is where it is going to come into the picture. And even with the binary classification, the sensitivity specificity is extremely good, far exceeds the FDA. And with glaucoma, we are pleasantly surprised. This is the work that has been going on to actually pick up the glaucoma reports in less than 10 seconds. These are some of the validation work that has been done with respect to the glaucoma. So I've just listed a number of conferences and number of publications that have already come out with respect to the Remedio FOP and the Medios AI, and the work actually continues. Well, the screening algorithms will definitely make retinopathy screening very accessible and affordable, because as physicians, we have been able to do everything else, but we are not completing our comprehensive care because we never really had an instrument like this. And the early detection and treatment can definitely prevent blindness. Well, so far, all the physicians and others have not taken it up. Well, we still live in a world that does not really exist. I think we have to now move and take on the responsibility and lessen the burden of the ophthalmologist. And I really request you all to join us in changing, because this is something made in India, extremely inexpensive, and giving us specificity, sensitivity, which far exceeds that of any other AI, which is also available or recommended by FDA in the world. So I would like to thank all my collaborators from Retina Institute of Karnataka, and a special thanks to Dr. Mohan and his team from this one, and Dr. Banshi and Jyoti Dev, many others who also actually helped us while we were evaluating it. And the evaluation continues, more work has started. I'm sure we'll be able to share more data about how AI is moving into the binary diagnosis and other areas. Thank you so very much. I think with that, I will stop my talk. And if there are any questions, I'll be happy to take the questions.
Thank you, Dr. Arvind, for a wonderful presentation and giving an idea about how diabetic retinopathy can be screened at community level also. And now we are for the third talk, Dr. Ashish.
Yeah, so moving on to the third talk in this important D-Tech conference. We are having our renowned Dr. Vijay Vishwanathan, sir. Welcome you, sir, for the next talk. His present position is Head and Chief Diabetologist, MB Hospital for Diabetes, and Professor M. Vishwanath, Diabetes Research Center, Chennai. He is MD, PhD, FRCP, London and Glasgow, WHO Collaborating Center for Research, Education and Training in Diabetes. He is President-elect from 2021 to 23 for Diabetic Foot International, based in Belgium and consisting of experts from 193 countries. It is a proud honor for us. National Vice President, RSSDI, completed 29 years as a diabetologist, PhD in diabetic nephropathy, and published 50 research papers in this field. First Vivian Fonsier Award from the American Diabetic Association for work in diabetes and tuberculosis in 2013. And he has developed a specialty of diabetic foot care in India by training over 2,000 physicians in the prevention of amputation, setting up a state-of-art podiatry center in Chennai since 25 years, and publishing 150 original research papers in diabetic foot. He has been awarded Fellowship of the Royal College of Physicians, London, for research contribution in diabetes. The field of interest is foot and diabetes, kidney and diabetes, diabetes in patients with TB, and socioeconomic diabetes. So I welcome the renowned Dr. Vijay Vishwanathan, sir. Over to you, sir, for your next talk.
Yeah, thank you, Dr. Ashish and Dr. Saurabh. I'll take only 12 minutes to finish my talk, but it's a very interesting talk. And let me share the slides. Yeah. So I'm going to talk to you on a new technology which we have used in Chennai for the early diagnosis of diabetic foot. So yeah, so now it's in full screen. So I'll take 10 minutes to take you through this new technology. First of all, we should know this point that as diabetologists, we have this classification, simple classification from our colleagues in King's College London, who talked about stage 1 when you have normal foot with a normal sensation, no peripheral arterial disease, deformity, and so on. Stage 2 is where the diabetologists are involved. Stage 3 is where, and stage 4 and 5 are where the physician has to call a surgeon, and the surgeon is involved. So this is for the diabetologist and this is for the surgeon. So today's talk is mostly going to be on stage 3, 4, and 5. And the next 11 minutes, I'll talk to you on this new technology. First of all, we should understand that in people with diabetes in India, the main reason for diabetic foot amputation is infection. This was a study which we published way back in 2005 in Diabetic Medicine, where we compared 3 populations, Germany, Africa, and India, and we found that the main reason for amputation in the developing world was progressive infection among the people with the diabetic foot. It's a noise there. So progressive infection is the main cause for amputation. Now, why should we prevent amputation? Why should we have new technology? So this was a study which we published in JAPI in 2013. And if you have people with diabetes who undergo recurrent amputations, minor or major, and compare them to people with diabetes who do not have complications, you find that people who undergo frequent amputations spend about 4 times more money than people who do not have any foot infection or amputation. So now I move on to my talk. This was one of our patients who came during lockdown, and this is not the ideal time to show this. An infected foot with a lot of maggots, and these are dirty maggots because of infection. And when you clean the maggots, you'll get an infected wound. You clean the wound and you get a good wound, and then you do a skin graft and you save the foot. In the next 10 minutes, I'm going to talk about a new technology which is called autofluorescence imaging of the diabetic foot ulcers. And this is using a novel artificial intelligence enabled non-invasive device. So this paper was published in the International Journal of Lower Extremity Wounds, IGLEW. And this is for the first time. When you get a person coming with a foot infection like this, you do not know whether it's gram-positive, gram-negative organisms which are present in the wound. We give empiric antibiotic and we do a culture and then we wait for the report. So this was a new technology which we used, which will hasten the wound healing and also improve wound closure rate. The technology is an autofluorescence-based multispectral imaging, and this has been tried out in some countries like the United States, and we used it in India, and it's a useful technique for the identification of bacteria, and it involves, what does it involve? It involves shining multiple wavelengths of light on the wound. So you just shine multiple wavelengths of light on the wounds and collect their emission responses. It will help you to understand, therefore, the pathophysiology and the bacterial colonization which is happening. It's a novel point-of-care device, which, as I told you before, is a multispectral autofluorescence imaging, which helps in rapid identification and classification of bacteria, which is growing in the foot. The study which we published in IGLEW was aimed to evaluate the diagnostic accuracy of this device in detecting the bacterial gram type against the standard culture methods. This device was developed combining multiple light source. You can see so many nanometers to shine the wound, and it collects multispectral images in approximately 30 seconds to detect infection on the wound. There is an image processing algorithm which is available in the camera, which I'm going to show you, which analyzes the spectral images, and a pre-term trained machine learning algorithm will then compare the relative intensity between the different autofluorescence biomarkers, thus enabling classification of bacteria into gram-positive and gram-negative in just 2 minutes' time. It's non-contact, it does not require the addition of any reagents, and it removes a burden of interpreting spectral images. The artificial intelligence engine runs on the development and can be used even in remote places with no internet access. It's just a camera, and it provides a comprehensive report along with the automated wound measurement. It also measures the wound and also gives you the type of bacteria which is growing on the wound. It's easy to use and requires training to image the wounds consistently. It requires some amount of training. So this is a device, this is a camera, which we have been using for the last 2 years in our hospital in Chennai. It's used to collect multispectral wound images. This is a camera, and you need a dark room, or you can use a black hood covering the wound area. You have to train the investigator how to take the images, but once he or she, a nurse, is trained, he or she can take the photographs very easily. Before imaging, the wounds must be cleaned with normal saline, and then you enter the details into the imaging application. And the user was, in the study, was guided to image the wound at a distance of 10 to 12 centimeters from the area of interest. And in about 20 seconds, you can get about 16 multispectral images. Now, if you have a green color, which is shown on the wound, it means it's a gram-negative infection. And if you have a red color, as you see here, it means you have a gram-positive bacterial infection. So you can change your antibiotic when the patient comes in according to the color which you get. So gram-negative is green and gram-positive bacteria is red. In this study, we had about 178 patients who were studied, and the mean age was shown here, and most of them were men. And the duration of diabetes, most of them had a duration of 11 to 15, and most of them had bad wounds. We used the University of Texas classification, and most of them had bad wounds. Most of them had uncontrolled diabetes, and most of them were not on antibiotics before the images were taken. And these were the isolates from the wound by culture. Now, this is an important slide. We compared the culture. We did the culture on deep tissue during the operation theater. We took a culture and we compared it with the photograph taken from the camera. And you can see that among these 178 patients, we had about 203 cultures taken, and the correct diagnosis was in about 168. In 35, it was misdiagnosed. Therefore, it was a close correlation between the culture method and the novel imaging method which we used. Now, this shows you the positive predictive value and the negative predictive value, if it's gram-negative or gram-positive, and no growth also. The accuracy was quite good, and if the person did not have any growth of any bacteria, the accuracy was much more. And even if it was gram-positive or negative, it was a good 86%. The conclusions of that study was that the accuracy of the device was found to be about 89%, with a positive predictive value of 80.8 for detecting gram-negative bacteria and 86.3 for detecting gram-positive bacteria. The area under the curve of 0.86 showed a significantly discriminating ability of the device to the presence of pathogens. So there's a close correlation between no pathogens and pathogens by using this autofluorescence method. And there was a high sensitivity and specificity, which you can see here, which was shown on the study. Now I'll show you two examples of how it could be used in clinical practice. So this is not from the study, but this is from our experience after the study was published. This is a patient with necrotizing fasciitis involving the right foot and leg. There's infection here. You can see that it's mostly gram-negative bacteria, which is seen before the debridement. We did the first debridement, and the infection was opened up and the bacteria was cleaned. But you can see that even after the second debridement, there is still a growth of the gram-negative bacteria. And the patient has to go for a second debridement. You can see the first debridement was till here, but your second debridement is much more extensive. So the surgeon can decide the number of debridements depending on this camera. For your naked eye, you cannot see the bacteria. And once you start the antibiotics, you cannot keep doing cultures over and over again. Therefore, this camera will help the surgeon to decide whether more and more debridements are necessary. You can see that this is another picture of another patient. You can see the infection has both gram-positive and gram-negative. You have a combination of both infections in this wound. This was before debridement. Now, in some patients, even after the fourth day of debridement, you can see there is still growth of the organisms, the gram-positive, gram-negative organisms. So this is after the fourth day of debridement. So you have to debride further. And it also gives you the measurement in length, width, and area. It's a camera after all, so you can get the width of the wound, the length of the wound, and also the area of the wound. This is another patient after the second debridement. You can see that you have to debride more if the camera shows that there is infection. So this was the picture after the debridement, the first debridement. But after the fourth day, it's still showing organisms, and you then debride the second time. Therefore, such technologies will certainly prevent amputations. But as Professor Andrew Bolton and his colleagues published in Lancet, I think the most important fact is that about 85% of all the amputations in diabetes is preventable. It's due to infection. And if you do a proper debridement and get rid of the infection and also treat the vascular problems, you can certainly save many of the limbs. We showed that simple foot care education in 2005 again. We showed in this paper in Diabetes Care that by educating the patient long enough, you can prevent an amputation. We can't fix a problem until we know and acknowledge it exists. If you diagnose a problem very early, if you diagnose a bacteria which is infecting the person's foot very early, if you do a vascular intervention very early, you can prevent a messy job later. If you detect the leak quite early, you can prevent a disaster later. I would like to thank all my research and clinical staff at the MB Hospital for Diabetes and Professor M. Vishwanathan Diabetes Research Center in Chennai for all the good work they do and for helping me to make this presentation this evening. Thank you for your attention.
Thank you, Vijay sir, for an excellent talk and the new thing which we have learned today. And it is a very much need of the hour to diagnose the patient properly and then treat them, which we are not doing because the culture report will come after 3 days or 7 days. Till that time, we are behind because the infection spreads like a fire in the diabetic patients I have seen in my hospital also. I am very much interested in diabetic foot patients. I am preventing the amputation in Jabalpur. No one was doing the diabetic foot practice here. But since 15 years we are doing here and we are saving so many amputations. And I hope this new gadget will help in the future to prevent more further amputations. Thanks a lot for your excellent talk, sir.
Thank you, Ashish.
Saurabh, any questions?
I think there are no questions in the chat box also. And
So I have one question, Vijay sir. How much the gadget costs, this instrument?
Well, this was developed by a company in Chennai, and you can have two options. You can either rent it out from them, in which case you pay them a fee for each patient. We are paying about 150 rupees for each patient, for each photograph you take.
So how much is the charge for per patient?
Per 150 rupees. You want to use, yeah. But if you want to buy the machine, the camera, they're charging some 3 lakhs. So right now we are only renting it out, and we're paying per patient to the company. It's a company in Chennai. It's
okay. I will contact you. Yeah, it is a great thing. So Mithun, I have one question that the shockwave therapy, is it available in India for the?
Yes, it is available. Ashish, I've been using it for the past 5-6 years now.
Okay.
But you have to carefully screen the patients because it is expensive. So a typical shockwave, they recommend 12 sessions. That would, burn down for the patient to be around 60 to 70,000 rupees. So the problem is patients' expectations are very high when they pay so much of money. It's directly proportionate to what kind of erection they want. So if they pay 60,000, they really want a really good response, which is not possible.
Like in obesity, we face a situation like I have faced in one of my patients that डॉक्टर साहब मैं गैस खरीदूं कि आपकी दवाई खरीदूं मोटापा कम करने की मैं तो पतली हो ही नहीं रही हूं so they blame us. So you have to be cautious in these things.
Yes, so I think you need to warn the patient because the machine itself costs around 30 lakhs. And there's a reflector which costs around 83,750. That is for 12 patients. So it is an expensive therapy.
So any questions for Arvind sir?
I think
Would you like to add some light?
No, I mean, I was actually listening to Vijay speaking about this. I think this is very fascinating because, even though we are told, in fact, trained under his father, that you always start off a gram positive, gram negative, both antibiotic to start off because you still need 72 hours before you get the report. Vijay, there can only be one thing, some of the bacteria, especially methicillin-resistant staph, those are the areas where MRSA is being picked up. I think that is where we can actually go wrong with this just gram-positive, gram-negative identification. Did you have a chance to see MRSAs when you actually did the culture and this going wrong there?
Yeah, I showed one slide. Maybe I didn't spend enough time on the slide. There were some 30 cases of MRSA out of 170. So it was not a very high prevalence. Like in the Western countries, we have very high prevalence of MRSA. In India, we don't find that much of a high prevalence of MRSA. So MRSA is there, but it will be categorized as gram-positive. And you still have to follow the guidelines of the IWGDF or the American Infectious Diseases Society and so on. You still have to follow that. This is just to help the physician, the surgeon, to decide about a second debridement, third debridement.
I think that was a very interesting point. You have already debrided and you're looking at an image which still shows that there is some infection. I think it tremendously should be helping the surgeons.
Yeah.
Dr. Arvind, can I ask a question?
Today, weather is hazy sunshine, 38.3 degrees.
Hello.
Carry on, Dr. Rajesh.
Sir, I want to ask you a question. My experience with these non-mediatric cameras has not been very good. I have Trinetra, and what we do is we take pictures and we send them over to the retina specialist. So earlier we were taking without dilation, but what later we've had different retina specialists all of them are of the view that, it is important to dilate the patients. What has been
I fully agree, Rajesh. Trinetra comes nowhere near Remedio's FOP, and it's not even FDA approved. And I think most of the people have given it up. And unfortunately, in India, what happened was there were some pharma companies which were buying and giving it to the doctors. I think you can stop using Trinetra. I'm sorry for saying this because the image quality is not good. Okay, now Remedio FOP has been compared with the best of the tabletop models, in fact, across the world. That's why it has got an FDA approval. I fully agree with mydriatic versus non-mydriatic because the pupil size among Indians sometimes is small. So if you are not getting a good quality image, because this FOP has an auto-click mechanism, so anybody who can just focus on the optic nerve or probably on the macula, it automatically takes the image. Suppose you find that the quality of the image is not good, then you can go ahead and dilate the eye and take it. And you may not get a non-mydriatic image in at least 20% of your patients, wherein you have to dilate and take the images. And the important thing is, for ophthalmologists, if you are using teleophthalmology, it depends on how you are sending the images. If you are sending WhatsApp images, please stop it because there is a drop of almost 10 to 20% on the quality of the image size. It can make up most of the DMEs. I think these are the few things, because this is what has been done for a number of years by the physicians who are not trained in ophthalmology. So I think this change over a period of time, we'll see a number of physicians using FDA-approved devices. And all that it costs for the AI is about 50 rupees. And it comes loaded with some 1,000 AI diagnoses with the camera. And after that, each image is about 50 rupees, which is very affordable by most of the patients.
What is the cost of this Remedio?
I think they're giving it under 3.5 lakhs now. And RSSDI definitely were a part of this deal. All RSSDI members were getting it at 3.5 or so. But one can actually talk to the Remedio people and try to reduce the price further.
Yes, because the Trinetra is considerably, it is almost twice.
I mean, Trinetra went into a lot of problems because most of their parts were imported. They were not really doing it here because this AI was tested against most of the Indian cameras available at that particular point of time. And somehow we had a lot of problems testing it with the other cameras.
Thank you, sir.
Even Bosch came out with a handheld device, which would give a lot of problems.
The only problem, Arvind sir, as you know, it wasn't very steady with the handheld.
It was very difficult to take it with the handheld thing. So the Bosch also stopped it. Technology looks simple, but when you actually do it, you get into all kinds of problems. Actually, I must thank Chennai because Anand Shivraman, who started Remedio, is actually originally from Chennai, and then he had to come to Bangalore because he got married to a Kannada-speaking girl. That was the influence to get them to Bangalore to start this. Vijay, you should also now. I mean, you can't now. It's too late.
I think the only thing that this session has given me the idea is that all the three sessions were related to microvasculature. So I'm going to call Vijay sir and Arvind sir offline after this. It's given me an idea to tie the three around suddenly, which is not, we don't have much data on that. So call offline. Suddenly realize that these are all three microvasculature.
Yeah.
Thank you.
Excellent talk by Dr. Arvind sir, Dr. Mithun, and Dr. Vijay Vishwanathan sir, as usual. Thank you, sir, for being here, sir.
Thank you.
Thank you.
Mithun, I enjoyed your talk.
Thank you, sir.
And
Thank you.
Arvind sir,
Great talk,
enjoyed
sir.
your talk.
Great talk.
Thank you so much, sir.
Mithun's talk is usually enjoyed. Thank you.
Thank you very much. Thank you. Very kind of you. Vijay sir, there's a new thing called hemoglobin spray that has come out for wound healing. You are on mute.
You are mute.
You are mute.
No, there are so many technologies, but I think you need randomized controlled trials because there are so many new honeys and everything, maggots being tried out. But I think we need randomized controlled trials to because ultimately debridement, vascular intervention, offloading is what is preached by everybody.
Offloading works like wonders, sir. It is one of the treatment part. Offloading is very important tool which we are missing because we don't teach the patients when they go home. I think so. Offloading is a very important tool.
This, if I can say, Ashish, I presented some work in RSSDI Endocrine Society in West Bengal last week, where we showed some gruesome vascular disease, where we corrected by angioplasty and saved the limbs. There was absolutely gangrene and black tissue, and we did angioplasties and saved the limbs. So vascular assessment and vascular intervention has become the order of the day. And offloading, of course, is very important. But I think it's very important vascular control is very important. And
Timely
intervention
is very important.
People are getting amputated because the surgeon is in a hurry to debride without looking at the vascularity. So we get a lot of patients who have gangrene because they're not even examined the posterior pulse or dorsalis pulse. They've just debrided. There's no hurry to debride. First, you have to establish vascularity and then only you should debride. That's what we do. But many surgeons are in such great hurry. They see pus, they immediately go in and debride. You should not debride until you're sure that your blood supply is adequate to the pedal arches. And if you don't get enough blood supply and you go and debride, it will become a dry wound with absolutely no blood flow. And
so prerequisites should be followed, which we are not following. That is, we have to see the vascularity, neuropathy, all the things first we have to deal, and then we should go for surgery. That is the message.
Yeah.
A simple question that in the 3-tier cities in which these facilities are not available, what antibiotic you will suggest to start to the physicians?
So we have this guidelines from the IWGDF by Benjamin Lipsky. So supposing you have a fresh infection, which is less than 2 weeks old, not yet exposed to antibiotics earlier, you cover only gram-positive. You give only gram-positive. But supposing it's a chronic wound, more than 2 weeks old, with a past history of exposure to several antibiotics, you have to cover gram-positive and negative. If you have a foul-smelling wound, then you should cover gram-positive, gram-negative, and anaerobic cover. So clindamycin is a good, it covers gram-positive and anaerobes, clindamycin. You can cover clindamycin with some gram-negative cover. So the guidelines are very well written by the IWGDF and IDSA, Infectious Diseases Society of America. We have 2 guidelines for antibiotics, empiric antibiotics. Ashish, does it answer your question?
Yeah. Thank you, sir. Because I want to spread this message to the physicians because they start very late and the absurd antibiotics we are seeing in the prescription. So we should give a proper message to the physicians.
Start IV antibiotic parenteral antibiotic if your infection is quite severe. Many people give only oral antibiotics. You can give oral antibiotics after 4 or 5 days. You should start intravenous to start with.
Thank you, sir.
And thank you so much.
So over to the organizers.
Thank you. It has been an excellent session by Dr. Mithun, Dr. Vijay sir, and Dr. Aravind sir. I think sir said they were all the complications of microangiopathy, and they very well enumerated about the technologies can do in it. It's a judicial approach. Patient has to be trained. We need to choose our patients, and definitely the wonders can be there. So moving on to our next session. Thank you, sir, and thanks to our chairpersons for the first session. Now moving on to our next session.
Thank you, Anubhav. Thank you to the organizers.
Yeah. Thank you, Dr. Ashish.
Thank you.
Thank you, Dr. Saurabh.
Thank you, Dr. Anubhav. Thank you, Dr. Saurabh and Dr. Ashish and all the speakers. Thank you.
Hi, Amit. How are you?
Hi, Ashish. I'm fine. Thank you.
There's been a great sessions going around.
Amit is going on reverse aging process.
So next, a very interesting session on self-monitoring. So I think we are at hurdles. Technology, when we talk about, I think when I heard about this conference, first thing which comes out to our mind are training our patients to at least monitor blood glucose and tracking their data. So today for this, on this symposia, we'll be inviting our chairperson, Dr. Nandita Arun. She's already with us. And Dr. Jay Prakash Sai, I think he would be joining soon. So over to Dr. Nandita to introduce our chairperson.
Thank you, Dr. Anuba, and very good afternoon to everyone here today. Of course, before I start, I must thank the organizers, especially Dr. Bansi Sabu sir, and congratulate the entire team, including Dr. Rakesh, Amit, on this grand success. And I'm very excited to be part of this as well. So without further ado, I'd like to start off this session, which is on self-monitoring as a whole. So as we all know, the management of chronic disorders like systemic hypertension, diabetes, self-monitoring plays a major role, and it is one of the pivotal roles that in patient empowerment, if I may say so. Self-monitoring also helps the patient to, not just the patient, but also the doctor to gain a lot of insight into the disease. As we all know, just doctor visits or just blood testing in the clinic is not sufficient for us to actually achieve good targets. With that as a brief introduction, we will move on to the first session, in which Dr. Jack Wang, the head of APAC Marketing and Global POCT at LifeScan, he is from Japan. And do we have a further introductory slide on Dr. Wang?
No, ma'am.
Okay, great. So I'd like to welcome Dr. Wang to the D-TechCon 2020, and he will be talking to us about self-monitoring of blood glucose. Over to you, Dr. Wang.
Thank you, Dr. Arun, and for that kind introduction. And thank you to the Congress organizers for the opportunity to present at this prestigious Congress, amongst esteemed colleagues. It's truly an honor and a pleasure. Can you, just to double check, can you hear me okay? That's fine?
Yeah, you're audible. You're audible.
Okay, so let me just share my screen. Can you see my presentation okay?
Yeah, it's visible.
Yes, okay, great. Actually, I'll quickly skip over this, but I'll just say that actually I originally came from Australia. I did my medical training in Australia, moved to Japan to do my PhD at the University of Tokyo before joining LifeScan. At the time, it was still with J&J, but time flies when a lot of things are happening all at the same time and developing at the speed that it is in the world that we're seeing today. So, it's a pleasure to be here to talk to you about, advances in blood glucose monitoring and connected health. And I think, before we go to the connected health part, I do actually want to take a trip down memory lane, because I think just to see basically where we started with blood glucose monitoring, I'm going to use LifeScan as an example, because I think LifeScan did pioneer the blood glucose monitoring space, back in 1981. This was 41 years ago. LifeScan introduced the iconic one-touch meter. It was the first of its kind, the first time that you could actually do blood glucose monitoring portably, and relatively affordable. And basically throughout the years, as we joined under the Johnson & Johnson umbrella of companies, we never ceased to develop and improve our products. So that takes us to the present day, where we have kept to ensuring that the products are simple to use, that they are accurate, that patients together with our healthcare professionals can trust the products. And to this portfolio that you see here, of course, going forward, we'll need to continue to add not only blood glucose monitors, but of course, continuous glucose monitors, CGM, other connected devices. But whatever we do, I think in this day and age, and also within LifeScan, our focus and our center of our portfolio is actually going to be this digital solutions, what we call the One Touch Reveal ecosystem, the platform, because whichever device that you actually eventually connect to, it needs to connect to something eventually. So that's the reason why digital solutions make sense to have at the center of everything that we do, to ensure that the patient experience, the user experience is improved over time as we continue to develop the products along with it. With that said, I'll just give you a brief history of One Touch Reveal ecosystem. Actually, back 13 years ago in 2009, LifeScan at the Apple's iPhone iOS 3.0 session. This was a long time ago, but LifeScan was actually the first company to demonstrate that you could actually transmit blood glucose values to an iPhone or another smartphone wirelessly through Bluetooth. And so we've come a long way since then. So in the space between 2009 to 2014, we were able to develop the first version of the One Touch Reveal app. And then since then, we are able to go through 4 iterations and also smaller iterations of the app, so that now we're at version 4.x. We've improved user interfaces and also interfaces for the healthcare professionals, so that telemedicine reports, all those things are also available to improve engagement between patients and the healthcare professionals. So with that context, I just like to go back a step and kind of look at it from a macro level, because I think as we all understand that we are just living in a rapidly growing digital health market globally. I mean, this is public data, but if you look at where we are at, estimated in 2018 in terms of the digital health market, it was at about $86 billion in value. 2025, it's estimated that this will grow to more than $500 billion, 30% every year. So it just speaks volumes to how quickly the market is actually moving in terms of digital health systems, technology. Now, this is across all areas of health, as well as mobile health technology is also growing at a rapid pace. The other bit that I'll say is that this is a report from the McKinsey & Company consulting firm that shows you that a lot of that action is actually going to be in Asia. So even in 2020 already, you see that the companies from China and India were leading the way in terms of the number of registered patients. And altogether with these companies, they were already touching over 1 billion lives in Asia alone. So certainly we're going to be seeing a lot of growth in Asia, India, and China, amongst other Asian countries. And we just need to be able to keep up with the pace of development in this area of digital health. So I've said a lot about digital health, but going back to the title of my talk in terms of connected health, I mean, what exactly is it? I mean, digital health is broader. I mean, it covers artificial intelligence, chatbots, IoT, virtual reality, big data, a lot of other things that encompass digital technologies used to improve the outcomes of health and medical care. So in terms of connected health, I see it as a smaller subset of digital health. It's more related to, as the name suggests, connections. So according to this definition, it does encompass terms like wireless, digital, electronic, mobile, telehealth. It refers to the conceptual model for health management where devices, services, or interventions are designed, around the patient's needs, and health-related data is shared in such a way that the patient can receive care in the most proactive and efficient manner possible. So that is, one of the definitions of connected health, and I think it's a pretty good definition for the purposes of talking about this category and area. So with that in mind, I do want to, introduce a bit about the LifeScan's mission, because I think LifeScan's mission folds quite nicely into this idea of connected health to also designing solutions around the patient's needs. Because, if we look at our mission is really to deliver personalized health and wellness experiences that engage people with diabetes and related conditions to live their best lives. We no longer can just focus on patients with diabetes, because diabetes is a long spectrum. I mean, oftentimes we focus on patients who are on insulin, but then in actual fact, with the advent of digital technologies, connected health, it allows us to intervene more efficiently, more effectively at earlier stages of the disease process, and even in pre-diabetes or in healthy individuals who do not yet have disease but may want to stay healthy. So that's the mission at LifeScan, and that's where we're heading to. What makes us believe that we can actually achieve this is the data set that we already have and that we're continuing to build on. For example, we have already 12 billion consumer data points. Now, this is across not only the mobile apps, but also across all the digital touch points like websites, consumer engagement platforms, etc. We also have a patient base of about 20 million patients globally, so that's across all the countries. We have 10 million global customer interactions annually. We also have about over 500,000 global app downloads annually across 27 countries, and that's including India as well. And I think accumulated up to this date, we already have over 3 million downloads in terms of our app across the last few years in accumulation. And then finally, in terms of the physician offices, because One Touch Reveal ecosystem and a lot of other digital solutions do allow the opportunity to connect patients with physicians. And so you see that we already across the globe, we have a total of more than 16,000 physicians, offices, hospitals connected to our solution. Moving on, and so I think this data set in a de-identified fashion means that we can also analyze it and give back to our users, to our patients, to our HCPs, trying to make the experience as personal as possible as we develop and upgrade and improve on the digital solutions that we provide. This is and then in the sense of how to achieve that, again, going back to the portfolio and how of what we're going to use, you can see going back to what I was mentioning before, we have our digital solutions at the center of everything that we do. And so that enables, again, personalized app experiences. It enables HCP office integration. So not only through this mobile app and the HCP web app browser interactions, but sometimes if designed correctly, it will also allow direct to EMR integrations. Telehealth and remote monitoring is also, of course, possible as part of that. And then progress reports and outcomes. In terms of devices, of course, we already have connected BGM devices. CGM, it's coming, and they will definitely have to connect to this digital ecosystem as well, so that we have a synchronized data source between BGM and CGM in the future. And then also connected instrument pens, we can't forget about that. These are also in the pipeline and in talks as well between LifeScan and the major insulin companies as well. So more to come on that. I do want to speak a little bit to our digital partners, and I'm going to use the examples from the US actually for this particular purpose, because as you may have noticed, One Touch Reveal is a digital ecosystem more centered around blood glucose monitoring, but patients with diabetes, as everyone will know very well, experience a lot of other, medical and healthcare needs. For example, weight loss, or coaching on nutrition and what to do under certain circumstances, fitness and activity, and then other conditions like hypertension, hypercholesterolemia, etc., and even maybe sleep disorders. So, in that sense, what we have done is to supplement our One Touch ecosystem, One Touch Reveal ecosystem, by partnering with digital solutions providers that offer expertise and services in those areas. So you'll see that, for example, Noom is evidence-based behavioral weight loss program provider. Cecilia Health is also a provider in the US that provide digital coaching with live diabetes educators for those patients that sign up. Fitbit, I'm sure everyone has heard of, and it's more to do with health, activity, and wellness. And then WellDoc. WellDoc is one of the, not the first company in the world to actually go into the digital therapeutics realm and get FDA a regulatory approval as a medical device, as a software. But WellDoc not only supports diabetes, but it also supports a variety of other conditions like hypertension as well. So what we try to do is to augment our own solutions with these partner solutions, so that we can offer a more holistic package and solution to patients and their healthcare providers. Eventually, this is an image. We actually don't have the solution yet, but eventually we do want to make something that will organize all the data points for the connected patient, so that they can live, grow, and thrive going forward. I'm going to move on because under the umbrella of connected health, I think digital apps are an extremely important facet of enabling connected health. Now, this number is actually 351,308 is the estimated number of digital health apps globally in 2021. It's a whopping big number. It's not only limited to diabetes across the entire health space, but it just speaks volumes to how complex the digital app environment has become over the last few years. And so what apps are good, what apps are bad, how do you choose apps to use for the patients or healthcare professionals? In order to guide that, actually the EASD and the ADA worked together to publish a consensus statement back in 2020 on what healthcare professionals should do, what manufacturers should do, what patients or advocacy groups should do, etc., in order to make the most use of digital apps. The essential, there are a lot of recommendations, but I think it's important to note that it's quite important. Quite important to provide safe solutions, and also have support to users and healthcare professionals, and also important to have clinical evidence to back up your digital solutions for those digital solutions that have significant healthcare outcome benefits. So with that in mind, I do want to introduce you to 3 of our clinical studies that LifeScan has conducted or is planning to conduct, in order to show you how we are trying to contribute to this space and provide safe and effective digital solutions. The first clinical study I want to introduce is a study called the 2 Salute study. It's actually, it was run in an underserved Hispanic population Latino population with, I think 66% of the population actually eventually enrolled had a primary school education or less. So the numeracy, literacy was not high. Their knowledge of diabetes was not good. And what we did was we took 120 of these patients, randomized them to either using their current blood glucose meter or the OneTouch Barrier Flex and OneTouch Reveal mobile app. We followed them up at 12 weeks and looked at the HbA1c readings in range along with other things. What we did then was to take this control group, that patients that were staying on their BGM, and switch them to the OneTouch Reveal system and the OneTouch Barrier Flex, and to see if there was any additional benefits. And the results were actually quite surprising to us as well, because you can see that in the test group, indeed, when the patients would put on OneTouch Barrier Flex and OneTouch Reveal mobile app, you could see a noticeable significant difference, a drop of more than 1% in HbA1c at the final 24-week follow-up. In the control subjects, there was also a small drop at 12 weeks, but when we switched them to OneTouch Barrier Flex with Reveal, you saw an additional drop of 0.6% in HbA1c. So I think this is goes to show that with the correct intervention and engagement, tools that are already available now can also have significant and beneficial effects on HbA1c and health outcomes. In the interest of time, I'll just briefly go over this next two studies. The next study was really looking at the real-world evidence from our OneTouch Reveal database. So what we did was we took a total of 17,000 data points, so 17,000 patients, roughly 4,000 patients with type 1 diabetes, and a little less than 13,000 patients. 14,000 patients with type 2 diabetes, and looked at, in real world, what their engagement was and what their results in range was. And we showed that basically there was improvement actually with the use of the app in their clinical health outcomes across the board. The more they were engaged, the better the health outcomes. And then finally, this is a study that we're planning, 800 patients with type 2 diabetes to be enrolled. We want to see if the partners that we're partnering with do in the real world actually bring sufficient, clinical benefits. So a lot of things happening, and I'll end it there. Saying that at LifeScan, we're trying to create a world of elements for people with diabetes and related conditions. Thank you. Let's stop there.
Thank you, Dr. Wang, for your wonderful talk. It's quite nice to hear about the work that LifeScan is doing, and I think many of us have already been using the OneTouch Reveal program in our patients and found that it is, in fact, very, very useful. Where patients also it helps patients to connect to the doctors a lot more easily, and it definitely has made a difference. Shall we move on to the next session, Dr. Amit, and take questions at the end?
Yes, Dr. Nanita, there is just a slight change. Dr. Mudit will be speaking first. After that, Dr. Narsingh Verma will speak.
Sure. Right. So the next session will be on, similar to the previous session, but taking it one step further, the integration of glucometers with smartphones. And we are in the technology era. Even in the previous session, we heard about the technology boom, and Dr. Wang was talking about the number of apps that we have and how everything is now available at the click of a button, and how healthcare and integration with technology is also transforming lives. So we have now Dr. Mudit Sabharwal from New Delhi, who is a clinician and with a large amount of rich clinical experience. He has a professional experience and significant experience as a diabetologist in various leading super specialty hospitals in New Delhi. He is also a mentor at Cardiff University. He has received several awards from Pharma Leader Award and the Most Innovative and Admired Diabetologist Award of India 2021. His special interest is in the management of diabetes, metabolic syndrome, and thyroid disorders, and also medical research and clinical training and innovations. Dr. Mudit, do we have Dr. Mudit with us? Yes. Over to you, Dr. Mudit Sabharwal.
Thank you so much, Dr. Nandita, for introducing me.
I'm sorry to interrupt. Is the video clear? Rakesh, are you able to see Dr. Sabharwal clearly? Or
no, I think there is an issue with his background.
Sir,
I think you should remove the background.
Background, sir. Yes. So we can see you clean.
Right. Yeah. Now you're clear. Thank you.
Thank you so much, Dr. Nandita, for introducing me. I'll just share my screen. Presentation. I hope my screen is visible.
Yes.
Yeah. So, good evening, everyone. As mentioned, I'll be talking about the unlimited and endless possibilities for a better and holistic glycemic control when a smartphone needs a glucometer, forming a digital yet affordable connected care ecosystem. Dr. Mudit Sabharwal, I'm a practicing diabetologist at Delhi and NCR. Now, as per the recent indices by International Diabetes Federation and various other forums, more than 77 million people in India suffers with diabetes, and about 80% of them with an alarmingly high HbA1c of around 8.5 on an average. A typical journey of a person with diabetes starts with discovering diabetes-related symptoms when his health starts to deteriorate. He then visits a doctor and gets himself tested, which leads to the discovery of uncontrolled glycemic values and other metabolic markers. This leads him to a state of denial, shock, and helplessness when he looks for other references that may or may not be scientific in nature. Again, so this basically creates a havoc in his life. So again, he's subjected to, so when he visits the doctor, he's subjected to medication and lifestyle changes that burdens him with their high cost, affordability, and compliance issues, leading to poor adherence to the complete regime, missing regular follow-ups with the doctor, and again, ultimately worsening his HbA1c levels and other biomedical markers. Again, the Indian diabetes care landscape has several fundamental challenges, which may be categorized into three major categories. So again, first of all, it's the accessibility, where 95% of people with diabetes are from tier 2 cities, and who can actually approach only 5% of endocrinologists available in these cities and beyond. And hence, only 8% of these individuals are able to seek a specialist for treatment. The next is the lack of awareness among people with diabetes, where 70% of them remain unaware about severity of the impact of disease and to the various organs. And just 10% or less have been introduced to diabetes education or health coach ever. The third one is the affordability, where high cost of medication may lead to lack of compliance and adherence to the given treatment regime. Moreover, the indices say that only 12% of these diabetes patients were ever subjected to glucometer monitoring. So what is the solution for these problems? The solution to these problems may include a high engaging digital care solution or platform to manage and to control diabetes at a large scale. Its components may include collection, tracking, and analysis of various data points for a patient, including his blood glucose values, biomarkers, weight, BP readings, and steps, and sharing them through a cloud or other sources for a real-time AI-based actionable insights and nudges for immediate support on his uncontrolled values and trends, and then sharing them with a certified diabetes educator or a health coach for providing management and assistance on his current high or low values, maintenance of his values in safe range,
through individualized nutrition, physical activity, and adherence to the prescribed diabetes medication. And additionally, instant alerts which are sent to his registered care providers or loved ones and to his doctor on his dashboard for further change in the treatment regime and prevention of such events in future. Now again, a holistic, connected, affordable care ecosystem has been successful in demonstrating clinical outcomes among monitoring population, and also has been responsible for expanding the diabetes care in the community at large. In reference to some of the studies published in various forums, glucose monitoring and individualized health coaching leads to about 1.1% HbA1c reduction, about 10% drop in the average fasting blood glucose levels, and about 60% hypoglycemia event reduction in just 45 days. Moreover, this impact has been seen in about 70% of diabetes patients from non-tier 1 cities, majorly tier 2 and tier 3 cities, where 55% of them were using a glucometer for the very first time, and 83% of them were connected to a diabetes educator for the first time ever in their life. Now we know from the UKPDS study, each 1% drop in HbA1c reduces the 10-year risk from suffering from all microvascular diseases by 37%, heart attacks by 14%, stroke by 12%, and peripheral vascular diseases by 43%, which ultimately leads to a 12% drop in death rate. Hence, this digitally connected care ecosystem adds a great value in managing diabetes and its complications at large. Now let's look into certain evidence for the impact of connected continuous care on diabetes management. Now this was a study published in Diabetes, Metabolic Syndrome and Obesity, Targets and Therapy in 2021, where more than 7,000 type 2 diabetes patients were subjected to the connected care ecosystem, including digitally supported and real-time self-monitoring of blood glucose, driven counseling by the certified diabetes educator, nudges and alerts. Now again, there was a high reduction within 45 days, including 60% reduction in hypoglycemic episodes post counseling, 81% reduction 81% patient had no hypoglycemic episodes post counseling, 9.9% reduction in pre-parenteral blood glucose, and 9.2% reduction in the post-parenteral blood glucose, respectively. Again, another study published as a poster in ADA, which included more than 7,500 patients, where reduction within 45 days showed that there was 9.3% reduction in pre-parenteral blood glucose, 8.9% reduction in post-parenteral blood glucose, 9.5% reduction in fasting blood glucose, and 6% reduction in the random blood glucose values when the patients were subjected to the connected care ecosystem. Again, another recent poster published in ATDD. So again, this was again on a large patient base with more than 2,500 patients who were subjected to AI-enabled digital diabetes care ecosystem. And there was about more than 45% reduction in post-parenteral hypoglycemia incidences, about 40% reduction in pre-parenteral hypoglycemia, 51% reduction in fasting hypoglycemia, and about 39% reduction in the random hypoglycemia incidences. So it not only reduces the glycemia at large, it also helps in reducing the hypoglycemic episodes at various levels. Now, this is a recent study which was published in ATTD 2022 as an abstract. So again, this was a 90-day study where the SMBG triggered CDE counseling effectively controlled overall hyperglycemia and maintained good in-range blood glucose levels during the lockdown phase in 2020. So again, within 90 days, there was a reduction of average blood glucose by 16%, fasting hypoglycemia by 81%, pre-meal hypoglycemia by 72.5%, and about post-meal hypoglycemia for about 68%. Again, let's talk about some of its affordability, and again on the affordability of the continuous care, which actually benefits the patient. Now I'll talk about a case where Mr. Nitin Bhide, who is a 45-year-old male from Pune. He had a known history of type 2 diabetes since last 3 years and was on 2 OADs, including sitagliptin 100 mg and metformin 500 mg twice a day. Now, on examinations, he had a normal BMI with HbA1c of 9%, fasting blood glucose of 195 and PP of 240. Again, he was subjected to, so as his HbA1c was quite high, even after 2 OHAs, he was given injection Degludec, which 12 units once a day, sitagliptin 100 mg and metformin was continued. He was basically in shock and depression because of uncontrolled diabetes and the insulin initiation. He felt that he was burdening his family with the higher medical cost. Now, he was referred by his physician to Beto's digitally connected continuous care program, where he was provided with a smartphone connected glucometer, regular reading reminders as per his critical medical profile, and alerts were sent to his caregiver for all the out of range readings. Now, he also received actionable insights which were pushed to him on all the readings as a guidance on for managing and preventing hypoglycemia and hyperglycemia episodes, and the data-driven chatbot which actually did some interception in between. Also, he received regular guidance and support by a diabetes coach to maintain his blood glucose values in range through individualized diabetes and exercise diabetes diet and exercise regime. Additionally, he was also given certain support on further lifestyle correction through some videos on yoga, diet recipes, etc. digitally. Now, after 3 months, there was a great impact. So again, his insulin was stopped. Sitagliptin and metformin continued. His HbA1c came down from 9% to 7.8. Fasting came down from 195 to 138 and PP from 238 to 184. All other biomarkers were good and there were no hypoglycemia incidences at all. Again, he was quite happy. He exercised regularly and he felt quite empowered. Now, the key takeaways from my side would be from this talk is basically the digital and mobile-based connected care ecosystem should be considered as a useful aid to the standard diabetes management protocols. Studies have shown that digital ecosystem help control HbA1c, fasting blood glucose, PP blood glucose, and moreover, reduction in the hypoglycemia episodes, which are more critical for these patients. And again, making the ecosystem affordable will aid to democratize diabetes management very effectively at a very large scale. Thank you so much.
Thank you, Dr. Sabharwal. That was an excellent discussion, and I quite enjoyed all the studies that you had presented as well, the original work that you have done in the field. We are actually unable to reach the next speaker. So before that, can we fill in by asking maybe a couple of questions? If anyone has any questions to ask the previous speakers, we have Dr. Wang and Dr. Sabharwal with us. Dr. Wang, are you here with us? Yes. So I had a question to ask you, Dr. Wang, if I may. Sure. As I had mentioned, the One Touch Reveal program is something that many of us clinicians have started using and found pretty useful to integrate into our practice. And patients themselves have actually found it very useful as well. But what I wanted to ask you is, in a country like India, where digital literacy is probably not as high as other parts of the world, but it is still picking up, of course. What were the challenges that you faced with integrating this, or in other words, the patient acceptability from the patient's end, and more so also from clinicians' end? Because I remember when the initial discussion at one of the programs that I attended, I found that many of the doctors were concerned about the legal implications behind, patients reporting their blood glucose. And if, for example, a patient had a hypoglycemia and they'd entered that into the one-touch reveal. And if it has not been picked up by the doctor, or if the doctor does not respond immediately, what are the legal implications? So there were some apprehensions that I noticed that doctors did have initially when the one-touch reveal program was initially brought up. So what were the challenges that you faced in that front? Is what I wanted to ask.
Thank you, Dr. Arun. I think that's an excellent comment and question. Actually, that's the first time that I've heard of such a legal concern. And I guess what goes through my mind is that a one-touch reveal ecosystems, much like other digital solutions, is not really meant to be a real-time alert system. So I think it does help with remote monitoring because you have a set time. For example, at this particular time, you set up a remote consultation, or if the patient constantly uploading their data and they come into your clinic, then the HCP, their attending physician, can quickly pull out the report, have a look at the summary, so that it basically makes the interpretation of the results and the patterns, are they high, where are they low in the day, etc., to be much faster. But at least in my experience, I've not actually heard of much use of it, or trying to use it as a real-time alert system to say, oh, you have hyperglycemia. What are you going to do? And I think that's where certainly CGM will come into play, because I think there's always a place for BGM, digital apps, and also CGM going into the future. And so CGM with their alerts and alarms will definitely have a much stronger force in that light. But even then, I mean, even if the CGM is connected to a cloud system, it's not really meant to be something that's alerting the healthcare professionals immediately, because everyone is busy, and you can't be on call 24/7 a day, 365 days a year. Although that would be ideal. So that's my comment. To your other comment about the experiences in India, it's funny because my role covers both India, China, and Japan. Right. And I can tell you that the pace of digital solutions pickup in Japan is actually much slower than India. So you'd be surprised. And I think it's more to do with the mindset, actually. Your comment strikes me as a little bit surprising, actually, because I would say that, wow, Japanese patients and doctors should be more like the Indian healthcare professionals and patients. So in that sense, that was one reaction that I had. But not limited to India, but I've seen in my experience with our own apps, and then also across other app providers, is this idea of engagement, that there needs to be a constant, consistent engagement between the healthcare professional and the patients in order for them to continue to use the app. So I think that's certainly a hurdle, because if I've seen reports where if the healthcare professional is actually not providing feedback based off the reports from, say, One Touch Reveal, at least in a consistent manner, across visits, then the patients tend to drop off much more quickly, because they see, well, what's the point? And maybe that's more related to an Asian ethos compared to, say, the Western cultures, where patients tend to want to do more things themselves. But at least what I see in Asia Pac is that patients tend to listen more to their healthcare professionals, want to do more, not only for their own health, but also to do more for their own doctors as well, in that sense. So there's certainly that engagement piece that I find very important, and I see consistent across all the countries. I don't know if that helps to answer some parts of your question.
It does, absolutely. I'm in fact very happy to hear that you think the Indian population acceptability is much higher than, as you said, compared to Japan. What I was more sort of pointing out to was the challenges in terms of the digital literacy rates. And if you compare, Japan, for instance, to the Indian population, majority of course, in the urban areas, you'd find digital literacy a lot higher. So that's in terms of numbers that you'd probably find comparing India and another country like Japan, you'd probably find that's where that question actually came from.
Okay. Yeah. No, thank you. So actually, that points me to the study that I introduced during my talk, the Two Salute study, because, to your point, it's not an issue that is only, seen in India. It's actually an issue shared across all the markets, really, that there are gaps in understanding. There are also differences in numeracy and literacy. And so what the Two Salute study tried to show was that it doesn't matter if you have low literacy or numeracy. If you are using barrier flex and the one-touch reveal system, because it is color-coded, so you actually don't need to understand the numbers at its most basic level, but you can just say, okay, if it's red, then you're high, and if you're green, you're in range, etc. So it just takes a little bit of coaching and understanding, and you can kind of tailor to the patient's literacy and numeracy depending on how much you think they need to do, how much you think they can comprehend to manage their diabetes that way as well. So, the meters and the apps, it's not for everyone. I'll see that. But it does give you more to offer patients if you think that they are ready for an app, amongst other tools that they can use to manage diabetes.
Absolutely. Yeah. I completely agree with you. And I think apps like this and technology in general has literally enriched, the management of diabetes, and the way forward is, integrating technology into healthcare. And having said that, I also must tell you that I've seen patients who come in with their one-touch reveal, with their data, and then they proudly present it to you and, show you their red zones and the green zones. So patients are very happy, and it's definitely a very useful tool. Dr. Sabharwal, would you like to add any comments that you have, or anything that you'd like to add?
Yeah, definitely, Dr. Anjana. I mean, as just adding to Dr. Wang's comments, I mean, again, the data which is now available has a very enriched, probably, it's enriching, and it's actually easier to interpret. It clearly shows that, I mean, if we compare the connected care ecosystems over here, let's say, for example, VTOs, I mean, it's like, a patient can clearly see where exactly the fluctuations are. I mean, again, CGM is an important part of our diabetes treatment protocols nowadays. But then again, it's not easily available, and it's not affordable by all patients. So I guess the glucometer, probably the connected care ecosystem through an SMBG.
This is the important thing, and this is the aspect what I'm going.
It actually helps, and it basically becomes. It actually helps making the whole diabetes management affordable, giving a similar kind of impact in the whole management. In the whole management result when we actually see a patient. And again, it basically helps in getting better results in the treatment itself. So the patient himself knows where are the fluctuations going on, and how is basically where exactly were the hypoglycemia episodes. The doctor can interpret hypoglycemia episodes and make the changes in the treatment protocols.
Dr. Jack, I would like to, first of all, I would like to thank you for accepting our invitation and taking out time for this World Congress of Diabetes Technology. And your talk was excellent, wonderful. I just, in one of your slides, you have shown that there are more than 3 lakh fitness app or the health coaching apps which are available right now. So the dilemma comes, how does one person chooses the right one? So there is a lot of, as during the inaugural ceremony, our chief guest, the guest of honor, Dr. Shashank Joshi, he talked about that one of the important responsibility of any forum dealing with technology is to deal with the misinformation also. So we need to deal with the information overload, information clutter, and lots of information. The information which is not evidence based, it travels very fast. But the science doesn't. It doesn't happen the same with the science. Science is always looked upon with suspicion, but something coming up with the non-scientific person will travel very fast. So how do we identify the right app, right things, and for our patients?
First of all, it's my pleasure to be participating in this congress. Thank you for your kind words, Dr. Gupta. The next question to which I have no answer to, because that was actually pointed out in the recommendation by the EASD as one of the biggest issues, that there is a lot of clutter, and how do you choose? And so that was the genesis of how they came to that recommendation. Like, I mean, they say that, for example, from a healthcare professional's perspective, you should do your research before you choose an app, or try to talk to the patients about the apps before you start using it. But now, while that is ideal, you probably don't have time to actually do all of that, right? So I think while there are that many digital apps out there, the truth of the matter is that a lot of them are probably just out in the App Store, and not really doesn't come with a lot of information. There is also a lot of mismanagement. For example, the versions are not updated regularly, and this is covering a whole spectrum of apps. It's covering from, say, things like Reader, One Touch Reveal, to all the way to like very simple like nutrition apps or menu apps, etc. So it is a wide spectrum. But what you didn't see, what it didn't show in that the 3 lakh number is actually there's a lot of flux. Like, I think in that report every year there's like 50,000 apps that are deleted, and then another 50,000 that are added. So there's actually a lot of flux in there. But I guess to try to answer your question, my guess would be that the manufacturers or the companies will have a very big role to play in this, and with responsibility to provide information in the form of clinical evidence that I presented. Also, Dr. Sabrawal also just presented, trying to be able to provide that information in a manner that makes sense, and be able to answer your questions. Also have, whether it's from the sales reps from the company, or whether it's customer care websites, all that support set up properly in order to ensure that at least there is a portal for information gathering should that be required. So I think that's probably the biggest difference between, say, company like LifeScan that has that scale and be able to provide that support versus maybe an app that was just built and left there on the App Store. So yeah, while the number is big, I think there are probably a lot less useful apps with that sort of support that can help healthcare professionals better make the choice of which apps to use. Does that help somewhat?
Yes, thank you, Dr. Jack. You have answered that very aptly. Mudit, I have one question to you also related to the same thing. As you know, you talked about the smartphone connected to when a smartphone gets connected to a glucometer, so possibilities are unlimited. So one of the things you talked about is the way you inform patients to keep track of their sugar levels, and you intervene. So how do you decide on the frequency? Because sometimes that can also be invasive to the patient, because many of the times there are patients who actually appreciate that, but on the other hand, you have the patients who do not actually appreciate this. So how do you define the frequency, and what is your experience, because you are using it for a longer time? So and how do you wish to address that?
Thank you so much, sir, for your question. So first of all, I believe that there are 2 incidences, and number one is hypoglycemia. So the intervention should be done, and probably that is again defined, very clearly defined. If someone's glucose falls down below the critical level, so the CDE and then AI nudging system automatically intervene and pushes off nudges to control, to manage and to prevent hypoglycemia in future. And the patient is actually sent, the data is sent to a CDE or a health or a diabetes coach for guidance to the patient. The chatbot actually intercepts in between by probably guiding and guiding the patient on the protocols to prevent and manage hypoglycemia in future events. Now, secondly, again, hypoglycemia when the sugar levels goes beyond 240. So that's basically again another trigger when the patient is intervened in a similar manner for management and prevention of hyperglycemia in future. The third part is when we see generally it's the trends. So it's actually if someone's glucose values are going trending to an uncontrolled level from a normal values to hypoglycemia levels, or probably normal values to hyperglycemia levels, or if there are multiple fluctuations which we can probably see in the SMPG patterns, then the intervention similarly comes into picture when the diabetes coaches intervene and guide the patient to manage the state. It's actually, and the intervention as per se is not just telling them what to do. It's actually goes beyond the diet and exercise. It's actually a pro-clinical or pre-clinical approach where the patient is guided on the diabetes diet, which is individualized as per the patient's requirements, as per the patient's medical profile. And again, the exercise regime, which is again as per very individualized as per the patient's own clinical and personal profile.
Dr. Mudit, if I can ask a question.
Please, sir.
Are you there, Dr. Mudit?
Yes, sir. Please, sir.
Yes. So see, the connected smartphones and the devices which are connected to smartphones, people are concerned about the digital footprints. So whenever you go on Google and search for something, you start getting advertisements for that same product on different devices and different platforms. So are you concerned about that while connecting your device, mobile device to a smartphone?
Generally not, sir. If in case it is properly regulated, I guess most of the devices are HIPAA compliant, and probably if they are properly regulated as per the FDA protocols, then I guess these things can be avoided.
No, but the guidelines are for devices, not for the apps, I guess. So like if you are connecting your device to an app which is not regulated by any guidelines, so that app would track your activity, and maybe then
Sir, it depends. I would say, sorry to intervene, sir. Sir, it depends. What is the intention of the device? What is the intention of the app to track your activity? If an app is tracking, and as Dr. Wang also said, if an app is tracking your blood glucose levels or biomarkers and helping you and guiding you and in management and prevention of acute events and managing your diabetes regularly and in a better manner, then I guess patients are always happy because they have a second hand which is holding them when the doctor is not available. So it's as
but along with that, it's tracking other activities as well. So that risk is always there. Like being the devil's advocate, I would say that people who are using such devices which are connected to apps, they always have this question that would that track my activities? So
generally all the certified and regulated apps and devices, both of them are generally regulated. As Dr. Wang said, there are lakhs of apps available on the App Store. I'm sure I don't know about others, but yes, I guess whether it is OneTouch or whether it is Beto or whether it is any other good company, they generally take care of these regulations.
Dr. Wang, do you want to add something to this?
No, I completely agree. There are, not only in India, but across the globe, there are very clear regulations on cybersecurity, depending on the markets it goes. I think, it's a lot more stricter now in Europe and the US, for example. So we certainly do need to ensure that our cloud systems, the servers that we store all the information, for example, are comply with those strict regulations, because otherwise, to your point, there's always that worry and concern from not only from patients but also from healthcare professionals about, well, is there going to be a leakage of your data, etc. So I think that's also one of the things that was pointed out in the recommendations by the ADA and the ASD, that you do need to comply with these regulations, and not all the apps do, but certainly the more reputable manufacturers will need to comply with that, because it is something to do with the brand recognition as well. So that's the only thing that I'll add.
Thank you, Dr. Wang. Dr. Nita, the third speaker was going to talk on home monitoring of blood pressure, but I think he couldn't make it because of some technical problems. So maybe if we can discuss on that, maybe I'll start with you.
Sure.
If you have, if you can talk about HMBP.
So sure, of course, Rakesh. Before I, we delve into the blood pressure monitoring, there's just something I wanted to add about the fact that we should be fortunate as clinicians to be in this field of diabetology, because diabetes is one of those fields where digital technology and the application of online platforms is actually possible. And unlike many of the other fields in medicine, I think diabetes, dermatology, and maybe psychiatry are the three fields where online consultations and in fact, I think there's a huge transition in our OPDs itself, where we are now moving on from just a face-to-face visit with our patients to almost a hybrid model in our daily clinical practice as well. Even I think every day we're seeing probably a 50-50 sort of patients face-to-face, and then 50% of them already that we are starting to see on the online platform. So we recently, in fact, launched an app called the Dia Home app from our center in Chennai. This is a 360-degree comprehensive model where we bring everything to the patient's doorstep. And all the patient has to do is download the app, and they have at their disposal, they have not just the consultation with the doctor, but they can also order the tests. There's a physician assistant who is roped in, and the physician assistant takes the entire history of the patient and orders the tests, whatever test needs to be done. And the tests are all done home, including the blood test, the eye, the foot examination, which it would include the Doppler and the biothesiometry and ECG. All this is done in the patient's home at the convenience of the patient's home. And the final step is, of course, a consultation with the doctor. And this we found has been widely accepted among patients, and it's been really doing well. And you're sitting in your clinic in Chennai and literally seeing patients across borders. I think this is definitely the future, the way ahead, and probably one of the blessings in disguise after the COVID times, because that transition has probably been pushed further after the COVID era.
This I was telling a blessing in disguise.
Absolutely.
Definitely a blessing in disguise.
Yes.
Yeah, whether we talk about the blood pressure monitoring we were discussing also, if not only in the file of diabetology, we are equipping the patients also. Well, it's a great thing that you're having 50-50%. We have a lots of future for the hybrid patients also, not only for the hybrid conferences.
Right.
Can we have something talk about home monitoring of blood pressure also? I think our learned speakers would highlight on the importance of this home monitoring.
So if I may start off.
Because one of
Sure. So I think other than blood glucose, the other parameter which remains asymptomatic, and where the patient is, where patient empowerment and self-monitoring is extremely essential and an integral part of better outcomes again, would be blood pressure, home blood pressure monitoring. And of course, not to mention the so-called white coat hypertension, where many patients in our clinics, we find them saying, no, doctor, I check my blood pressure at home and it's normal. It's only when I see you here in the clinic, I'm stressed out and my BP is elevated.
This is
so. Right. So, I think blood pressure monitoring and home monitoring of blood pressure is extremely essential for us to be able to diagnose for both therapeutic and sort of diagnostic purposes. So of course, there are various drawbacks to this. There are both the pros and cons. The accuracy of the devices and the devices that are being used. There are various technologies behind it. So I think there is a school of thought that only the mercury or the sphygmomanometry is the actual or the best way of and the electronic devices are probably not. We have Dr. Verma with us. Good afternoon,
I'll
sir.
add on, Doctor.
Yes, Dr.
Hello. Yeah, Doctor. I was just wanted to add because the mercury sphygmomanometers are no longer recommended by the guidelines of blood pressure monitoring. The electronic oscillometric methods are equally effective, and as we all are aware, diabetes and hypertension go hand in hand. So if we are able to have a SMBG and home monitoring of blood pressure, because ABPM may be a gold standard, better as you told about the white coat hypertension, the masked hypertension. But if the patient is able to monitor at home, at his ease, and able to share the data, so that could be a better way, because as we had a previous session, the microvascular complication, the clock goes on ticking. So I think if both the arms are controlled, and yeah, the standardization will always matter, definitely. This can be in our Indian context. What we can do is we can ask the patient to bring both the glucometer and the blood pressure monitor along with them, and we can have it rechecked with our clinic measurement machines. So that can give a confidence to the patient, and even we can ask them to get it standardized on a very particular way. Oh yeah, we have one more. I think Dr. Nandita, you can just call upon. I think sir is there.
Yes,
Dr.
we have Dr.
Verma sir is
Good evening, sir. Dr.
Good
Verma,
evening,
are you
sir.
able to hear us?
Good evening. Good evening.
Good evening. So we now have Dr. Narsingh Verma. I will not keep you all from hearing from him. He is going to be talking to us about home monitoring of blood pressure. Sir is the head Department of Family Medicine in KGMU Lucknow, and he's a president Association of Physiologists of India, past presidents UP Diabetes Association. He has several, I think it'll take a longer time for me to go through his entire CV, but without further ado, sir, I'll pass over the mic to you. Over to you, sir.
Thank you. Thank you for giving me this opportunity, despite of your very busy schedule. Anyhow, I made it. So I will share my slide. And thank you, organizers, for giving me this opportunity to talk about the home monitoring, which is very, yeah. I think my slides are visible.
Yes, sir.
Yes, sir.
Fine. So I will be talking about home blood pressure monitoring and how to perform it and what is new about home blood pressure monitoring. I have no financial relationship to disclose, and I will not discuss off-level use or any investigational use in my presentation. Whatever I will talk is known, and it is evidence-based medicine. So objectives of my talk will be rationale for blood pressure monitoring at home, equipment, patient education, home blood pressure values, and various resources which can be very useful for all. Challenges to hypertension management perceptions are that 80% of people were unaware of the association between hypertension and CVD. They don't take hypertension seriously. 63% believed that hypertension was not a serious condition at all. 38% of people thought they could control high blood pressure without the help of a health professional. And about the measurement, this said by the normal Kaplan is very good saying that the measurement of blood pressure is a clinical procedure of greatest importance that is performed in the slopiest manner. A lot of problem with the measurement of blood pressure, and hardly anybody takes seriously. It is being performed as a routine, casual way, and that is why the control of blood pressure is very poor in my country and also all over the world. So how to measure? We have different methodologies to measure. I am not going in detail about that. Auscultatory method. Here, the auscultatory method, we need a stethoscope, and by that we auscultate, and changes in the flow of blood can be measured. And in that, we try to find out the systolic and diastolic. Then the auscultation, by auscultation, we try to find out the systolic and diastolic blood pressure. But oscillometric method, which is rarely taught in medical schools nowadays, even after having these meters available, instruments available, is still not being taught in the medical school, oscillometric method, which the physician will be using throughout the life. In this, oscillometric method is based on the change of the magnitude of oscillation. And here, the mean arterial pressure is measured, not the systolic or diastolic that can be known by mean arterial pressure. We all know that mean arterial pressure is more important rather than the systolic and diastolic one. Now, the next question is, how often should we measure? The blood pressure measurement should be done at least twice a day. Why? Because at least 2 readings in the morning and 2 readings in the evening will be enough to find out changes in blood pressure. The diurnal changes, at least, we know that blood pressure is very, very dynamic parameter, keeps on changing. But at least 2 readings can be taken to find out the difference morning and evening. Measurement taken by patient at home are often lower than the reading taken in the office and closer to the average blood pressure recorded by 24-hour ambulatory monitors. So what I heard about ABPM, the discussion was going on, we can have the home monitoring in place of ABPM for all patients, and only for select patients we can go for ABPM. Home BP reading predicts risk better than office BP. And in a 2005 Gallup poll, it was found that 35% of hypertensive patients now check their blood pressure at least once per week. 86% of patients who had been advised to purchase a blood pressure monitor had done so, and 55% of patients were monitoring their blood pressure increase in 17% from 2000. But the COVID time has also done one thing in India, that most of the house now own at least a monitor. But only problem is still is that whether that monitor is of gold standard. That is the question we have to answer. So equipment is very important. Fully automated monitors that use the brachial artery for measurement are the most reliable. Documentation can be improved if patients use monitor capable of printing and storing readings. Oscillometric devices may not work well with patients who have arterial fibrillation or other arrhythmias, but now we have got good oscillometric devices which can be used in these conditions as well. Patient monitors should be checked against mercury sphygmomanometer. This is a standardization, and this had to be done at least 3 months. Every 3 months had to be repeated. For validated equipment, this is one website which is available, and by that British Hypertension Society guidelines, we can find out that which monitor is validated one and which can be a good monitor. To my knowledge, in India, we have only 2 good quality monitors available, but I cannot name them here in this particular meeting, but they are there and they can be used. And you can find out more about the validated equipment on the this particular website. The patient correct cup size is very, very important. And for cup size, the length and width are given here, and we have to use different cup size for good readings rather than relying upon a single cup size, which is most commonly seen in our clinics, that we have only one cup size. What I do, I ask my obese patient to carry their cup along with them, because they had to take blood pressure again and again. They should purchase the different cup size because their cup size is different. It is not our fault. So home blood pressure monitoring is the call of the day. The several disadvantages of the office measurement are not there, and this has been proved by so many guidelines. So many researchers have proven that home monitoring is better. But how to do monitoring of blood pressure at home? The correct technique for home blood pressure monitoring is sit calmly with back support. Back support is very important. Feet flat on floor for 5 minutes before taking a reading. Feet flat on the floor, not hanging, and upper arm should be bare. This bare upper arm is very, very important. When taking a reading, the arm with cuff should be supported. When taking a reading, the arm with a cuff should be supported on a firm surface at heart level. The arm should not be hanging. Should not be hanging. Caffeine, smoking, and exercise should be avoided for at least 30 minutes before the reading is taken, and the cuff should fit snugly, not very tight, not very loose, because very tight cuff will have different reading and loose cuff will definitely have wrong reading. Patients should take at least 2 readings, preferably 3 readings, and record them all. The interval between can be as little as 1 minute. Readings should be routinely taken in the morning and at night before bed, and in the morning just after rising from the bed, after widening the bladder. Widening bladder is very, very important. When the bladder bubble is not comfortable, the blood pressure will be different, it will be high. The recommendation is to take more than 2 morning readings and more than 2 evening readings every day for 1 week for confirmation of hypertension. This gives a total of 12 readings on which to make clinical decision on, and that clinical decision will be valid decision, and this decision will be accurate one. And we have to educate patients again and again so that they can learn the art of, they must be having the monitor, but they do not know how to monitor it. So we have to teach them and educate them how to take blood pressure. The upper limit of normal for home pressure is 135/85 millimeter mercury. This corresponds to office measurement of 140/90. So these are the advantages of the home blood pressure monitoring. They can take multiple readings over the extended period of time, avoids white coat reaction to BP measurement, reproducible, predicts CV morbidity and mortality better than office one, and can diagnose white coat and mask hypertension better, and which cannot be possible by office one, allows patient to better understand hypertension management, and telemonitoring allows remote monitoring by healthcare professional, detects increased BP variability. Now we have monitors which are having the Bluetooth technology, and the patient can take a reading, and that reading will come to you, and you will monitor the reading, and accordingly you can monitor the treatment as well. So this technology is emerging and which can help our patients. The good quality monitors have this particular technology, the Bluetooth based technology. Limitations are also there. Some devices have been found to be inaccurate, and in India, a lot of such devices are being sold. There's no regulatory body to stop it, and cuff placement can affect accuracy. For that, the one more technology has been done, and it is in the sum of the monitors, that is called as IntelliCuff technology. IntelliCuff technology is that technology which helps that even if the positioning of cuff is not correct, not have the changes in the reading. Risk of treatment change by patient based on casual home measurement without doctor guidance is one risk which is very high in my country, because in my country everybody is a doctor, including the relatives of the patient. Lack of nocturnal recording is there, but in the evening recording can be done. Some of the monitors do have this facility that they can record night reading as well, but that requires some different type of monitors which are available nowadays. For India, this is not important because we are not being reimbursed anything. So this was I was talking about Intelli wrap cuff technology. Here, the standard cuff, industry standard, new Intelli wrap cuff. You can find out the difference, that acceptable range is there, and longer air bladder is there, larger acceptable range of placement versus brachial artery, means risk of error if placed outside of range is lower than with the standard cuff. So once, if purchasing a monitor, the monitor, if it is having the Intelli wrap cuff technology, it is better one rather than the simple one. So the home blood pressure monitor is very valuable, and 5 prospective studies have compared home and office BP for predicting cardiovascular outcome. All 5 found that home BP is a significant predictor, and 4 out of 5 that is stronger than office BP. Other studies have shown that home BP predicts target organ damage better than office BP. Patients who monitor their home BP may be more likely to take their medications regularly. Recommendations: by various guidelines is also there. National Institute for Clinical Excellence, nice guidelines for guidance are again in favor of home blood pressure monitoring. For each BP recording, 2 consecutive measurements they have advised, and that we have already talked about. And the European Society of Hypertension Working Group on Blood Pressure Monitoring has produced a detailed consensus document on guidelines for home blood pressure monitoring. It recommends semi-automated or automated electronic devices, which we have already talked about. So advantages are various in the form of reproducibility, accuracy, white coat effect diagnosis, mask hypertension diagnosis, and recent meta-analysis published, which has recommended that the risk stratification is better by the home monitoring. Prediction of cardiovascular stroke morbidity and mortality again is better by home monitoring. So many, but I will not say all. The prospective studies have found that home monitoring predicts CV and stroke morbidity and mortality more accurately than office BP. However, home monitoring does not provide nocturnal reading that I have already talked about. Special population who have been benefited by home monitoring, they are elderly one, BP variability tend to be high in them. So they will be benefited more. Diabetic individuals, which Dr. Anubha was talking about, diabetes and hypertension go along. And if we can have a glucometer, why we cannot have a good quality monitor? And both should be, patients should be asked to record both, not only glucose levels. And tight BP control is required in diabetics. That is why she was talking about it. I firmly agree with her. Pregnancy, the early detection of preeclampsia might be facilitated by home monitoring. Chronic kidney disease, BP may be fluctuate a lot, and home monitoring help with management. And here in chronic kidney disease, the home monitoring is a good parameter. Children, white coat hypertension occurs in children, and there are some data on normal home BP levels at different ages. Also, adolescent hypertension is rising. So again, we need home monitoring in children as well. Large-scale studies are now investigating the optimum use of home monitoring in prevention of CV outcome. And the multi-centric hypertension objective treatment based on measurement by electronic devices of blood pressure, HOMED BP 2001-2010 trial, proves the feasibility of adjusting antihypertensive drug treatment via a computer rhythm that automatically generated treatment recommendation based on home monitoring and suggested that a systolic BP level of 130 should be an achievable and safe target. So this was published in Hypertension Research in 2012. Very good article, and the coming time we can have all these type of things in my country as well. Advantages, other advantages are different methods of measuring BP response by clinical treatment decisions, and a meta-analysis of more than 6,000 patients found that antihypertensive response to therapy measured by home monitoring was 20% less than office measurement. So this is again a good one. Compliance and improvement of blood pressure condition, and several meta-analyses have shown that the compliance increases with an increase in blood, and not only compliance, also the blood pressure control is better. And you will agree that if the compliance is good, the blood pressure control is definitely going to be better. Cost effectiveness is already there, and this was published in Lancet that showed that cost benefit analysis found that ABP was more effective than conventional clinic BP monitoring in diagnosis and management of hypertension. This is used devices and values. We have already talked about that. Regular verification is very important, and educate patient training is very important. Without this training, home monitoring will not be that useful. And regular verification, accuracy of the device, measuring techniques, that verification is very, very important. So one more thing, that if the brachial pulse is a radial pulse, we can palpate, and it's regular, automatic monitor is better. It is irregular, then the manual monitor will be better. But there are certain good quality monitors which can be used even in the tail fibrillation without any problem. So patients also prefer home monitoring, and all these things which are seated and 5-minute rest, etc., are common as in office measurement. Clinical inertia about change, which is very common with physicians, but they are not accepting it wholeheartedly, maybe because not having access to good quality monitor. Their myths are there, lack of awareness is there, but everything is changing very fast. During COVID times, even physicians agreed to home monitoring, and lot of houses now own the monitors, and we believe their readings after we have made videos to educate them how to measure blood pressure, and then we are accepting their readings. This was one trial, honest home blood pressure and cardiovascular outcome in patients during antihypertensive therapy. Primary result of honest say this has shown that the HBPM program using electronic monitors is effective in improving compliance in arterial hypertension, measured using the MEMS monitoring event management system. That was case, and that has shown that this program is useful in controlling blood pressure. So that was my presentation. Thank you very much for giving me this opportunity to talk about home monitoring. I still say that home monitoring is a very good device and can help in controlling of blood pressure, which is very poor. Only 9% of Indians have the good control of hypertension, and also some of them are receiving drugs without hypertension. So accurate diagnosis, good prognosis, and good control and good compliance, everything can be achieved by home monitoring. Thank you. Thank you very much.
Thank you. Thank you very much, Dr. Verma, for your wonderful talk. That was quite a powerful talk indeed. And I think you've really cleared some of the doubts that many of us clinicians have, in spite of this blood pressure monitoring being such a basic parameter that we check in almost every patient, rather. There are many doubts that still remain uncleared, and that I think you've thrown a lot of light on areas that we needed to. Without further, I think we have Dr. Warren Lee with us, who's a speaker for the next session. So I will hand over. Thank you, everyone. It was lovely to be part of this session. Thank you. We'll move on to the next session.
Thank you.
Thank you, sir.
Thank you.
Thank you. Thank you.
Thank you, all the speakers and the chairpersons. I would like to invite Dr. Ayush to take over the next session, and please invite the speaker so we can move on to the next session.
Thank you, Verma sir. Thank you. Dr. Amitesh is not there. He has some medical family emergency. So Dhruvi will be there, I guess.
Thank you so much. We have a fantastic D-TechCon going on. We've had a wonderful session, and Narsi Verma sir has, really made us all excited for the next session as well, which includes futuristic technologies. So our first speaker is Dr. Warren Lee. He is a pediatrician from Singapore. He's a fellow Academy of Medicine Singapore from 1997. He's also FRCP from London and RCP of Pediatrics and Child Health 2007. I have read his profile online, and it says he was one of the first pediatricians to initiate insulin pumps in 1998 in type 1 diabetic patients. So I think without much further ado, I would like to request Dr. Warren Lee sir to move on with our very first topic of our session on futuristic technologies.
Thank you. Can you hear me?
Yes, we can.
Share screen. Yeah,
yes,
let me try and share screen with you all.
All right.
Let's see. How do you do this? Yes. Okay, so sorry. Just reviewing my slides while talking to you all. Okay, can you see me here?
Yes,
right.
We can.
So my topic, I think was a little bit difficult. I was asked to talk about alternative methods of delivery of insulins. And I think it's perhaps a little bit easier to talk about new insulins, new technologies to deliver insulins, and alternative delivery methods. It's a challenging talk to give, I must say. But anyway, first, my disclosures. I've been in this field for 30 over years. I'm very thankful to Banshi Sabu for inviting me to speak to old friends in India. And I have no conflicts of interest with regard to the contents of this talk, even though I've actually spoken on behalf of most of the companies in the field. I feel that the challenge of this talk is that there are multiple eminent speakers and domain experts. I just spent some hours listening to fellow experts just now. It's mind-boggling about the scope and expertise of the program. So the overlapping program topics and presenting accurate data on yet to be marketed products and services is actually difficult. While maintaining a sense of perspective regarding new technologies when it comes to convenience, efficacy, price, accessibility, affordability, usability, and relevance for own practice is a challenge, especially when listening to the reality that many of our patients are not where we live. They're not in tier 1 cities like Singapore or the major cities in India. Many people will have difficulties actually assessing basic insulin in countries in Asia, but also in communities within hitherto rich countries like America. So just to have a quick short history of insulins, we first had insulins discovered about 100 years ago, first patented in 1923. The first recombinant human insulins came about 60 years later. 10 years later, the first analog started coming out. And soon after that, the long-acting analogs came out. And once the patents expired on these new analog insulins, we had the introduction of biosimilar insulins, as well as lots of places where they were making copies of the patented insulins. Now, 100 years since insulin was invented, we found that actually there's been a consolidation of the market, especially in the Western world. In China and India and Eastern Europe, there are companies that make insulin as well, but the big three actually control big parts of the market. Now, subcutaneous insulin has inescapable limitations. Firstly, it needs to be injected. Absorption is slow and erratic, and insulin is fed into the systemic rather than the portal circulation. And these absorption limitations cannot be overcome by engineering the molecule. So there was a commercial incentive to move on from the human molecule, which can be patented, which cannot be patented, to genetically engineered analogs, which can. And so we are in this era of patentable new molecules. And on the one hand, there is obviously a desire to reduce pain and suffering and make things easier for patients. On the other hand, we recognize that this is an area where people can make lots of money. So the analog insulins are essentially modified delivery systems, because at the end of the day, you still have to sit on the insulin receptor, which has not changed. The thing is that analogs typically cost 6 times the cost of human insulin, and they are better. And cost apart, there is not very good reason not to use them. But do they really help us to do the job? Are there other alternatives available?
Yeah, sure.
So what was the old paradigm? I put that in green. And what needs to change, perhaps in yellow? So the old paradigm is insulin is a protein, and it can only be given parenterally using using a needle. Fast insulins were never fast enough, and basal insulins were never flat or predictable or long-lasting enough. Glucose levels and insulin delivered, we didn't know what that was. It was mostly guesswork, and therefore most dosing decisions and pump settings even were based on experience and dogma. So what we needed to do is to find other routes to give insulin, try to find ways to doing away with the needle or reduce the number of pokes, and actually get better insulin, so that instead of having to do 2, 3 insulins many times a day, perhaps to use 1 injection and then for long acting, and different methods to give short acting insulins. We could also have smarter dosing decisions. So we might get and integrate information about glucose and insulin levels and food in a very simple way. And while this has been done with pumps, could we do this without the pump? So strategies to reduce injection pain include needleless injectors, but for some reason, although they have good theoretical results, good absorption, there has been poor acceptance, and it's not very new. I didn't want to talk about them too much. We could reduce the number of injections by having super long acting basal insulins from almost daily, glargine and detamir, to anytime daily, which is Tresiba or Degludec. And now there are once a week insulins coming on the market. Somebody is talking on this program about that. Or we could use injection pods, so that instead of injecting into your skin, you inject into the injection pod, and you change only once in 3 days, like an insulin pump, but you don't pay for an insulin pump. Or you might have faster acting mealtime insulins and smarter pens that can talk to your handphone and have AI to tell you how much to dose so that you end up giving more correct dose and fewer correction doses, so fewer pokes. Or we might actually have insulin that is given without injections or needles. And that might be oral, intranasal, inhaled, rectal insulins, or even a transdermal patch. Now, let's just go back to a few basic things, right? So if you talk about glargine, this is one way to reduce insulins that were MPH given twice a day, even 3 times a day. And what they did was they changed the molecule a little bit, so it became more acidic. And when you inject it, it turns into, it sort of turns into aggregates underneath the skin and slowly releases. And with that, we had fairly decent long-acting insulins lasting a day. Then you had degludec, and of course, in that era, detamir was the competitor. And then you had degludec, the next thing, which from Novo, where they actually found a way to attach a fatty acid, so to make it last longer. And then we had basal insulin with GLP-1 analogs, mainly used in adults. I think it will come to type 1 diabetes and children soon enough. And basically with this is that if you use a basal insulin, an insulin sensitizer, or GLP-1 analog, you will actually end up with fewer injections because there's a lower requirement and these people are more able to make their meal boluses on their own. And then again, coming on this program soon, somebody will be talking about icodec, which is a new analog that is designed to last 1 week between injections. So that really will reduce the number of injections we might want to give, which then makes a short-acting meal insulin given by a non-injection method a much better viable option. Because there was the other point that if you had to give insulins, if you could give insulins without injection for meals, but end up still having to give long-acting insulins every day or twice a day, what was the point? So icodec actually is one of these things where you are able to bind this insulin to albumin and it slowly releases itself. So we only need to give it once a week. How about making faster insulins? Well, so we had Lispro, which was invented over 20 years ago, but the people at Eli Lilly actually added things called prostacyclin analogs and citrate to make it to have local vasodilatation, so it could be absorbed faster. Okay, so it comes out faster. How about Fierce? This is Novo Nordisk's new thing, where they added vitamin B3 to their formulation. So again, it comes out faster. And all these things, yes, you can have statistically improved time of onset, rate to maximal, shorter duration, which makes it easier and more convenient to give meal boluses. So do they actually represent valuable advances? Well, you know, the insulin Lumjev is about twice the cost of generic insulin Lispro, And the retail prices for Fierce and Novolog in the States, which is the Novo branded form of NovoRapid in the US, is about the same on a per unit insulin basis. But before we run away with that, we have to understand that when we read these press releases about insulin in the States, you have to remember that insulin in the States costs about 10 times more than in any other developed country, even than their neighbor across the border, Canada. Okay, so if these are new insulins, are they going to be so costly? Does it really represent an advance that we can use on our patients, or just something to read about, something that we better know something so that if our patients ask us, we don't look so ignorant? So coming back to more mundane things and topic of I was supposed to talk about, what are the challenges of alternative routes for insulin delivery? If you give by mouth, the buccal and sublingual mucosa present special problems for delivery due to the effect of the relatively thick multi-layered buccal barrier and the constant flow of saliva, which actually has enzymes as well. How about through the skin? Although the skin is easily accessible and has a large surface area, it is relatively impermeable to hydrophilic polypeptides, which are proteins such as insulin. So if you want to use it through the skin, you've got to find a way to get past this barrier. How about through the nose? Local barriers to absorption exist in the form of active mucociliary transport mechanisms. Okay, again, our nose is designed to get rid of stuff like pollutants and dust and pollen, which the body doesn't like. So it's got an enzymatically active, low permeability, low pH nasal epithelium that you must get through in order to go and have a peptide absorption like insulin. Not that they have not tried. How about through the lungs? Well, this is the largest available surface area for drug delivery, but you have the challenges of inspiratory flow rates which change, patient techniques, large inter and intra-patient subject variability, and the challenges that are posed by people with asthma, COLD, smokers, and carcinogenic potential, as well as the problems of the product itself, especially if you're in a humid climate like Singapore. Does that change absorption? And so far, through the lungs, you've not had any long-acting insulin, only fast-acting insulins. Similarly, through the nose, fast-acting insulins, through the mouth, fast-acting insulins. So I talked about the basal insulins because without an effective basal insulin, you're not really reducing the number of injections and pokes, even if you have these alternative fast insulins. So how about nasal insulin? Actually, surprisingly, this thing is over 25 years old. And actually, the Novo Nordisk people tried doing this in the 90s. They use a lecithin-based enhancer. So lecithin is something that we use for non-stick frying. What was the issue? The side effects included transient nasal hyperactivity, pruritus, sneezing, rhinorrhea, and the chronic persistence of nasal crust. Now, actually, it had very good absorption, a lot of very, very good safety profiles and and there's an interesting article in 2021, which says that, in fact, administration of insulin nasally might help not just to control hyperglycemia, but there is a reported improvement in cognitive function, human memory, and also perhaps maybe in the prevention of things like dementia. Okay, so why aren't we hearing much more about this? I think sneezing, rhinorrhea, nasal crust, that might be a barrier to entry for a lot of people. But I think this is a space that we should watch, because in the elderly, if you can tell me that firstly, you can just squish the insulin and then you might actually help my cognitive function besides my blood glucose, maybe that's something that people will be thinking about. How about iontophoresis through the skin? Yes, there was some articles about this. You can look it up yourself. How about rectal insulin? Do you know that people actually tried to give insulin rectally? And we can give anti-epileptics rectally. We can give analgesics rectally. Presumably, you can give rectal insulin as well. But for some reason or other, it hasn't really caught on. Wonder why. How about a freezer? Okay, so a freezer is actually one of the remaining inhaled insulins on the market. We all know about 15, 20 years ago, there was a lot of buzz on the market, and many people were talking about inhaled insulin, but it was not really a commercial success because of cost, and also because there was a worry about acute bronchospasm in those with chronic lung disease, and there was some concern about whether there might be oncologic issues. But the other thing is that 1 unit of a freezer's insulin can cost as much as 20 times the price of other rapid-acting insulins. So, and this is at American prices. So if you think about it, maybe this is also an issue that will make adoption a problem. How about the smart insulins? So you've got these mannose-linked insulins, and this is a concept that mannose-related insulin analogs can lower glucose in a glucose-responsive manner. So not only are you talking about potentially giving a non injection parenteral insulin, but that this insulin might actually be able to release more of itself when the blood glucose is high and less of itself when the blood glucose is lower. Okay. You can also talk about oral insulins, and there's some development in this area, because the trick is to be able to protect the insulin while it is passing through the gut, and then increase absorption through the mucous barrier of the GI tract. Okay, and there's been a lot of development in this area. People talk about putting it in a muco-adhesive polymer. So you protect it from stomach acids and enzymes in the polymer, but once it reaches the mucosa, there's again something special about this polymer that is muco-adhesive, so that the insulin has time to diffuse through. Okay, so one of the words to one of the names to think of is Oramed, and you can read about them. Okay, so how about the insulin patches? So the insulin patches using the polymeric matrix, where you actually use chemical complexes to induce swelling once the insulin is actually passed through the skin barrier, but because it's actually through a skin patch, lots of little microneedles, you don't feel it as painful. And then when, according to the levels of glucose promotes the insulin release from the polymer. Again, something you can read about, it's just come into the news. How about automated insulin delivery devices? And we usually think about the pumps. There are about 600,000 pump users worldwide in 2021. But I was actually asked to talk a little bit about implanted insulin pumps. And actually, this is not new. It's been discussed since the 1980s. There's this venerable implanted insulin pump from Medtronic that was in many of people's slide presentations in the early 2000 era. And it's actually implanted underneath the skin of the abdomen, but there's a catheter which delivers the insulin in through the intraperitoneal space. But the problem is that there has not been a lot of development in this area. Only 4 people in the US and maybe 450 people worldwide are on this as of now. It went out of production in 2020, and it uses U400 insulin, which is not very, very common. But the new thing in this market is that last year, Medtronic has just bought a whole bunch of intellectual property from the same foundation that actually sold them the technology for the current line of insulin pumps, right? And this is a new set of implanted insulin pump technology that will be MRI compatible, that can actually detect occlusions. It's smaller than before, and it's got more precise delivery of insulin because the electronics are now better 20 years down the road. So I think we have to watch this space. There's another also European development where people have been trying to figure out, maybe if you can have a pill that it can actually deliver insulin into a pump that's implanted inside your body, that might be good too. So far, they've only tested it in pigs, but again, this is the PIL-SID pill-sit device. Watch this space. I think it's important for us to actually just consider what is the current state of the art technology, and that's the Minimid 780, which has got algorithms that help us bring the blood sugar down to about 5.1, 5.5 millimoles per liter. And not only that, but able to do this such that it only exits auto mode once a day, once in every 4 days instead of once a day, and by doing corrective boluses. So in order for a parenteral non-injectable device to reach this kind of accuracy, I think we have to bear in mind this is the bar that we are at. The Tandem T-Slim, their competitor, that's another thing which can be used with the Dexcom series, and their thing is 0 finger sticks. So again, you have reduced pokes simply because you have 0 finger sticks. Now, what if you don't want a pump? What if it's too expensive to buy a pump? So you've got the next level of insulin pens that now talk to your CGMS, that now talk to your smartphone, so that you can integrate information and make better decisions on how to give insulin doses. And here's your Medtronic one where they've actually put it into a product. The algorithm is now on a phone. Their pen also talks to the phone. Okay, and I talked about those people who don't want to give themselves a pump, but they also don't want to inject themselves so often. So you inject your pen into a pot, which has got a terminal and not so dissimilar from the way that our infusion sets work in insulin pumps. Okay, so with that, I end. I think I've just run out of time, but it's just a quick overview of the technology available, how we must actually not look at just one of the developments in this field, but how sensors, AI, delivery devices, new insulins have to work together with the aim of reducing number of injections, pain of injections, and overall burden of treatment. Thank you.
Thank you so much, Dr. Lee. It was indeed fantastic to listen about all the alternative delivery systems for insulin. It's always very intriguing to us, to be able to understand whether in the future these all will be, having some kind of potential to be into the actual market and for us to be able to prescribe them. Just one quick question, if I'm allowed. What is your take on the insulin capsules that are coming out or are in the pipeline?
Yeah, so those are the insulin capsules that are going to be coming out. They're ways to again protect the insulin from the stomach acids and yet improve the absorption into the gut. I think what will be the big constraint here is the ability to get very fine-tuned dosing. Things like a freezer, for example, one of the reasons why it didn't work very well is that you needed a very cumbersome system. You needed several capsules or several dose portions, and because to get the relevant dose, and because it was so expensive, you still needed a basal insulin. So I understand you're a pediatric endocrinologist like me. So for our patients, is that really practical? And if you consider American pricing, vis-a-vis the rest of the world pricing, vis-a-vis the buying ability, I mean, the consumer ability to pay, even if you talk about pricing for third world and first world countries outside the United States, is it really practicable within the next 10 years? But who knows?
Can we take the questions now after all this talks? We'll have 15 minutes for that. Can we have?
Yeah. Sure.
Sure. Thank you. Thank you so much. Thank you, Dr. Lee. I think we'll move on to our actual Indian leader and a very, very dynamic endocrinologist and diabetologist from Thiruvananthapuram. Dr. Jyoti Dev sir is the chairman for Jyoti Dev's Diabetes Research Centers from Trivandrum. He's the editor-in-chief for the International Journal of Diabetes and Technology that we all look forward to for putting our papers into. He publishes a GEMS newsletter every month almost, and we look forward to that also. He is the first author to a lot of Indian guidelines on vaccination, on insulin pumps, and he's our very own Indian, dynamic person leading us from the forefront in technology. So with that, I'm going to request sir to, take over the digital stadium.
Thank you. Thank you, Dr. Dhruvi, for the kind words of introduction. Long time we met. So I'm planning to come to Ahmedabad to meet you.
Thank you, sir. Sure.
And hello, Amit. And hello to my co-speakers. Both of them are good friends, Dr. Varenly and Devinci. So I am given a very special topic. So I will start sharing my slides. Hope it is visible now. Thank you.
Yes, they are, sir.
So I am given the task of discussing the non-invasive glucose monitoring systems. So you may be wondering why this topic, since none of these are currently commercially viable or available. But as Dhruvi said, this is a forum where we are going to discuss on those technologies which are probably not available, but will be soon available in the market. There is a difference between treatments and technologies. So when you discuss about treatments in diabetes, if you have a time-tested treatment or a medication for diabetes, it is here to stay forever. However, with technologies, it keeps on advancing. It keeps on improving. And this happens with glucose monitoring as well. Glucose monitoring with Benedict's reagent, it lasted for almost a century, almost 100 years. And now we are using these glucose meters and continuous glucose monitoring devices, and we are also using the automated insulin delivery devices, as we have listened to the previous speaker, Warren Lee. So these are my disclosures, nothing to disclose about this lecture. So how can we forget Glucovage biographer? I still remember lecturing on Glucovage biographer back in 2005. I have a passion for history, and that is why I included this in my lecture. Glucovage biographer, if somebody is asking you, this is the world's first and still the only US FDA approved device for non-invasive glucose monitoring, automatically capturing the glucose levels without any bricks required. But this is a very unfortunate story. It is a story of a failure. Look at what animals did. Animals life scan, they thought this is a panacea. This is the end of glucose meters, and they decided to purchase the Cygnus in March of 2005 through a $10 million deal, only to recognize that this results in skin irritation. It is insufficient in its accuracy. Not only LifeScan burned their fingers, the device also burned the skin of many, many users, because this can result in burning of the skin. And within a few months, US FDA decided to recall the device. Still, I believe, even though this is a story of failure, I still believe that this will have a position. This will have a position whenever we are discussing non-invasive glucose monitoring technologies. Remember, the Apple Watch, which we are using nowadays, 2 decades before Apple Watch was launched, Glucovage biographer was launched with multiple sensors to monitor the glucose levels. So we should never forget this technology. So let me now share something very personal, and this is something which is still kept in preserved in my diabetes museum. And this is the first glucose meter which I purchased for my mother, the Ames reflectance glucose meter. That was in the early 1990s. And this is, of course, the first CGM device. The CGM was gold from Minimum Medtronic, which was launched officially in India in 2004. And this is also kept in our diabetes museum. And this has been the story of the evolution, how all these monitoring devices evolved from the first to the second to the third generation of continuous glucose monitoring, and to the fourth generation of the non-invasive monitoring, which we are going to discuss today. So I would admit that most of the devices that I am going to discuss, more than 24 devices are there in the pipeline. Only 3 or 4 of them are now available commercially. But I don't think none of them are reliable enough for a clinical use. But still, we are dreaming for accomplishing non-invasive monitoring. The reasons are multiple. It is costly. You have to have a recurrent expense. If you are using a non-invasive monitor, there is no recurrent cost involved. But if you ask a patient, why are you not monitoring as per the recommendations from your doctor? The most important reason will be the pain of monitoring. Pain of monitoring. That is the most important, I would say, the deterrent factor for patients not to adhere to a structured monitoring of glucose levels. And of course, rarely it can lead to infections. It is time consuming. You have to carry around all these devices. And hence, the non-invasive monitoring technologies have become, currently it has become an international research topic. And if it is going to be successful, I'm pretty sure that this will be successful in the coming years. This will bring a vast relief to, it will bring a relief to millions of patients, millions of people with diabetes all over the world. So let me start my discussion introducing a device which I have purchased a couple of months back. And this was introduced to me by a patient, a person with diabetes in a neighboring country. And then I started inquiring, and then I stumbled upon a website, and then I could purchase it online. I tried to contact them, but there was no response. We actually, the organizers, we all tried to contact us for participating in D-TechCon, but we didn't get a response. And they claim as if this is the world's first patented high-tech non-invasive device for glucose monitoring. And you have 3 modes available. So you can see the device. So this is the device. And there are 3 modes available. One is normal, the second is pre-diabetic mode, and the third is diabetes. And they have actually made a statement that this should not be used for type 1 diabetes. So obviously, this is not a reliable meter, but it is pretty very fast. Within 15 to 30 seconds, it will provide you with the result. And you require only 2 3-year batteries. But I would say that this is very expensive. I have paid 30,000 Indian rupees for an online purchase of this meter. So it is very, very expensive, but it consumes very low power. One battery will last for almost 1,000 tests, easy to carry. There is no need to carry any needle or pen or lancets or alcohol or cotton. And this is how you have to test. You have to wash your hands with soap and water, and then you have to place the thumbs and fingers over the sensors. I will show you a demonstration video where I am the person over there. I am a person with pre-diabetes. So I have checked my glucose in the glucose meter. It is 135 milligrams per deciliter. And this is 1 hour after the food. And now I am going to check with my E-Test Us, which is a non-invasive glucose meter. And there are 2 sensors at the back and 2 sensors in the front. You can see that. And I am touching those with my thumbs and index fingers. And you should not be using the tip of the finger, you should be using the surface. And you can see that the reading is almost closely matching, but unfortunately, when I repeat it, after a minute or so, there is a difference of almost 30 to 40 milligrams per deciliter. So obviously, this is just a prototype device, not for a reliable clinical use. So how do you classify these devices? So the monitoring devices can be invasive, non-invasive, or it can be minimally invasive. And all these devices are currently available, and the non-invasive are the ones of interest to us. And many, I will say that more than 25 of them are now in the pipeline, undergoing clinical trials. So if you ask me, what are the advantages? The advantages are multiple. No needles, no prick, no blood, no test. But I would say that if I go back to this device, you can see this in my video, there are no test strips. There are only 4 sensors. And I need to replace these 2 batteries. And that's it. That's it. So there are no recurrent expenses for the sensors or for the glucometer strips. And it is very, very convenient for me to carry around. So the ultimate benefit is going to be cost saving for the person, in addition to relief from pain. So we are all doctors, not supposed to discuss the methodologies, but I believe that when I'm discussing about non-invasive monitoring, we should have a basic understanding on how we are capable of measuring the glucose non-invasively. So broadly, this can be divided into optical, microwave, and electrochemical methods. And the optical methods could be near infrared reflectance spectroscopy, that is NIRS, polarized optical rotation, Raman spectroscopy, fluorescence, or optical coherence tomography. So these are the multiple optical methods. And then you have the electrochemical glucose biosensors, 1st, 2nd, and 3rd generation. 3rd generation will have the direct glucose oxidase electron. So I will briefly go through the optical methods. I will discuss only one, and that is a Raman spectroscopy. I still remember in one of the ATTDs 10 years ago, there was a demonstration of 1 or 2 devices based on Raman spectroscopy. It was once thought to be very, very accurate. And this is based upon the principle of scattering phenomenon of light. And it detects the fundamental vibration of atomic groups. But unfortunately, though it was supposed to be accurate, when it's tested in human beings, there are differences in the skin tone. There are differences in the level of hydration. There are differences in the basal metabolic rate and the skin thickness. And this results in variability in the glucose levels, and hence couldn't be replicated in the real clinical situations. And when you are overall discussing the demerits are much more than the merits of all these optical methods, which are cumbersome, requiring sophisticated devices and large interference of background signals, also limiting the use. And when you are actually getting a glucose value, again, you have to correct it with the help of algorithms. And hence, clinically, it was found to be not viable. So let me now move on to another area, and that is based on biofluid, measuring glucose from the biofluid. So I will have the discussion of the saliva, because saliva is the easiest to collect, very easy to extract, because I know that I have done a genetic test also based on saliva. And there is a good correlation between the salivary glucose and the blood glucose levels. And in addition to glucose, you have lactic acid, phosphate, there are many enzymes for digestion, there are steroids, antibodies, etc. in the saliva. The tear, another rich media. There is salt, there is protein, there is less of impurities such as bacteria in tears when compared to saliva. And there is also a positive correlation with the glucose levels. Sweat is another media, a very hot media, possible for measuring with a wearable device such as seen in this picture. And you can even combine this with a CGM or with an intelligent closed loop system. This one has been very popular in the news. I remember until 2 years ago, we have been actually anticipating the arrival. Google and Novartis, along with Dexcom and other major players, were actively involved in research on having a contact lens based. And this is also dependent on a fluorescent light to monitor the glucose. But unfortunately, the results were disappointing. And the contact lens based glucose measure, and this also has faded out. So unfortunate. So I'm so sorry that most of those areas where I'm discussing today are non-invasive. They have been tested, they have been in the clinical trials, but found to be unreliable, insufficient reliability for clinical use. And moving on to tattoo-based, non-invasive. And this is also part of my title of the lecture. Tattoo, as seen in the picture, is easy to wear. And this can, this is based on a reverse endophoric extraction of interstitial glucose along with enzyme-based amberometric biosensor. So this is a schematic representation over there. You have a iontophoretic sensing system, and this is a tattoo-based paper. And you can see the silver electrode, the pressure blue electrode, the transparent insulating layer. And this is a process starting from diet and then how it is measured and how it is, the glucose is detected. Moving on to another major player in the market, the Diabetic. And they have come up with easy solutions. Only a couple of seconds to measure the glucose levels, fast, painless. And all of them are claiming that this is cost effective. Of course, it is cost effective because there are no strips involved. There is no recurrent expenses. And there are 3 different products which are in the pipeline from Diabetic. And this is a D-base, D-pocket, which I can carry around similar to, it looks very similar to a mobile phone. And then you have a D-sensor, and this is similar to a wearable device. So despite all those advantages that I have discussed, the demerits, the drawbacks are much more for these biofluid-based sensing mechanisms. In saliva, there are innumerable impurities and interfering substances, including bacteria. In tear, there is poor precision. All of them, they are hysteretic. In sweat, if the person is not sweating, then you may not be able to measure. And ISF, again, skin irritation. So probably these are not providing the reliable results as expected. So moving on to non-invasive continuous glucose monitoring system. So until now, I have discussed some of those promising results and devices for non-invasive glucose monitoring. And these are non-invasive CGM devices. I will probably showcase only a couple of them. Many are there in the pipeline, and this is G-Wave. Why is it important? Last year, the US FDA has granted a fast-track designation for this device. The sensor is inserted. You can see this in the picture. The sensor is inserted in a ceramic lightweight, a very comfortable bracelet. So it is again in the form of a watch worn over the wrist. And this uses radio frequencies to measure the glucose levels. So most of these guys, Graphia, Movano, My Sugar Watch, D-Sensor, all of them are actually using the watch as the wearable technology for measuring the glucose. And the similar ones are from LifeLive, the Afan watch. This one is different. Novio Sense is different. And this is a sensor which is placed under the lower lid. And this can wirelessly send glucose levels directly to the smartphone app. So almost all of them you can see, they're all wirelessly connected via Bluetooth to the app in the mobile phone. And some of them have AI, some of them have predictive algorithms. So similar to the CGM that we are currently using, they can also provide you with predictive glucose levels and can get connected to the closed loop systems. Sugar Beat is another one which is commercially available. But this one is different from the other sensors that I have discussed. And this is a UK-based Nemura Medical approved for use in the US, approved for use in the Europe, not in the US, sorry. And this is a small peel and place patch. And this need to be replaced once in every 24 hours. So there is a recurrent expenses involved in this adhesive-backed rectangular transmitter, and this sends wireless readings to the smartphone app via Bluetooth every 5 minutes. So now moving on to an excitement, and this is an exciting innovation from India. We tried to contact them too. We tried to email them, but there was no response. And this is the news which has appeared all over in the visual and in the print media across the country. So if I need to be convinced, of course, this is Blue Semi, and we are not aware of any clinical trials that they have conducted. They claim that they have conducted clinical trials, and they claim that they have published the data, but I couldn't find any publications. But they have showcased this product and they have officially launched at the CES convention in Las Vegas this year, early this year in 2022. If we need to dig into the depths of this device, it is an innovative patented technology leveraging sensor fusion. There is intelligent artificial intelligence, very accurate algorithms, and smart Internet of Things. And this is again with the help of multiple sensors. More sensors are there when compared to eTouch US. And this is how it can measure 6 vitals. So this can measure 6 vitals within 60 seconds. Apart from glucose, electrocardiogram, heart rate, blood pressure, SpO2, and temperature. So it looks very, very exciting. And this is the screenshot from my own Apple phone. The Apple Watch measuring the activity, the SpO2, the ECG, the activity, the sleep with auto sleep, even VO2 max. So everything is now possible with Apple Watch. And I would probably believe in non-invasive glucose technologies to be reliable enough for clinical use when Apple introduces this in Apple Watch, because there is a rumor for the last 3 years that Apple or Samsung will be introducing this in the wearable devices. And I believe that this is soon going to happen. And that is when it is reliable enough for clinical use. So why have we included non-invasive glucose monitoring in D-TechCon today? And this is a reason. The experts believe that there is a potential for these devices to make it big. And the industry analysts believe, and they're predicting a booming market, a very booming market for non-invasive technologies in diabetes in the next 5 years. And here I stop. Thank you very much for the patient hearing and for the opportunity.
Thank you, sir. It is actually beyond interesting to listen to all the newer technologies and the non-invasive monitoring systems that are coming up, and which, every new day, I think we have newer and newer things to learn from. So I think we'll take the questions in the end, and let me move on to introducing our next speaker, Dr. Jibin Chi from Sweden. Can I have his CV on the screen, please? All right. Dr. Jibin Chi is the principal CHI Awakening Academy and a president for the Channel Biomedical Group. He is the managing director, Asia and Middle East, Mercodia AB. He's the vice president for Society of Harmonic Science International, and he's also board member for Happy Years AB. So I think he's got a very vast experience in specializing in translational medicine and trying to bring in innovation and connecting it with scientific advancement into the scientific medical community. He's a Dutch citizen, Chinese origin, and a resident of Sweden. So he's a multinational and an international faculty across across the globe. And he's got a vast experience in the field of diabetes. His new disruptive theory on diabetes and disease development model are in direct challenge to the century with a long definition and strategy on diabetes. So I would request Dr. Jibin Chi, sir, to talk more about the CHI fractal bioanalysis on mind and body in diabetes and beyond. So with that, over to you, Dr. Chi.
Thank you very much for the introduction. And all right. It's really a great pleasure to be on this platform to share my topic with all those great speakers and doctors. So without wasting much of time, I would like to continue this session with my topic, talking about a particular way of analyzing the body and mind connection in diabetes and also beyond. So I start my talk with a reference Nobel Prize winner Niels Bohr. In 1932, and there was an international congress on light therapy, and he was invited to give a talk. And in this talk, he talked about science and life, and he raised up a very challenging question. His question is about whether there's something fundamentally missing in our understanding about life because of the limitation of our human physics. Like the vision we have, the smell we have, the touch, the sense, all these things. And his question is extremely challenging, but it raised up a very interesting research area for someone. Here is the Dr. Diabetic. He was a physicist. And because of Dr. Bohr's topic, he started to look into biology. And because of his work, we actually started to understand the fundamental information structure in the virus. And this is actually the beginning of the modern, let's say, molecular biology. And later on will lead to the discovery of DNA. And today, matter is already considered at the fifth stage of information, considered at the fifth stage of matter. So if we look at it from a computer we use to our own body, DNA, everything is about information. And if you look at the future medicine today, we already see AI, everything. So the future of medicine is electroceutical and AI technology, and the future is today. If you look at diabetes, what is the fundamental challenge? After 100 years, our diabetes still focuses on the matter of insulin sugar based. And this is the reality today. Just look at type 2 diabetes. We have a long delay if you look at the tissue damage over 15, 17 years. And again, 50% undiagnosed type 2 diabetes. And our focus still is focusing on glycemic control. And the more challenge is when it comes to managing a single disease, we require multiple disciplinaries to involve. And the so-called integration is actually is a more difficult challenge. And today we understand the mind-body connection. We also understand the childhood experience, how they change our biological and behavior mechanism. So this also leads us to the new science called psychoneuroendoimmunology. But bundling is not true integration, unfortunately. If we don't change our view, we cannot change our destination. So the way we practice medicine is basically we use hundreds of medicine to treat one disease. But the truth is, we should use one medicine to treat hundreds of diseases. That's the wisdom of medicine or true healing. And that is also, is it possible that one doctor can realize true integration in his one own clinic? So if you go back to information, life is not biological, it's informationally stated. Everything we matter behind that is invisible information system. So here is the world of fractal. So from Indians Surya Yantra to the Chinese yin yang to the nature to our own body, everything embedded so-called golden ratio, mathematical algorithm. And this is also same with our body, everything in the same algorithm, one fundamental algorithm. So the so-called fractal is fragmented. Fragmented structure, the most important dependency on initial condition. And this is the true benefit about understanding in medicine. So this is so-called a butterfly effect. So a butterfly flaps wings in Brazil instead of tornado in Texas. So by understanding the influential factors, we can predict and look at the outcome, the consequential consequence in health. So with this, we can truly understand the systematic information is not limited to the physical body, but really mind, body, energy, everything all connected. And it's about one for all for one. And today, fractal in medicine actually long been researched, and even in diabetes field have been applied. So this system I'm talking about has fractal and also heart rate variability, stress theory, and neurodynamic algorithm. So this system is very intuitive software. It just takes about 5 minutes, and you can measure the bioenergy and the biodynamic, and also have diet recommendation, Indians Ayurveda dosha analysis, and also have a healing, with sound healing and breathing exercises. So just briefly, what it is about. The pulse we measure in medicine is applied in all different healings, including Ayurveda. So our heartbeat is actually a black box of all different rhythms. So by looking to the fundamental rhythm, the stroke and overtone, and basically create a binary coding system. And with this coding system, we will be able to calculate how the energy transferred in a body. So to make it easy to understand, you see, we are all energy. So if we are follow natural way, we are healthy, the rhythm we have should be same as the rhythm of nature, like so-called golden ratio, Fibonacci sequence. So now, that part of the introduction just briefly goes through what it's about. And now I want to go through specific case, look at how it can change our understanding about diabetes or other diseases. So here I started with one example, a diabetes patient, type 2 diabetes. So first, look at generic picture, what we can get. See, here I'm showing 4 parameters. One is looking at the heart, the cardiac adaptability, and one look at autonomic system, and one look at hormone, one look at the brain. If someone is healthy, he should be 100% according to the nature algorithm, so that should be 100%. But if we deviate from the nature pattern, that means his condition is not optimal or not healthy. And you look at this person, we can conclude to see there are a few things there: heart, hormone, and autonomic system, particularly all in red. The only a little bit better one is the brain in the reddish, that's normal status. But a really good state, according to nature, is green. There's nothing green here. And also, you can see his heartbeat is very hard, very fast, and overall, the condition is very low. So from here, we move on to how's this person brainwave. And this brainwave you look at, it shows this person have ADHD brainwave. So what is ADHD? Today, with a lot of discussion, fundamentally, is activation of right brain or spiritual intuitive brain. So that person has a large, let's say, huge subconscious connection. So I think, we probably all know about the left-right brain differences. The left brain, logical brain, per second, we can do about 40 things at the same time. The right brain, we can do 25,000 things without a conscious understanding. So this is why this is the fundamental root cause of this person's physical condition. He's extremely stressed and his hormone level is high. So because the brain extremely active, and it also makes it very difficult to go to sleep and vulnerable to mental problem. And this also gives him another benefit, that this kind of person, they are multitask oriented. So they simultaneously doing several things. So that's why they cannot focus. Now, next I move on to look at the brain and how it connected with the body. We look at a circadian rhythm. Circadian rhythm today already being, reviewed scientifically. There's a Nobel Prize winner that our body is basically a biological clock coming with the natural energy. So what is showing here, you see, the energy pattern in the evening is high. That shows this person at night has more energy. So this is very difficult to sleep. And this is also because the mind is managed by heart. So his energy at heart is low. And same time, if you look at the other end, where its energy related to liver, gallbladder, is quite active. So normally when you have energy high, it's good, but unfortunately here it's not, because the liver is connected with sugar, like we talk about glucose. So that means this person is using sugar as main source of energy. And at the same time, you also look at the emotional connection, mind, let's say the brain-gut connection. So you see his problem, physiological problem, the large intestine, small intestine, all relate to detox. So he has a problem with the detox. That's again, it's not because the gut started a problem. The gut and mind and the brain, they are connected. And the mind already talked about it, that he has a very busy mind. And next thing we move on to look at how it's connected with energy. And here I'm showing the image looking at the connection between the chakras and the meridians. So you see the highlight here is the blocked heart meridian and small intestines. So this shows emotional connection with the mind, the heart, the mind, the connection. And if you look at the chakras, and for Indian, I think we should be very familiar with the chakras and meaning to relate to the different stress from mental to the emotion to immune stress and communication. What is interesting, again, you see, here I'm showing the chakras, the third that manipulate. Normally, we say high energy is good. I say, no, not here. When it's in balance, particularly strong on third chakra, it shows someone very active with the pancreas or liver, particularly liver. So that once again, I point out that this person is using sugar as a main source of energy. And this, we can connect the dot. So mind, see, we talk about diabetes so often. See, I always ask a very simple question. Why we use so much sugar? Where the sugar goes? 60% of sugar supplied to our brain. As someone has such an active brain activity, so will he use a lot of sugar, particularly when you cannot sleep at night, you go to bed late, so even more active trigger the use of liver energy. And that's where the fundamental set off of the diabetes. So in conclusion, the root cause of this person's diabetes is actually because the brain pattern is lifestyle is secondary. So subconscious mind determines what you eat, what you do, and there also emotional blockage. And his problem is not about diabetes, sugar, it's about mind, heart, and the liver at high risk. And we also know that 70% of people die from cardiovascular disease in diabetes. So now I move on to the next example. Here we have extremely obese female, very young female patient, and he's supposed to go on to bariatric surgery because of too much weight. So here, again, let's start with the mind. It shows the same active pattern of previous patients, the diabetes patient. So very active subconscious connection. But what even more, this person, she has another trait. Clinically, we call it so-called autistic or Asperger or ultra-sensitive. What really it means? It simply means such a person, they're active both at the same time, left and right brain. The logic and intuitive mind work at the same time, so create internal conflict. So this person's brainwave tells everything about her eventual outcome with weight and loads of other things. So similarly, we move on from the mind, we look at a connection to the body. Here, same pattern. This kind of person, very difficult to sleep. At night, the subconscious, intuitive mind become active. So they are very difficult. They are very creative at night. So that's one thing is fundamentally disturbing. And second, again, similar to the previous diabetic patient, this obese individual also have a very active liver and gallbladder. So that's, again, related to the problem that is, one is sugar use, going to be a lot. Second, because she sleep so late, because active, so there wouldn't be a proper detox in her body. And that again, link the similar thing, the mind, and I see the brain-gut connection here. So emotionally connect to the digestion and detox issue. So her metabolic problem, again, relate to the fundamental issue with the mind. What is more, when we look at the chakras and meridians, we can see more information here. Particularly, I want to point these two connections here. You see, in the chakras, the heart chakra is the lowest. And then in the other side, the meridian, the heart meridian is lowest. So these two connections, again, point out the same thing, the energy imbalance. And her main problem, the risk, is actually cardiovascular risk because of emotion. What's even more, because of such active mind, she has a lot of mental stress. That's another hidden issue. And next step is looking at mother connection, mother relationship. When I did consultation to this person, the moment I start open my mouth, the tears just pouring down. In 20 minutes talk, she hasn't stopped with crying. And when I talk about her mother relationship, mother was sitting there and she just cried even more. Because this kind of person is extremely sensitive. And the child is mother. Mother is nature of water. The second, sacral chakra, is a water element. So that is a strong link related to the physiological condition. And again, same outcome, strong indication of active liver because the manipula or the third chakra, navel activation. So the conclusion here, again, the brain patterns, the childhood impact, social stress, all this, and in the end, she confessed. The way she changed her diet, everything started around 6, 7 years old. So that is just quick going through diabetes and metabolic, and now move beyond diabetes. What I'm showing here, this is the absolutely 100% according to the natural pattern. Someone is healthy, everything 100%. What is a complete unnatural? Cancer. Just look at this profile on top. Cancer patient, typical cancer patient, is almost everything is only 1%. Some even have a 0%. And this another 1%, 2%. Typically, it's just to say in 5 minutes test, without doing anything, you can identify someone already. This is a cancer patient. And another I was showing to share with everybody about another powerful combination is the chakras and meridian. In this type of patient, someone have very strong heart chakra. That means he's a very giving person. And that has a lot of love nature. But when it comes to meridian, it's energy provided to yourself and they lock themselves. This emotional contradiction is very often found in particularly breast cancer patients in female or a cardiovascular problem in male. And just with this test, I've identified people with breast cancer, brain cancer, bone cancer, colon, kidney, prostate, stomach cancer. And beyond that, also look at a relationship. So many people that I come across have tears. That's something they have never been told by anyone else. Just by looking at their chakras, energy, brainwave, I can understand their relationships in childhood with their mother. Another thing, talking about biofeedback as therapeutic intervention. What do? Do we really making change, meaningful change? So it has a biofeedback, look at a change before and after. And this is showing a cancer patient profile before and after the energy change, the brain change. And similar things, showing the same change. Another thing very important, today we so often give a consultation, but not everybody understand at the same time, and also their brain status not same time. And also in India, I know a lot of diabetologists and specialists encourage people to do yoga meditation, but how are they doing? We don't have a tangible measurement. Here, we can show exactly which state is the individual at is. So this has two implications. One is if someone practices yoga or meditation, you understand the state of mind. The other very important is actually to understand the patient's emotion, you can tailor your consultation to that particular mind setting. If someone in a subconscious mind, like the right brainwave, a delta wave, this is typical, you can link to emotion, link to imagination, visualization, and they respond extremely powerful. If someone in the right brainwave, that is beta wave, for example, and this typical like logic, so medical analysis could be very interesting. So here I just quickly wrap up this presentation with a short, 20 minutes. I like to quote someone, Albert Sangiorgini. They say, all life are the same tree of life, but the different leaves. The different functions we specialize, just manifestation of the same living matter. So we adapt to different jobs, different circumstances for the same basic principles. So in principle, it wouldn't matter whether we study nerve, kidney, or muscle to understand basic principle of life. But in reality, it matters a great deal. And this is the reality today we are facing. Today, just talk about diabetes, wonderful diabetes technology progress, yet every 5 seconds, one person dying from diabetes. And today, there's an even huge population grow into diabetes. And I think that is the same thing that we have to look at again, have to change our view before we really truly make a meaningful change to our destination. Thank you very much.
Thank you so much, Dr. T. It was wonderful to listen about the CHI fractal bioanalysis. If I'm pronouncing it right now I can, connect that it is the CHI fractal bioanalysis and not the CHI. It was wonderful to listen to how you're connecting the mind and body and how we are going beyond the, metabolic parameters. It's been wonderful. Can I request the organizers, if we have some time to take up some questions for Jyoti sir, for Dr. T?
Absolutely, ma'am. Ma'am, we have our next session at 6:30, so we can have some time to discuss. if we have any questions.
So I think that there aren't any posted questions right now, but it'll be very interesting to, listen a little bit more. I have just one question. Dr. T did actually elucidate a lot about the chakras and how can you, study the brain waves, and is it practiced so widely? We've been hearing this in India. There are a lot of doctors who are trying to recommend that you align your energy and your auras, and I think the studies that you showed go deeper and the analysis goes deeper. But if you have to put it into some simple words for our audience to understand right now, Dr. Cheek, could you just try and do that in a simpler manner?
I'm not sure if I can put it in that way. Just the simplest way is looking at, today we're looking at diseases, we look at the outcome of the tornado event. But we understand the butterfly is about the flipping wing. And the flipping wing, we look at it, physiology of the body. It's just mathematically, we follow the same pattern, we are healthy. So this is how the energy is connected. So our brain started energy. Let's see, the mind connection to the body is just, if you look at the algorithm of nature, you find the link. And there, one thing today, this is difficult to outline. The way I've been working today is really, I work in different fields, and particularly in psychology, not in diabetes, I created this kind of tsunami, but also in other fields, spirituality, also in psychology. Today, we look at diabetes patient, how many people have mental issue? We always use the counseling. As an Indian, we know the logical mind is here. The intuitive mind is here. That's actually the root cause of it. So unless we go into the deep there, we cannot solve the problem. So that's why to understand truly the mind-body connection is so essential.
Thank you so much. Thank you, Dr. T. I think a lot of us are moving towards that direction wherein we say that you have to take care of the mind and body both together. Any other questions from the panelists, from the organizers over here?
Yeah, Dr. Dhruvi, I would just like to make a comment here. Dr. Warren Lee talked in detail about all the newer insulin technologies and therapeutics, and the talk was really wonderful. He actually took us through a journey of development of the insulin and what exactly is there. And we are very grateful to Dr. Jyoti Dev sir, who, despite having a medical emergency at home, he is still committed to this session. And he presented his talk, and it was really enlightening to see all of the devices. To be very true, I was not aware of that first watch which you just showed today. We just thought it is just the Apple which has launched this kind of things, but only you gave us the insight that the technology is so advanced that it was already there in 2005. So thank you, sir, for that wonderful talk. And Dr. Jibinchi, it really comes as a surprise to me, because you have talked about those things which we talk about, the Indian system of medicine, so many things about the Ayurveda, the mind and the body and the medicine, and the way you are trying to analyze, because we respect all the views, because ultimately we are doing it for the betterment of the science, and whatever you are doing is also one of the alternatives. I think it is, with more evidence, it is going to be accepted more and more. So wonderful talk. So these are just a few comments from myself.
Jyoti sir, if we should look forward to something in the coming few months or coming few years in terms of non-invasive monitoring, what should we be looking forward to most?
I am glad to let you know, Dhruvi, Amit and my friends, there are a few startups in India also. And there are a couple of young boys from some IITs in India working on non-invasive monitoring. And some of them are working with the wearable socks with multiple sensors. So we wear a socks, and the socks is continuously monitoring the glucose. And according to them, it is very, very cheap. Very cheap, and the battery is going to last for more than 1 year. and no recurrent expenses at all. And some of them are also developing a small patch similar to the size of a Libre 3. So the future is almost here. The future is almost here. Because the technology is advancing, because the technology is different from the technology which has been in existence in 2005. So what I foresee is within the next 6 months or so, because I have shown this device, which is e-touches, and the next generation of this device will be there in the market. And that is probably going to be much more accurate and reliable. So it will be there very soon, both for glucose meters and also for replacing the CGM meters. So the CGM devices, I think, will be more popular as a non-invasive one.
Dr. Jyotidev, you very rightly said, I am on the Government of India panel, which gives funding to startups, entrepreneurs. Basically, so I have seen so many Indian entrepreneurs, IITians, engineers, who have done a lot of startups in the wearables. And as you said, on one touch, they measure all the parameters, what you showed, and some more. The only major challenge is clinical validation, as you rightly said. And I don't know why I have been on their panel for last 3 years. So many of them have come. Still, none of them progress beyond clinical validation, or they fail there. And I don't know, the challenge is there. They just get somewhere synced in the clinical part. Lack of clinical validation, clinical trials, and clinical studies.
Devashish, they need to partner with doctors from the first day onwards. That is what they are not doing.
We tell them, sir.
Tell
them. There is a way for them to partner with. The Government of India has identified 8 big centers, which they have to be part of that. And then that is my advice to them. Why don't you make a diabetologist or a physician from the day one your partner in the journey, so that insight is there with you. They are just engineers. They don't understand the clinical part. They develop everything. That's the challenge.
Jyoti sir, if I can add or continue with the comment that you made. In fact, like with D-Tech, we are attempting to bridge that gap. And recently for this startup pavilion, as you are aware, we approached so many startups, and we are trying to create an ecosystem where the group of doctors, not just 1 or 2 doctors, but a whole group of doctors can be of help for these startups to guide them, and that is what we are trying. I have one question, Dr. Jyoti. Like Dr. Debashish just said, that there is a lack of clinical validation, but even with the SMBG, we are accepting that variation of 10%, 15%, which was earlier 15%. So maybe even for the non-glucosive meters, even if there is a variation of plus minus 20%, 25%, probably that would be still useful, because it's anyways not replacing your conventional monitoring. It's just assistance, or additional tool that you are having at your monitoring. What do you say, sir?
Agreed, Rakesh. The problem here is not the variability. The problem here is not just the variability. When you are repeating the same after 5 minutes or after 2 minutes, there is a huge difference. And in the same person, when you are doing it in different places, again, there is a difference. So that is the reason why all the optical methods failed. And now we are going for the biofluids. So probably there will be one mechanism by which we will be successful. As we discussed earlier, these engineers need to be there partnering with us.
Right.
Because when I am there as an advisor for a couple of them, I realized that, as Dr. Debashish said, they don't know anything about normal glucose, abnormal glucose, diabetes, or type 1 diabetes. And even for this device, they have categorically stated that never use in type 1 diabetes. And when we contacted online, they again asked us a question: are you using it for normal people or for type 2 diabetes? And there is a mode for normal. And when I am testing it with normal, I get one value. When I'm changing the mode to pre-diabetes, I get another value. And at the same time, within seconds, when I'm changing to type 2 diabetes, I get a higher value. So obviously, that means for the 30,000 Indian rupees I have paid, this is just a prototype.
Right.
This cannot be used for any clinical purposes.
And they have different algorithms for different sets. That's why your values are coming.
And Devashish, there are options for calibration. And that is a sophisticated mechanism by which we can calibrate with the help of a glucose meter. And then you have to customize, and only one person should be using it. Then probably it will become more accurate. So there are probably chances that this is going to be much more accurate in the days to come. So that is why I said in the next 6 months or so, 1 or 2 of these devices might get launched. And I believe that that is going to be a CGM rather than a glucose meter.
Right.
Because it is easier for them to develop a CGM out of this. Much more
So
easier.
your comment regarding the lack of inputs from medical doctor reminded me of a story. You would be aware of the Defeat Diabetes campaign that we did. So the data analysis was given to some guys from IT or engineering background, and they came out with finding that the best predictor for a person being diabetic is that he is on OH. So
disgusting.
So that is totally true. That if you don't take a doctor on board, you probably do the maths well, but you won't understand the logic, right? Okay, so we may move on. The chairpersons can take it forward.
Thank you. So I think we are almost at 6:30, and if you do not have any questions, I think I would like to thank Dr. Lee, Dr. Chi, and Dr. Jyoti.
Precision medicine, precision medicine, you can divide it in different.
All right. Okay. So I think if we have the permission, I would like to thank all our esteemed panelists for a very thought-provoking and futuristic session on futuristic technologies and making us to think more about mind and body as well as alternative sources or alternative ways of giving insulin along with non-invasive technologies for monitoring. So with that, I thank all our esteemed faculties over here and our chairpersons. I think I'll close this session officially and request Pratap Jethwani sir, a leading diabetologist from the city of Rajkot, to take over. Jethwani sir is MD, PG Diploma Diabetes, a fellow of RSSDI, fellow Diabetes India. He's the executive member for RSSDI, chairman-elect, the Gujarat State Chapter RSSDI, organizing secretary for RSSDI at Ahmedabad. He's the past tutor for PG Diploma in Diabetes Core from Leicester. He's the section editor for Sadiko's International Textbook of Diabetes. He's the past president of Association of Physicians of Rajkot. He's a consultant diabetologist at Jethwani Hospital, Rajkot, and is an academician with more than 10 publications and has presented numerous posters and research at national and international conferences. So over to you, Jethwani sir.
Thank you, Dhruvi.
Our next chairperson is Dr. Raka Shiohare sir. He is a diabetologist as well as a poet, a writer, and a multicultural person. He's a director of Lifeline Madhumeet Diabetes Hospital from Raipur. He's the chairman for Madhumeet Diabetes Welfare Society and Madhupraya's Diabetes Conference. He's the president and founder of the Chhattisgarh State Chapter of Indian Podiatry Association. He's been affiliated to a lot of associations, be it the IMA, API, RSSDI, DIPSI, IAS, ADA, and a consultant for non-invasive cardiology as well. He's a past joint secretary for Chhattisgarh State RSSDI, and a lot of accolades to his name, a lot of papers in international and national conferences. With that, I would like to give off the digital platform to Dr. Raka Shiohare and Dr. Pratap Jethwani sir.
Thank you, Dhruvi, for kind introduction, and I welcome my co-chair, Dr. Raka, also for this novel first ever technology World Congress from our country. I thank organizers, Dr. Bansi, Dr. Manoj, Dr. Jyoti, Dr. Amit, and Dr. Rakesh Parikh for inviting us to be part of this novel initiative so that we can understand better the use of technology in diabetes. So we all know that type 1 diabetes is a disease, chronic autoimmune disease, which requires lifelong insulin therapy. And if we can prevent it, that will be the best thing we can do for our patients. And to understand the role of prevention of type 2 diabetes, the immunotherapy, the role of immunotherapy for the same, I would like to invite Dr. Nidhi Garg, who has worked in this field, is working in the research on various targets for type 1 diabetes, so that we can devise strategies in the form of various molecules to target those molecules to prevent type 1 diabetes or to cure type 1 diabetes. Dr. Nidhi has been trained in medicine and endocrinology at India in Delhi and Chandigarh. After that, she moved to Mayo Clinic, USA, where she worked in basic sciences, and currently she is working in antibody engineering, drug discovery, designing, and testing of genetically engineered various antibodies against novel targets for various diseases, including type 1 diabetes. So she will be the best person to speak about the role of immunotherapy for prevention of type 1 diabetes. Over to you, Dr. Niti.
Thank you so much, Dr. Pratap, for giving a kind introduction. Yeah, I would like to share the screen. Is my screen visible?
No, no, madam.
No. Okay.
At the bottom panel, there is a green button.
Yeah, yeah. So then there is an advanced files, computer audio, and share.
Yes, ma'am. Click on the share button.
Is it visible now?
No. After the click on the share button, you have to click on your PowerPoint presentation.
Okay. Okay. After the share button, then PowerPoint. PowerPoint is visual background, virtual background.
No. Is your file open, ma'am? Have you opened the file? If it is open.
No. Shall I keep the file open?
Yeah. Open that.
You keep your file open, then share screen, and then click on that PowerPoint presentation.
Once you open the file, then you will get the option.
Okay, it is opened now.
Now you go to share, and then you will get the option.
Share. So the PowerPoint is virtual background?
No. First, you stop sharing first, then do it again.
Okay. So PowerPoint as virtual background?
No, not as virtual background.
Not virtual background. Madam, your presentation.
You open your presentation at your desktop, at your laptop first.
Okay, yeah.
Ma'am, you have to come to the basic.
Can you see?
Now your screen is
Now
coming.
your screen is visible.
Thank you.
Yes, it is visible. Yes.
Yeah.
So
I'm okay. Yeah. So good morning, everybody. It's morning here, and transitioning from the basics of the body, mind. We will talk about the basics of the type 1 diabetes, that is the beta cells and immunology. So it's a shift from body and mind to the basics of the immune system now. So let us start our topic, the immunotherapy for type 1 diabetes.
Sorry to interrupt you, madam, but make it slideshow.
Slideshow.
Yes.
Okay.
At downstairs.
Yeah. Right. That one.
Yeah. Now is it okay? Okay.
No.
Just click. No. First, ma'am. First, stop share your screen once.
Yeah. Is it okay now?
Go to slideshow.
No.
You can go to slideshow, madam. Below.
Yes.
Yeah.
Fourth button.
Okay,
Yes.
I will.
Yeah. No.
Yes. Click on that.
Click that. Yeah.
Yeah. Is it okay now?
No. Ma'am, once stop share your screen, and at the time of share screen, you have to select PowerPoint presentation with slideshow mode.
Okay.
So click on the share screen button and click PowerPoint presentation with slideshow.
PowerPoint presentation
with slideshow.
It is not giving me that option of the slideshow.
First share your screen.
Share my screen. Okay.
What you did last time. Yeah.
Yes.
Is it okay now?
Yeah.
Yes, fine.
Okay. So, so exploring the etiopathogenesis of type 1 diabetes is like exploring an elephant blindfolded. thousands of scientists all across the globe have been working tirelessly to understand the etiopathogenesis of type 1 diabetes. They are working on various aspects of the disease. However, I believe that we are still quite far away from the clear vision and the complete view. So today, let us try to explore this huge elephant in these next 20 minutes. So let us try to make this attempt.
I think it's still not yeah. Dr. Nidhi, can we do one thing? We can take the next talk, and meanwhile, can you email this PPT so that we can read from our end?
Okay, yeah, I can do that.
Rakesh, I think she can do slideshow from the
Just do it
panel.
slideshow.
Yeah.
Do it by slide.
Madam, in the upper panel, there is slideshow is written. If you see.
Below red screen.
Below red screen, there is slideshow.
No. Ma'am. Just stop share your screen.
Harshit, can you take over the control?
No, sir. Because the Windows version is old, so that's why this issue is right. Ma'am, go to your presentation once.
Okay.
Make it on a slideshow one. No. Don't share the screen. Just go to your presentation and make it on a slideshow one.
Open your presentation and make it slideshow as you do it regularly. Then you start.
No, ma'am. Don't share the screen before putting on the slideshow mode.
Okay, got it.
Yes, first put it on a slideshow mode, then after share the screen.
Okay, got it.
Yes.
I hope it works.
Yes, ma'am.
Okay.
Yes, now it is okay.
Okay, I'm so sorry for all this technology problems, and we are going to talk about the technology now.
Next time we'll have a talk on this one.
Yeah, I think we should learn more from the computer engineers. So
automatically.
Type 1 diabetes. Yeah, can you hear me now? Okay, let us start. So what we all know so far is that type 1 diabetes is an autoimmune condition which is caused by which leads to the destruction of the insulin producing pancreatic beta cells by the autoreactive T cells. And there are various genetic and environmental factors such as microbial infections, neonatal nutrition, and exposure to certain toxins, which is responsible for the triggering of the whole process. In 1985, Dr. Bultazzo's lecture called Death of a Beta Cell, Homicide or Suicide, posed the idea of beta cell fragility for the first time. This means that some beta cells are vulnerable to their own destruction and damage. So in 1985, we got this idea for the first time. So whether these beta cells, they are innocent bystanders. So for almost 100 years or almost all this time, we just knew that beta cells are the innocent bystanders. However, in the last few years, or maybe one decade, our understanding about the beta cells have shifted, and now we have an understanding, and from the recent research, we know that they are the equal partners in crime. So beta cells and autoimmune responses, they both equally contribute to the pathogenesis of type 1 diabetes, and both the beta cells and autoimmune responses, they are the partners in crime. So let us, with this understanding, let us now try to explore the various beta cell mediated mechanisms and the T cell mediated mechanisms in the pathogenesis of type 1 diabetes. There is enough evidence that the beta cells have an active role in the pathogenesis, because we have the evidence in the form of the lack of consistent long-term success with immune intervention therapies, the existence of islet autoimmunity in general population without the development of type 1 diabetes, and there is persistence of beta cells in patients of type 1 diabetes even after diagnosis and the progression of the disease. In normal health, beta cells, they respond to the glucose fluctuations by secreting appropriate amount of insulin to maintain the euglycemia, which is a taxing process in itself, even in healthy individuals. And in stressful conditions like inflammation and nutritional access, the beta cells, they become more vulnerable. When there is an exposure to viral infections, cytokines, inflammation, or dysglycemia, there is a cellular response in the form of endoplasmic reticulum stress, reactive oxygen species, leading to the changes in the protein formation and post-translation protein modifications, leading to altered immunogenicity, T cell and antibody responses, altered beta cell function, insulin misfolding, altered metabolism, and impaired sensing and release of the insulin, leading to a compromised, unhappy beta cell. The various cellular mechanisms are endoplasmic reticulum stress, which results from high demand for protein production and secretion. This unresolved endoplasmic reticulum stress causes accumulation of misfolded proteins, dysregulated post-translation modifications, and eventually there is oxidative stress in the form of low levels of catalase, glutathione peroxidase, and leading to the reactive oxygen species imbalance. The prolonged oxidative stress leads to increased levels of reactive oxygen species, which leads to decreased insulin secretion and cell death. The high vascularity is required for the distribution of proteins in the bloodstream. It also provides easy access to the inflammatory cells and the cytokines. So when the beta cells, they come under stress, there is a release of these cytokines, insulitis, islet damage, and beta cell death. So why some beta cells are more prone for their demise or destruction as compared to others? Because there exists something called as beta cell heterogeneity. Using the novel surface markers, we have found that human beta cells are divided into beta 1 to beta 4, depending on the glucose responsiveness. So beta 1 are the most glucose responsive and beta 4 is the least responsive. The beta cells also have the hub cells, which are supposedly the pacemaker. And then they are the followers which respond after the hub cells, and the virgin beta cells are in the islet periphery, and they are functionally immature. This study is called as neogenic niche, and the new beta cells, it says that the new beta cells are originating from the alpha cells, and all these cells, they are the trans-differentiation intermediates between the alpha and the beta cells. Another study has shown that, that beta cells are spatially organized and depending on the physical distance from the first responder cells. There exists not just a functional heterogeneity, also there is a transcriptional diversity. The single cell transcriptomics and the FISH technology has allowed the exploration of beta cell heterogeneity, including the maturity, aging, and endoplasmic reticulum stress response. The first gene identified was the DLK1, and the other genes involved are the in the endoplasmic reticulum and oxidative stress. They are the strongest distinguishers of this beta cell subpopulation. The beta cells themselves contribute to the inflammation. So the beta cells, they produce the inflammatory cytokines CCL2, CCL5, and CXCL10, which when exposed to the inflammatory conditions or environmental triggers, the beta cells, they start producing these inflammatory cytokines. It leads to the recruitment of the immune cells, leading to insulitis, and these immune cells can damage the beta cells by synthesizing the reactive oxygen species, the inflammatory cytokines. The single nucleotide polymorphisms, these are the genes which are associated with the pathogenesis of type 1 diabetes. The fine mapping of the loci using immunochip method has shown different SNPs or the SNPs. The HLA loci is the one which is strongly associated with the disease and the T cell autoreactivity. The SNPs in the insulin gene remain one of the highest risk, and 60% of the patients of type 1 diabetes have SNPs in the insulin gene. Other SNPs which have been identified are DLK1 and C-type lectin domain family 16. The various T cell mechanisms along with the beta cell mechanisms are also involved, and we have enough clinical, genetic, histopathological, immune-mediated in vitro and ex vivo evidence that T cell play an important role in the pathogenesis of type 1 diabetes. This picture looks a little bit complicated, but let's start from here. How the various immune system, how our immune system, it attacks a beta cell and leads to the depletion of the beta cells. So in type 1 diabetic susceptible individual, in the pancreatic lymph node, when there is an environmental trigger in the form of any viral infection, there is a breakdown in the peripheral tolerance. So the CD4 and the CD8 T cells, they become activated and they start releasing the inflammatory cytokines. The beta cell specific T cells and B cells migrate to the islets and initiate the beta cell damage and death. The dendritic cells, they migrate to the lymph nodes and present the beta cell autoantigens, that is GAD65 and insulin, to the naive CD4 and CD8 cells, and it leads to further release of the inflammatory cytokines. So this process keeps repeating, and gradually the beta cells, they keep on getting depleted. Eventually, the beta cell mass reduces. Very little beta cell mass remains, and because in this pro-inflammatory environment, resulting in elevated blood sugar levels and clinically over type 1 diabetes. So after understanding the basics of the pathogenesis of type 1 diabetes, let us now try to explore the various immunotherapies we have so far. In 1922, almost 100 years ago, first time insulin was introduced, and since 1 century, the insulin remains the mainstay of the treatment in type 1 diabetes. However, in 1982, cyclosporine for the first time showed efficacy in reversing new onset type 1 diabetes. Since then, many immunotherapies have been tried and tested in type 1 diabetes. And this field continues to evolve as our understanding about the pathogenesis of type 1 diabetes is improving. There are therapies which are directed towards the beta cells and towards the immune system. And there are therapies in both the, which have been tried in both the human beings and also in the animal models. However, only a few therapies have made their way from bench side to the bedside. So the beta cell directed therapies includes the modulation of the endoplasmic reticulum induced beta cell death. There are two main drugs, torsodeoxycholic acid and imatinib mesylate. The torsodeoxycholic acid is a naturally occurring bile acid which can reduce the ER stress. In the mice model, it has improved the glucose tolerance, increased the beta cell mass, and improved the glycemia. Imatinib mesylate is a tyrosine kinase inhibitor, and in mice model, it has reversed the autoimmune diabetes. In clinical trial, imatinib has preserved the beta cell function at 12 months in adults with recent onset type 1 diabetes, and further studies are ongoing for the safety in children. And targeting the oxidative stress is targeting the thioredoxin interacting protein, which is an inhibitor of the detoxification pathway. Insulin and metformin were found to increase the degradation of TXNIP. Similarly, verapamil, a calcium channel blocker, has decreased the TXNIP and enhanced the beta cell survival in both the humans and the rodent islets. In the clinical trial, verapamil along with insulin promoted the beta cell function and lowered the exogenous insulin requirement. Stem cell therapy is another way to enhance the beta cell mass. Human stem cells for clinical use offer a long-term solution for type 1 diabetes without the challenge of organ shortage and HLA mismatch. Clinical trials by ViaCyte and CRISPR Therapeutics are in progress, and there's a special talk. Next talk is on stem cells. Then the immune-directed therapies consist of mostly the monoclonal antibodies. The monoclonal antibodies are of two types, depleting and non-depleting type. The depleting monoclonal antibodies, they bind and promote the apoptosis of the immune effector cells. However, the non-depleting monoclonal antibodies, they neutralize, they bind, they neutralize, and they modulate the various properties of the immune effector cells without the destruction of the immune cells. So these are the various targets on the T cells, B cells, and the T regulatory cells, where different monoclonal antibodies have been tested in type 1 diabetes. And let us discuss one by one. So anti-CD3 therapy, this is the most successful clinical immunotherapy for type 1 diabetes so far. First used in 1994 in the non-obese diabetic mice, it reversed the new onset diabetes, established long-term remission, and beta cell specific tolerance. However, when it was translated to the clinical trials in human beings, in phase 1 and 2 in the phase 1 and the 2, 14 days of teplizumab, when it was given to newly diagnosed type 1 diabetic, it failed to show the reversal of diabetes. However, In the teplizumab treated group, over a period of 2 years, the C-peptide responses and insulin production was sustained, which correlated with the decreased HbA1c and insulin dependency. In phase 3 trials, teplizumab did not meet even the primary endpoint goal. In the post-hoc analysis, it showed a reduced loss of C-peptide in subset of patients receiving teplizumab. In 2019, a new randomized double-blind placebo-controlled teplizumab trial, it addressed the safety and tolerability of the treatment in recent onset type 1 diabetes. In a recent phase 2 trial in high-risk non-diabetic relatives of type 1 diabetes patients, investigated the efficacy of teplizumab to prevent diabetes onset. Subjects who receiving a 14-day course of teplizumab exhibited an average delay of 24 months in the onset of diabetes. Another anti-CD3 drug, autofluorescence, it preserves the beta cell function and reduces the insulin use of 4 years in phase 2 placebo-controlled trial. However, it was terminated in phase 3 because it failed to improve the C-peptide levels with the reduced dosage. And it also caused reactivation of Epstein-Barr virus in some of the subjects. The anti-CD20 therapy is mainly rituximab, a mouse human chimeric IgG monoclonal antibody. After 1 year of treatment, there was an improvement in the levels of HbA1c and C-peptide, as well as the requirement for insulin, indicating that there was a beta cell function was preserved. However, there was no long-term benefit after 2 years, and further studies are needed for the timing and dosage of rituximab. The anti-CD2 therapy, a 12 and 24 months clinical trial with recent onset type 1 diabetes demonstrated a reduced frequency of activated T cells. Additionally, C-peptide levels were improved after a mixed meal test in elifasept group. And this correlated with the reduced exogenous insulin requirements and suggested that elifasept prolongs the beta cell function. The non-depleting monoclonal antibodies, it neutralizes the soluble immune effector molecules. The pro-inflammatory cytokines, interleukin-1 beta, interferon gamma, and TNF-alpha are cytotoxic to the beta cells. Therapies against the interleukin-1, that is canakinumab and anakinra, were found to be ineffective. However, the anti-TNF-alpha drug, etanercept, has demonstrated efficacy based on reduced HbA1c levels in recently diagnosed children. An ongoing phase 2 trial is testing etanercept in combination with vitamin D plus GAD65 prepared in alum adjuvant. The goal here is to suppress the islet inflammation. Simponi, which is a neutralizing antibody that binds the TNF-alpha, is also investigated to maintain the beta cell mass. In the non-obese diabetic mouse, the various monoclonal antibodies against the targets like interferon alpha, interleukin 12, interleukin 21, interleukin 17, and interleukin 25 have so far shown promising results. Modulating the immune effector cell activity, abatacept, an anti-CTLA4 immunoglobulin fusion protein, it slows the beta cell functional decline and improves HbA1c levels in new onset type 1 diabetes, although insulin independence was not achieved with abatacept. And in the non-obese diabetic mice, targeting the T cell receptors CD4 and CD8 prevents and reverses diabetes. The monoclonal antibody cytokine complexes mostly consist of the interleukin-2 therapy, and so far in the mouse model, it is shown to be effective. The bispecific monoclonal antibodies contains 2 distinct antigen binding sites, and the classical example is the beta cell specific GLUT2 and the T cell inhibitory receptor CTLA4, which has been tested in the non-obese diabetic mice. And it has reduced the T cell proliferation, cytokine production, and decreased the diabetes incidence. Combination therapies are there in which the 2 drugs from the 2 different categories are combined. However, most of the data is from the preclinical and from the mouse models. There is very little data on the human trials from combination therapies. So to conclude, the ultimate goal of an immunotherapy for type 1 diabetes is to suppress the ongoing beta cell autoimmunity without affecting the protective immunity and preserve the beta cell function. Clinical therapies targeting the T and the B cells via the anti-CD3 and anti-CD20, that is teplizumab and rituximab, have demonstrated safety and efficacy in maintaining the beta cell mass in newly diagnosed patients. The efficacy of monoclonal antibodies in type 1 diabetes depends on the timing of the intervention in relation to the disease progression. Thank you for the kind attention. And just a glimpse of like, this is the technology on which I am working currently at Mayo Clinic. And this is our technology in which we are designing the SCFE antibodies. This is like novel technology, and we are targeting the like novel targets with our technology. And our antibodies are much smaller than the monoclonal antibodies. The technique by which we are designing and making our antibodies is different from the monoclonal antibodies. And most of the targets are like novel targets on which we are working. So, I mean, this is totally on the animals right now. There is no translation so far on the human trials or any human beings. This is totally on the mouse, which we are working right now. So thank you so much.
Thank you, Dr. Nidhi Madam, for excellent overview of immunotherapy and what are the various agents which are available currently for prevention of type 2 diabetes, and your innovative area of research of very small antibody molecules which you are designing, and probably in near future we will be hearing more about those molecules. So I will request my co-chair Dr. Raka to introduce the second speaker and the second topic.
Yeah, sure. Thankful to Dr. Bansi sir for accommodating me in this technology conference, and thank you for sensitizing all of us to this new techno world. And here comes a new techno man, Dr. Rajaram J. Karne from our own India, and he's affiliated with VA Central OYO Medical Center. He's a technology man behind CMS Stage 1 EHR reporting in 2013. He has many publications to his credit. He is certified from medical school and residency from clinical center at the National Institutes of Health, fellowships from National Institute of Health Clinical Center. He's an American Board of Internal Medicine graduate, certified in endocrinology, diabetes, and metabolism. He has been licensed to practice in OYO and in US, active throughout 2022, and he'll be sensitizing us, giving the wisdom regarding stem cells therapy in diabetes and how we can approach. Earlier, there were an era of infection, then there comes the era of antibody. Now we are treating autoimmunity and all things with all possible and plausible modalities. Let's congratulate Dr. Rajaram for his own good deliberation on this stem cells.
Hello, good morning and good evening there. Can you hear me?
Yeah, sure, sir.
Awesome. So let me get the share screen and I'll get the PowerPoint. Do you see the slides?
Yeah.
Yes.
Okay, awesome. So thank you for the kind introduction, Dr. Jetwani. And my own best introduction is I am from KM Hospital, Mumbai. I did my DM there. And that's why I know most of you people. And I'm still, once you are from Mumbai, you are always from Mumbai. Okay. So today we are going to talk about stem cell and gene therapy. Now, both of these topics have too many cellular and biochemical words that we clinicians really don't understand. It's a different language, but how we use it clinically, what does it make sense to a clinician? I have tried to get overview, and because both the topics are so huge, getting into 20 minutes is a challenge, and we'll see how it goes, okay? So currently the type 1 diabetes, and that's what mostly we're going to talk about, is treated mainly by the exogenous insulin. That's the state of the art today. We are doing a lot better, almost close to the real natural physiological secretion. But we are working on the other modalities, which is pancreas and islet cell transplantation, which is taking up huge leaps in the development. And Dr. Garg gave an excellent talk on the immunotherapy. That's another development happening. So now, what we are looking at is a stem cell therapy, and there are different ways in which you can do the in vitro development of either islet cell themselves or the other cells that produce insulin, which is IPCs, insulin producing cells. Then there is another arm of gene therapy where we can do the gene editing and the genetic vaccines, etc. Just to say that gene therapy, immunotherapy, and stem cell, they are not mutually exclusive. There is a lot of overlap, as Dr. Garg was mentioning, and we will see it again. So some terminologies in the stem cells is IPC means insulin producing cells. They could be islets, they could be islet organoids, or they could be non-islet cells producing insulin. They come from human stem cells, which are pluripotent and can develop into any of the adult cells. One of the sources is embryonic stem cells, which are coming from the inner cell mass of the blastocytes, and they have infinite proliferative or renewal capacity. Second one is a human-induced pluripotent cell, which means they are somatic cells, but they are reprogrammed to become stem cells and then differentiate into islet cells. They have a similar capacity to proliferate, but advantage is the embryonic cell run into ethical issues of using human embryos, while in the somatic cell transformation, we don't get the ethical issues. Then there are the stem cells derived from the grown-up adults. And one very interesting transdifferentiation where the cell is already differentiated, and instead of going back to islet cell, it directly differentiates into a different kind of cell. So there are a lot of modalities going on. Now, the steps involved from in the embryonic life, from earliest embryonic stem cells to becoming the beta cell, there are a lot of these names that I have written at the bottom are the transcription factors, and they start getting more and more complicated and delicate as we go forward to the endodermal cells, which in embryologically develops into a primitive gut, which then foregut becomes a bird that develops into pancreatic endoderm, and that develops into the both endocrine and exocrine precursors. And we are interested in endocrine precursor, which is eventually immature beta cell and mature beta cell. So as you see, the factors that are involved in each of these stage start becoming very specific, delicate, and complicated. So what are the methods that they use for stem cell is either you generate insulin from directly embryonic stem cells. So we actually use embryonic cells, transplant them, and see whether they can develop insulin. Or you can develop some steps from embryonic cells to progenitor cells, like steps in between in vitro, and then transfer it. And then there is a very interesting chimeras. Now, this is strictly animal models, but what they did is, in a rat, they blocked the development of pancreas by PDX1, we'll talk about that. And then they introduced some mouse embryonic cells, which developed mouse pancreas inside a rat, reaching the rat size. So that's very like sci-fi type thing, developing the chimeras. And then the pancreatic duct itself has the stem cells, which has more potential to become islet cells under experimental conditions. And then there is a different way. Instead of going from the embryonic cells, we go from the adult stem cells to differentiate. Either the stem cell come from liver, mesenchyme, or bone marrow. Now, out of them, the most promising and most investigated field comes from the mesenchymal cells. Again, these are the mesodermal cells, and we are trying to get the product of the endoderm. So that's where the power of the stem cell comes, that they can differentiate. So little focus on these mesenchymal derived cells, that not only they become islets or try to become islet, they also have a side benefit of promoting regeneration of the existing beta cells. So all you know that at the type 1 development, we still have a 20% beta cells. So mesenchymal derived stem cells actually have a benefit on the regeneration of the existing beta cells. It also protects the cells from the apoptosis, and they are, if they are coming from the bone marrow, they have a potential for immunomodulation, which means they decrease the attack from the immune side of it. they actually help for the tissue repair. So this is something that has a lot more promise. And as I said, it converts into insulin producing cells under differentiating protocols. Another source, you can get the mesenchymal cells from umbilical cord, and they are better because they have more embryonic markers and endodermal lineages, and they have a very similar to the stem cells, but they are easy to get and have more potential. They also have a less immunogenicity. Now, just very interesting that all this we talked about type 1. And if you look at the top two, like differentiation into insulin producing cells and the promoting the regeneration of islets, they are wonderful for type 1. On the lower left, they actually have a benefit for both type 1 and type 2 because they have an antioxidant capacity. And we know that the inflammation is one of the cause of insulin resistance. But most interestingly, on the right side, they directly decrease the insulin resistance by activating post-receptor pathway through IRS signaling. So these mesenchymal cells can potentially be used for both type 1 and type 2 diabetes. Brief touch on the clinical trial. There is only one I have picked up that was done between 9 and 10 with 42 patients, half randomized to placebo or standard care. And they followed for 1 year at 3 months interval to check the C-peptide area under the curve at the end of 1 year. Now, this is a complicated style, but just to make it simple, the top curve is a C-peptide area under the curve, which got better. So there was more C-peptide. This one is a hemoglobin A1C, which got better. Fasting glucose got better. And the insulin levels, which was measured, they got better. So this was one of the positive trials. But there are a bunch of them. And if we try to do the meta-analysis or review of the trial, there was one published recently with 15 trials, 6 from type 1 and 9 from type 2. And they looked at the same 3 endpoints, C-peptide, A1C, and exogenous insulin. Interestingly, in type 2 patients, it was a favorable benefit with all 3 endpoints. But the problem was within the trial, different trials, there was a huge heterogeneity, which means the splay was too much. Interestingly, in type 1, there was no significant difference except for a little bit on A1C. So as we stand today, the stem cell therapy for type diabetes is not so effective in type 1, maybe in type 2, but this can change rapidly, as we know. The limitations are generation of functional beta cells in vitro, improvement the differentiation, how to protect them from the immune cell destruction, how to generate a sufficient cell to achieve the insulin independence. So this is one of the sticky areas where you require a tremendous amount of funding to manage these delicate cells and to try. There was one gentleman I met from the California lab we are working on. They said he was burning 2 million a month and still have not reached to the stage 2 or 3 of the differentiation. So this is where we are. A lot of research, a lot of funding is needed for this. So in summary, stem cell is a promising potential therapeutic model. There have been significant advances and improved chances of cure because all we need is just 1 or 2 breakthroughs that could change the whole picture, and not yet promising in clinical trial. It was a very rapid review, but we are switching here to the gene therapy. And again, I'm giving a broad overview and not going into the nitty-gritties because of the time. So introduction is the aim of gene therapy is to correct the defective gene or add the useful gene. And the techniques involved are either you overexpress the gene or overexpress the protein production of the gene, or you transplant the cells that have the desired genes. And this is where the stem cell and gene overlap and immunology overlap, because we can use the gene therapy to modulate immune response and improve the diabetes. So the first mod is a gene overexpression. There are different genes are the candidate. They have been studied in animal models and cellular lines to improve the diabetes features. One of them is IGF-1, which has a ability to improve the beta cell survival and actually mitogen to reproduce more. It also has some effect on immune function. The other genes are REC3G genes and hepatocyte growth factors. They both improve the survival, while glucose 6-phosphatase gene improves the glucose utilization. And then there is a big interest in the anti-aging gene, clotho gene, which, if it is absent, is shown to cause more beta cell apoptosis. So if you can overexpress the genes, they show promising effect on type 1 diabetes. Protein overexpression, on the other hand, where we are actually inducing the gene, but they are producing more amount of proteins, neurogenin 3, then alpha-1 antitrypsin, glucokinase, leptin, and PDX. These are the candidates are being studied. The most interesting is the PDX. It is a transcriptional activator of several genes, and without which we cannot develop the pancreas. It's absolutely essential for pancreatic development and sustenance of the gene. But if we give that gene through the adenovirus, it actually led to severe hepatitis in the mouse models. So we have to be careful on using this gene therapy, especially on the safety issue. There is one very striking mechanism where we combine the gene therapy with genetic engineering, which is very interesting. What they do is they take the mouse GIP gene and link it to the human insulin gene and then implant it. There, these mice, the K cell from their gut, they start producing human insulin. So it's not just a gene therapy, but we are combining the genetic engineering into that. Another one is human adipose tissue engineered with PDX gene. Now that's the gene required for the differentiation. And we see that those adipose tissue cells now are secreting insulin. Switching, the next mechanism is Dr. Garg mentioned as immune interventions are very promising in development of or the treatment of diabetes. So we can use the gene therapy to modulate the immune responses. One of the ways we do that is we actually modify the precursor cell. So before a T cell become toxic, what we do is we transfer the gene into that precursor cell to modulate it so that the antigen is recognized as a cell and autoimmunity is not developed. It basically prevents the CD8 T cells from attack on islet express antigens. The other way to do that is targeting the gene therapy to a T receptor on the islet cells. So basically the T receptor will not attack the islet cell. And one more mechanism is we modify the cytokines. So basically the T cell producing cytokines are either, if they are bad, they are suppressed, or if they are good, like IL-10 and 15, they are more produced. So in this way, the gene therapy can modify the immune function that would help the diabetes. There are other approaches. One is a transplantation of the cell expressing genes against type 1 diabetes. Now here, we are the bone marrow cells, dendritic cells, and they have an autoimmune regulator gene, which will decrease the, I would say, again, toxic T cells. So it leads to the deletion of autoreactive T cells and decrease the autoimmunity. And it also prevents the epitope spreading, which epitope spreading means if you have autoimmunity against a particular cell or protein, over the time, the other unrelated cells or the proteins, they start becoming reactive to the same autoimmunity. That process accelerates multiple autoimmune disorders, and we can prevent that by this transplantation, theoretically. Then there is a genetic vaccination, which is the same principle that we used in COVID mRNA vaccine. But here we are using the plasmid DNAs, which can produce a specific neutralizing antibody that would prevent the toxic immune response. So the most common method used to add the genes or use the gene therapy are the viral vectors, and they are made non-pathogenic by muting their replication, but at the same time, the ability to transfer gene is kept intact. Again, it all sounds like a sci-fi novel, but it is actually being in works. And the way that the virus goes inside the cell by endocytosis, and the adenovirus is the most commonly used, most widely used. It is safe, effective. although almost all the gene therapy in practice are done by the adeno. And then there are other viruses like retro, herpes simplex, Epstein-Barr, and lentivirus. Their animal models have worked pretty well. We still have the concern on the toxicity, inflammation, and immunogenicity in the humans. So that's where a lot of development is focused. The non-viral vectors are either physical, by giving the gene gun, you mechanically inject the genes, or we can use the plasmid. As I said, they are the small extrasomal DNA molecules independent of chromosomes, and they can replicate, so we can use them. You can use the chemical polymers, you can use the electroporation. These are all methods are non-viral and they are safe, obviously non-immunogenic. They're not as effective as the viral methods. So in summary, there are multiple approaches are being used to manipulate the genes to treat the diabetes. By overexpression of genes and proteins, genetic engineering, transplantation of stem cells, vaccinations, immunology, and vectors can be viral or non-viral. The limitations are they may trigger unnecessary immune response. Almost all studies are in the animal model, and safety is not established in humans. So the question was, is it a mirage or oasis? As we stand today, I could say that it is still a mirage. We see something there, we are going there, but who knows? In next 10 years, we will be sitting back again. And as I said, one or two breakthroughs can completely change the picture. And we could call it as we are in oasis. Thank you.
Thanks, Dr. Rajaram, for nice deliberation on such a complex topic. In a limited time, it's very difficult to decipher all these things. We are stunned to have such miraculous thing around the world, and we are thankful that we are doing still. Although it is miragosis rather than mirage and oasis, it's miragosis, waiting for some miracle. I'll introduce Dr. Jetwani to go further to introduce our next speaker.
Thank you, Dr. Raka. I think we are moving to the third topic of the cellular therapies, that whether we can use this stem cells or exosomes as biomarkers in the field of diabetes. And we have none other than Dr. Sabyasachi Sen, who is professor of medicine from George Washington University. After completing his graduation and post-graduation from the city of Kolkata, he has done too many academic accolades to his credit. He has done MRCP from UK, Ireland, from London, diploma in geriatric medicine, diploma in sports medicine. And apart from medicine and medical education, he is also skilled in clinical research, life sciences, and clinical trials. So over to you, sir.
Thank you so much. Hope you guys can hear me and see me. Let me try to share my screen. And it would be this one. Okay. I hope you can see me.
Yes, sir.
Awesome. Can you see my slides in full
Yes,
screen? Sir. Awesome. So thank you for inviting me, and thanks for Bansi and Dr. Jetwani, Dr. Shahor, and Dr. Parikh for inviting me. I personally have met many of you and talked to many of you over the years, and hopefully this collaboration will continue. And so Dr. Carney was also in NIH with me a couple of years before me. So he actually did a fantastic job of setting up the stage for me to talk about stem cells, not only for therapy, but for use as a biomarker for our patients that we treat every day. And hopefully this will become a reality to know who responds to what in individualized medicine. As you know, everybody throughout the world is trying to figure out how we can individualize therapy and medicine.
Dr. Sen, if you can change the view, I think we are seeing two slides, the current slide as well as the next slide right now. Is there any alternative view here? Yeah, just try that, please.
No, no.
Okay, it's better. It's better, but then I think this is better. Dr. Pratap, is it okay?
Let me try to close this slide. I hope this wouldn't close everything, but let me try.
I think you shared the whole screen, so maybe if you share the PPT alone, then we can see. Okay.
You can change the way of your slideshow.
Oh,
okay. No, still.
Yeah.
So click on
Now
the
it is
display
okay.
setting.
No,
Yes, sir.
now it is okay. Now it is okay, sir.
Okay. So hopefully I wouldn't make this too complicated. So hopefully any screen would do. So essentially, I'm going to talk about adult stem cells, which means you can obtain these cells from any adult patient, right? It's not embryonic, it's not even neonatal. So it's adult stem cells, and I'm going to talk about two of them. Essentially, one is derived from peripheral blood, which is essentially you get the mononuclear cells, which is essentially white blood cells after you spin down the blood. And from that, you put it through a magnetic bead column to get CD34 positive cells. So CD is essentially a cell surface marker, and these have been shown to have progenitor capabilities. And the other one that I'm going to talk about, and then Dr. Carney already mentioned, is mesenchymal stromal cells. These looks like spindle-shaped cells like this one. So the progenitor cells, which are CD34 positive, are also, if you sort it again, can be VEGF receptor positive, which is a vascular endothelial growth factor positivity. So if these are both positive, then it's clearly going towards a vascular lineage. So it comes out from the bone marrow with certain, in response to certain chemotactic factors, and it sits down in a blood vessel to form the endothelium. So as you can imagine, the critical components that a stem cell needs to have is it needs to be able to move in response to a chemotactic factor in order to assimilate in an endothelial lining. And unfortunately, that's impaired in diabetes. It doesn't move fast enough. Its numbers are low because the high glucose kills these cells and so on and so forth. So, and it has been shown by multiple investigators over a period of time that these cells truly mature with different changes in the cell surface and phenotype, and they do assimilate in the cell surface for endothelial lining once the mother endothelium is damaged. So as you can imagine, these are very critical cells. This was first discovered by our group, by Jeff Isner, way back in the Science paper in 1997. And subsequently, our group has done numerous studies on these cells. These are, as you can see, eNOS positive or nitric oxide synthase positive, CD31 positive later on, such as HUVEC, and these cells become positive at day 14 and so on. So these are truly CD34 to begin with at day 7, which subsequently become day CD31, which is a mature endothelial cell surface marker. And you need these cells to essentially assimilate. Now, these cells have a lot of properties, such as it produces a lot of growth factors and so on. But in clinical medicine, you need to see whether these cells, after you give a therapy, whether the endothelium is getting any better or its progenitors are getting any better, right? That's the whole reason why we are treating our patients. So, which means its migration needs to improve, it needs to be able to home in to form the or repair the endothelium, right? And so the other component here is that the formation of colony count, and this has been shown in clinical trials multiple times, that these seems to be a robust cardiovascular risk indicator. These are usually 14 to 16 in a normal patient who doesn't have diabetes, and these are almost always reduced in diabetes and prediabetes, indicating that they cannot form a colony, which is the first step towards forming a vasculature. So with that in mind, I'll go to our first trial that we devised way back when I was a faculty at Tufts, just after my fellowship at NIH. And this was done in conjunction with University of Massachusetts in Amherst. From exercise physiologists there, we designed a crossover exercise intervention trial. This was, I believe, funded by American Heart. So, and we had a 6 weeks non-exercise, 6 weeks exercise moving to non-exercise, or it's starting with non-exercise moving to exercise. So period A is about 6 weeks. We have a washout period of 4 weeks, and then again exercise or no exercise, depending on the group they cross over to, right? And the exercise simply was what is currently mandated by ADA, is a combination of aerobic exercise and some resistance. This was actually purely aerobic exercise for 150 minutes per week. These were all pre-diabetes patients, and all of them were office goers and had regular job. None was so-called sedentary, had sedentary lifestyle, right? So very normal patient population that we usually get. So in these patients, pre and post exercise, the white bar is at a non-exercise phase, and the black bar is an exercise phase. As you can see, the number of progenitor cells are definitely higher in patients who exercised even for 6 weeks. And so that was quite interesting, that even with small possibility of exercise, their CT count, the progenitor cells went up, and the colony count, which was as low, this was actually quite interesting, that it went down to as low as 4 and 5, as opposed to normal patients. So even pre-diabetes, the colony count is so low, and that it responds fairly fast to almost 8 and 9 post-exercise. So dramatic cell-based changes. I'm not going to go through all the gene changes. Some classic ones, such as interleukin-6, went down with exercise, apoptosis gene went down, enos went up, and so on. So the reason I'm showing this is for twofold. I'm showing not only that it responds to exercise, but the fact that you can actually use these cells to discern who responded and who didn't. Now, clearly, of that entire exercise population, not everybody would have responded to the same degree. But here you have a modality where you can check whether a particular patient is responding or not. Now, clearly, these tests are not for everybody, but if somebody wants to know and has and can support these extra tests, I think it's worth doing. But when you actually, the other interesting part was when we looked at the accelerometer data from all these patients, as you can see, none of these patients at home did any vigorous exercise. None of these patients, either in any arm, did any even moderate exercise. What they did was probably change their lifestyle, which means they were less sedentary, which means they were more fidgeting. They tried to do more. And that alone was enough in a pre-diabetes state for cell-based changes. Now, we looked at a lot of biochemistry, it didn't change a huge lot. And when we do clinical medicine, it doesn't, IL-6 hardly changes, right? But here you have a modality which clearly showed some differences. This was obviously published. Let me move on to another study that we did. This was a fat-based MSC. So again, this was a pre-diabetic population, A1C between 5.9 to 6.4, BMI, which was mostly overweight, age more than 40. We had a pre-exercise and post-exercise fat biopsies. It was used by a biopsy gun without any incision, so that there was not much scar and so on and so forth. So once you culture these cells over a 14-day period, you actually do get a spindle-shaped cell population. Then you sort these patients based on some surface markers, continue to go for another 14 days, and you get a very homogeneous, nicely growing population, individualized cell-based assay, right? Now, mesenchymal stromal cells can differentiate into fat, there's adipocyte, bone, or cartilage, right? So the question is, how and why does it change from one or the other? Now, clearly, we don't want it to produce a lot of adipocytes. We do want it to continue to make bones and cartilage and muscle, right? So when we did the gene analysis again from these cells pre and post exercise, clearly there was more VEGF, more KDR and eNOS with exercise. A lot of antioxidants went up, which is fine, which is what we showed in the previous test. This is actually easier cell to get than the blood. I mean, it's not, these are more abundant, I should say. Blood may be more easier. But the other interesting fact that we also got their cell endothelial progenitor cells from the blood, right? So this was the normal cell culture. This was essentially on exposure to adipogenic media. As you can see, these red blobs are essentially fat forming vacuoles inside the cell, right? And this is essentially when you add the conditioned media or the secretome from the progenitor cells, from the CD34 blood-derived progenitor cells, you're adding them on the fat-based cell culture in presence of adipogenic media, right? As you can see, these blobs have disappeared, okay? So clearly, these post-exercise cells are producing a secretome which actually can prevent adipogenesis. This is almost the first time we showed that there is a direct inhibition of adipogenesis with cell-based secretome post-exercise in prediabetes. If you look at that in adipogenic and post-adipogenic with ECM, endogenic conditioned media, most of the fat genes like FABP4, PGC1 alpha, CBP alpha, PPAR gamma, these are significantly reduced in gene expression. Again, KDR was higher and so on and so forth. So this is actually an interesting study. And remember, this is not a long-term study. This is fast and quick. You can go in and test these in a fairly relatively short period of time. Again, this is published. Let me show you one more study. This was using SGLT2, which is canagliflozin, low dose. There's a lot of good stuff about SGLT2. So we did a 16-week intervention with canagliflozin of 15 patients with the medication and with placebo. This was a blinded placebo-matched study. This was funded by American Diabetes Association and in conjunction with our placebo, which was made from Janssen. And I'm showing you the blood pressure. As you can see, there was a sharp drop which came close, but this drop alone is quite helpful for patients. Adiponectin actually went steadily up. It actually went down in placebo. IL-6 clearly went down, and this is only in 16 weeks. As you can see, there's a sharp drop. This was close to statistical significance. Migration of the cell-based assays, there was an upward trend. If you continue, it will probably diverge more. CXCR4 is a chemotactic factor receptor, which the stem cells respond to. And that went up quite significantly and showed a statistical significant difference, which matches with this one. We looked at the exosomes in this study. Now we are going into the exosomes as a biomarker. So the exosomes are essentially small packages of secretion from different cells, right? The exosomes could be in blood, could be in urine, could be in CSF, could be in any fluid that we have. So exosomes could be of various sizes. You have to actually know what that clinical trial is specifically looking at. We looked at 50 to 150 nanometers, okay, which is classified as so-called EVs. So these are essentially how one cell would crosstalk with another cell. And the hallmarks would be gene regulation, angiogenesis, wound healing, and so on. So there has been a lot of work on exosomes and how this cargo, differences in this cargo that the exosome has, can show the response or as a therapy and as a biomarker. So when we looked at the exosomes in the canagliflozin study, remember this was a low dose canagliflozin study in type 2 diabetes, not pre-diabetes. And the one that showed very clear trend was a podocalyxin. Now, what are these? These are nephrin, podocalyxin. These are proteins produced from podocytes. And these are, as you know, in diabetic nephropathy or diabetes per se, we look at albuminuria all the time. But that protein is very non-specific. However, we know in diabetes that there is podocyte damage. So these are podocyte-based proteins. The higher they are, the higher the inflammation of the podocyte is. And this has been shown by other labs. And what we showed for the first time that in canagliflozin, there's clearly a drop coming up with podocalyxin and possibly also nephrin in a small study that we conducted. We are actually conducting a large study now with empagliflozin. Let me come to COVID. You cannot have a talk in this day and age without COVID. And I'm not going to bore you with lots of data about what's COVID, et cetera, et cetera. You know that there's cell surface receptors and so on and so forth. What we did essentially was we were interested in long COVID. In other words, what would happen if you had COVID, had resolution of symptoms, but then what happens at 10 weeks, 6 months, and 12 months out, right, using these markers. I'm going to skip that. What we did show was even if these patients were not diabetic, okay, but when we looked at their blood glucose levels were clearly higher than what would be for a diabetes patient at random values. Now you can say, well, random values doesn't mean much, but at the same time, when we got their blood sugars at 10 weeks and 6 months post-COVID, these were not diagnosed to have A1C of more than 6.5. Their random blood sugar levels were higher. Now, clearly, this is probably not fasting, but just a correlative sign. So based on that, we looked at the number of mononuclear cells and the progenitor cells, and clearly, even compared to a type 2 diabetes patient with mononuclear cells, as you can see, even at 10 weeks and 6 months, the cells or infection-fighting cells or progenitor cell pool is significantly lower. So there's something going on that is not even close to a type 2 diabetes patient, which is, of course, stable. When you compare their CFU colonies, it's actually very surprising that these patients who are 10 weeks and 6 months out of COVID had their colony count almost as similar to a type 2 diabetes patient, which is 10 to 11. Remember, a normal one should be somewhere here. So none of them had, even they were not known to be diabetic, had a poor colony count. That alone tells you that they have some cardiovascular risk, which is kind of unidentified. So we looked at their urine exosomes. Why? Because as you know, we were getting signals that these patients probably are developing metabolic dysfunction. And as you know, microalbuminuria, proteinuria is almost the first clinical scenario that happens. And we wanted to look at what happens to their podocyte markers. Again, looking at nephrin, podocalyxin, and here you see that the nephrin when controlled to a standard exosome marker, this is a ratio, 10 weeks, 6 months, 12 months compared to a type 2 diabetes patient. As you can see, there is type 2 diabetes patient actually has way lower podocyte damage. And this damage or the podocyte inflammation is continuing. It's not only just scary that it's there at 10 weeks or 6 months, it's actually continuing up to 12 months post-COVID. Now you can say that why is this so low? Well, maybe in type 2 diabetes, the podocytes are already damaged by that time completely. But the fact that it's way higher than type 2 diabetes levels, statistical significance, and the levels are persistently high at 12 months. We are now doing a VA study, which is looking at 18 months and 2 years, because this is actually scary, if you ask me. And we have medications that we can put in for early signs of kidney damage, which we don't do right now. If you look at another biomarker, podocalcin, same story. When we looked at two different experiments, here we have a total of 23, 24, same trend. There's a combination of the two experiments, a total of 47 patients, same trend. It's actually getting scarier when you pool all the data. So this is unpublished. Please don't, it's not for wide circulation yet. This is essentially data from last week. But I thought that this should be portrayed out there because there is signs of kidney damage, long-term kidney damage in post-COVID or long COVID patients. So, and it's based on exosomes, which probably we would have missed if we just looked at albuminuria in these patients. So strong biomarkers, cell-based biomarkers, exosomes. I don't think I need to go through these take-home messages. I think the message was fairly clear that we need to use more cell-based, more novel techniques where we can have a individualized cell-based assays towards individualized medicine. Not everybody is not the same. And thank you. It's a long journey, as you can imagine. And these are my funding group and funding agency. Thank you so much.
Thank you, sir, for enlightening us with this new era of role of exosomes and various other biomarkers in the field of diabetes. Not only diabetes, but also you have shown us that how can we use that to identify the damage being done by this newer infectious agents also to our human body. So with that, now the session is open for questions. So I will request my co-chair if there are any questions. Dr. Raka, any questions from your side?
Yeah. So it's all noise things. I don't know what to ask, but for the sake of community that we are here to teach and decipher the knowledge to everybody, what is the simplest way to use these kind of technology to a normal layman of India? Because see when you come to your clinics, when you're seeing patient in front of you, then what you're going to offer, because they are just begging towards a miracle for type 1. They are begging for when they come crying for their kids. It's very difficult for us to see a ray of hope to them. So I'll try to say that as a component, a complex component from all of the you three, which we are carrying our Indian genes, and in this expert panel, try to accommodate a single statement, how to go ahead and what to see in future.
Right. Let me take a stab at it. So I think I tried to show you the various samples from blood and fat biopsies. I personally have done, as far as Indian genes are concerned, of course, there's not many Indian patients that we look at on a daily basis, right? So I essentially did and didn't do exercise for 6 weeks and I did my own colony count, and it was dramatically different. It actually shows that how quick the exercise washes out the effect and how quickly you can see the effects back as far as colony count. So simple things like that, if we can portray to our patients that, you know, your cells are responding. It's your cells, nobody else's cells. That's a fairly simple thing to do. And that's, I think, very telling. And that convinced me that I need to do some exercise every day. I don't know, this is very anecdotal, but it's out there.
Anything
Yeah.
related to gut microbiota? Anything related to gut microbiota from your science's point of view, which we can give them a simple linguistic way to enhance their immunity or whatever you can say.
I'll let somebody else take a stab and then I'll say something.
Yeah. Regarding the first question, there's a bigger picture for myself going from an obscure medical college in Miraj, where I carried the Benedict reagent in my pocket to do the urine sugar and all the way to the NIH. All I can say is there is a 25 to 40 years of difference between the cutting edge and delivery to the patients. So the topics that we have chosen are at so much cutting edge that we are not delivering them to the clinics in the United States also. So yes, Indians are getting benefits of continuous glucose monitoring today, which was unheard of in 1980s when I was in the med school. There is and much faster growth and shrinking of the time between the bench to bedside. And there is India is progressing like amazing fast. There is limited to very few people, but still it's available and can be eventually obtained by others. So yes, there is the ray of hope, but unfortunately today I cannot give. Second is, you talked about this gut microbiome. Dr. Sen is also obesity board certified. I have done obesity in world of weight loss. The gut microbiome have been shown to be critical. There are not so much studies on the diabetes as far as I know. Anybody else knows?
So, so as far as the metabolic dysfunction and microbiota in pre-diabetes and diabetes, I think what we have figured out is that so-called firmicutes in your flora is more aligned to weight gain, and whereas Bacteroides, microbiota or bacterial flora, is associated with weight loss or so-called ketosis state. That we already know. What we don't know is who responds to a ketogenic diet and why. And as you know, the first line of therapy that we all are trained to do for pre-diabetes and obesity is lifestyle changes. For how long and what, we never tell the patients. But let's say ketogenic diet. And after the patient has done ketogenic diet, as you know, not everybody responds. At least 1 out of 4 will not respond. So what determines the non-change of flora? We know what changes happens, but clearly there's a subset of population which doesn't change. And that's where the data analysis and so-called predict mod platform and other platforms that has been developed in data management is coming up. So we recently got a grant looking at floral changes in response to ketogenic diet in veterans, and to develop a predict mod so that when a physician sees a flora data, they input it and tell you that you're going to respond and you're not. It's coming in. I'm going to talk more about the data predict mod system in the Diabetes India talk. So I'm going to leave it for that.
And regarding the first question, I just want to tell it in one sentence that probably a combination of the stem cell therapy and the immunotherapy in type 1 diabetes probably is a hope for type 1 diabetic patients. And I think we are quite close by this ViaCyte group and therapeutics. So the stem cells are really a good hope to enhance the beta cell mass, and with the help of gene editing and the silencing of the HLA genes and other immunotherapies, and the problem with immunotherapies, especially in India, what we see is that these monoclonal antibodies, they activate the FC portion of the immunoglobulin, and this FC, they have the immunoglobulin FC portion, and this FC portion is the one which is responsible for activating the whole immune system. So now with the genetic engineering of the FC portion of the immunoglobulin, like in our lab, what we are doing is we are using only the specific VH and the VL, the very specific antibody part, which is responsible for blocking the receptors. So it specifically it blocks the target, and the if the target is 10 to 15 amino acids, so this antibody is going to bind to that specific target. So if we can combine these two things, stem cells and the immunotherapies, which are engineered in such a way that they do not have the FC portion, or the FC portion is not functioning. So that can probably help in preserving the beta cell mass in both the prevention of diabetes as well as in the cure of the patients who have already developed type 1 diabetes and they are receiving the stem cells islet cell transplant. So that is what I feel.
So one question to all of you. So your views about why type 1 diabetes is increased globally. What are the reasons you feel?
I think it is related to the various environmental triggers. So these environmental triggers in the form of like the neonatal nutrition and various toxins. So probably this is causing a lot of genetic mutations in the form of this single nucleotide polymorphisms. And we are yet to understand more this SNPs or the single nucleotide polymorphism genes. And probably that is one of the reasons that there are changes which is happening at the level of the genetic level. So that is like globally the type 1 diabetes is increasing.
We need to go to.
If I can add a comment, we all must compliment all the speakers because you know it was such a tough task to get speakers for this particular session. We tried contacted so many people. Even if you go to the brochure of the different technology society meetings, there these topics are not covered. I would have mailed at least 50 people who have published papers on gene therapy, stem cell therapy, but even they didn't reply. And most of people are ready to talk on insulin pump, CGM, and those things. But for talking on gene therapy, stem cell therapy, exosomes, we definitely need, the speakers deserve a big round of applause. So thank you very much for covering this session, important sessions.
Thank you for having us.
Thank you so much. Yeah, thank you so much.
Also, thank you everyone.
We learn a lot. We learn a lot about the basics of these things, I think, which is missing in routine events and CMEs, that we keep on learning same thing again and again. But there's something new we have learned about this upcoming technology in the field of diabetes. Not only immunotherapy, stem cells, but also their role in the diagnosis and understanding the impact of interventions also. So thank you very much, all of you.
There is a ray of hope.
For sparing your valuable time.
Thank you.
I would like to just make a comment here. And we are very thankful to Dr. Sain, Dr. Nidhi Garg, Dr. Rajaram Karne, because you have joined us from the US, and I think it is very early morning there. And so you took all the pain and for this particular session, as Rakesh has already pointed out. And next year, we are going to have another edition of D-TechCon. And this is going to be one of the face-to-face meeting also. And we would request your continuous support to the D-TechCon and in the coming years as well. Thank you very much.
And thanks
thank you so much. Thank you.
The mind of D-TechCon, Dr. Rakesh Parikh and Dr. Amit sir. You people have done a great thing, collaborating all these big speakers, and we have new keynote lectures already on Hall 1. I'll request our audience to go there also to see, and I request all of my.
One thought was coming to my mind today when we were having inaugural function. Dr. Shashank Joshi, as you all know him, he coined a new term called digitonians. So all the members are very excited, all the faculty members, organizing committee members, and you will see a lot of posts talking about digitonians. So he told us that anybody who is working in the field of technology is a digitonian, just like a Rotarian right itself, a Rotarian or a law. So we are all digitonians. Thank you for being a digitonian.
Until unless orthopedicians get some differences on that opinion of word digitonian.
Yeah, Shashank and I were together in KM in 93, 95, and I'm hoping to see him tomorrow, I believe. He's coming in.
Yes, he is talking tomorrow. You are most welcome, sir. If you have some time, please join us again tomorrow, and we will be more than happy to have your comments on the session and your active participation. Thank you, sir.
Thank you, sir.
Thank you so much. Thank you.
Hall A, where the keynote lectures are still happening. And
how do I go to other hall?
Sir,
I'll send you the link, sir. I'll send you the link over WhatsApp.
Okay.
You can share the link. You can put the link in the chat box itself.